So, good morning all. May I request now Professor S.P. Dhaneria sir, Professor Chayna Sarkar madam, to please kindly chair the session. Yes, I know. Acha, theek hai. So may I request madam to chair the session. Madam, mic diye do, madam. So it is our real honor to have madam with us, Professor Chayna Sarkar. Madam is currently head at Department of Pharmacology at Negrims, Shillong. Madam had done her TM in clinical pharmacology from PGI Chandigarh. So welcome, madam. Now please moderate this session.
Good morning, everybody. So today's session is the smart use of antibiotics. We'll start now. So you know already the extravagant use of antibiotics has resulted in rise in multi-drug resistant bacteria. Therefore, it is essential to use antibiotics in an optimal manner to prevent the antimicrobial resistance. And already you know that WHO have started 2019 classification of antibiotics on the basis of that AWAR classification, mainly based on how much consumption of antibiotics in various categories, like access group or watch group of antibiotics or restricted use of antibiotics. So to this session, we have three speakers. So first, all are related to this, how to use, better use, optimal use, appropriate use of antibiotics that will present. So now, I would now request Dr. Bhaskar Krishnamurthy. He is going to kindly deliver his speech entitled on antibiotic prescribing in critical care. So, Dr. Bhaskar Krishnamurthy, please.
Thank you, madam. Very good morning to my respected seniors, my dear colleagues, and everyone attending. So, am I audible? The screen is clearly visible. All good? Okay. So at the outset, I would like to thank the organizers for giving me an opportunity to speak on this stage, and more importantly, for having my session in the early morning, because a few years ago, I had come across a survey which said that the number of people likely to sleep in the lecture is least in the early morning session. Noteworthy point, they said least, they did not say zero. So the topic allotted to me is antibiotic prescribing in critical care. To be very honest, it's a topic for an entire conference itself. but I'll try to summarize this in the allotted time by giving an introduction of the topic. What are the PK/PD changes that occur in the critically ill and how do they occur, with a few examples? Certain recommendations which are there in the literature with some way forward, and I'll summarize my presentation. So to begin with, infections are extremely common in the ICU setting. In fact, in a majority of these cases, the infection may be the cause of ICU admission. There is sepsis, septicemia are commonly seen. If it is a hospital-acquired infection, it is more likely to be an antimicrobial resistant pathogen. There are MDR, multi-drug resistant pathogens, which are now known to cause infections. And studies have reported that the per capita antimicrobial consumption is the highest in the critically ill population. And if the antimicrobial use is not appropriately designed, if it is unnecessary or if it is prolonged, then it can lead to various harms, such as increase in the hospital stay, increase in the cost of therapy, including increase in mortality. So that is why this is a special population we need to consider while designing the antimicrobial use. So what are the various factors which affect the PK/PD of drugs in the critically ill? The pathophysiology of the disease itself can affect the drug PK/PD. Generally, in the ICU patients or the critically ill patients are likely to have multi-organ failure. Liver and renal failure can affect drug clearances. The organ support therapies that we use, like renal replacement therapies, mechanical ventilation, extracorporeal membrane oxygenation, they can also have an effect on the PK/PD of drugs. And needless to say, polypharmacy is extremely common in this population, and that can lead to a high incidence of drug-drug interactions. So the various PK/PD changes that occur in the critically ill, the volume of distribution increases, more so for the hydrophilic drugs. There are various reasons for this. There is inflammation in these patients, which cause vasodilation, increased capillary permeability. It can lead to edema and loss of drug into the interstitial spaces. There can be reduction in serum albumin secondary to liver dysfunction, which can increase the free form of drugs. There are body weight alterations which occur. Even intensive care procedures have an effect on the drug PK/PD. So all of them combine to have an increase in the volume of distribution. Even the external fluid support that we give can lead to increase in the blood volume and dilution. So the volume of distribution can increase. The clearance can either increase or decrease depending on the situation. Renal failure can decrease drug clearance. If the patient is undergoing renal replacement therapies, the drug can be excreted by hemodialysis, so clearance would increase in such a case. Plasma protein binding changes, and not only PK, but even the PD part is affected, because the MIC, or the minimal inhibitory concentration that we calculate, it is generally based on in vitro studies where we have a static concentration of the antimicrobial and a fixed microbial load. Generally, in the in vitro studies, we have a 10⁶ to 10⁸ colony forming units per ml of the bacteria or the microbe. But in a setting of sepsis, there is a possibility of high microbial load. It may go up to 10⁻10 to 10⁻12 CFU per ml. So the actual concentration or the actual level of the antimicrobial that we have may be insufficient to take care of this high bacterial load. At the same time, if it is a resistant pathogen, naturally the MIC is likely to be higher. So both PK and PD are affected in the critically ill population. Various studies have shown various examples where the absorption of the drugs can be reduced if there is an increase in the gastric pH, or decreased perfusion to the GIT, or reduced intestinal motility, or reduced apical drug transporters due to loss or disruption of the architecture of the colon. The distribution of the drugs can be affected because of hypoperfusion, hypovolemia, decreased blood flow to various organs. There are fluid shifts also. In yesterday's presentation, Dr. Sumit Matthew had said loss of drug into the third spaces, loss of drug into ascitic fluid. And then when the ascites is drained, the drug is lost along with it. Same thing can happen with pleural effusions also. So third space losses of drugs. Then variations in albumin and alpha-1 acid glycoprotein can affect the free form of bound drugs. The hepatic enzyme activity can be affected primarily due to a hepatic disorder or secondarily due to increased toxins in case of renal failure, secondary to uremia. There can be acute kidney injury or the renal failure can occur, and renal replacement therapy itself can have variable effect. So coming to hemodialysis, the dialysis membrane, the dialysis machine or the membrane itself acts as an organ of excretion. Multiple factors affect the clearance of drugs, which can be classified into drug, dialysis machine, and patient-related factors. Drug factors: low molecular weight compounds, more likely to get filtered. More hydrophilic drugs, more likely to get filtered along with the water. Plasma protein bound drugs, less likely to cross membranes. High volume of distribution, more distributed in the tissues, less likely to be excreted in dialysis. The type of the dialysis filter, how much it can absorb drugs, that can affect drug clearance. The surface area, larger the surface area, more is the clearance. Blood flow and dialysate flow rate, whether the dialysis filter is reused, whether the patient has liver disease, and the total fat content or body weight. All of these can affect the clearance of the drugs in hemodialysis. So certain examples where the clearance of the drugs has been measured on conventional, that is low flux or low flow, and high flow dialysis. Naturally, with the high flow dialysis, the clearance of most of the drugs is found to increase. More so with vancomycin, especially, the type of filter that we are using has a significant impact, where whether we use a polysulfone filter or a PMMA filter, the clearance is likely to change. There is something called as augmented renal clearance, which can occur in early stage of sepsis. This is a compensatory mechanism where the body tries to increase the cardiac output, and this can increase the renal blood flow and transient increase in the renal clearance of drugs. So this was one study which showed that the clearance of beta-lactams and aminoglycosides in the initial stages of sepsis may be enhanced. So the doses initially may have to be higher. So we may have to start with higher doses of these drugs while starting therapy. Mechanical ventilation can reduce the cardiac output. Mechanical ventilation is a state of artificial respiration where the intrathoracic pressure is made more negative. The cardiac output can reduce, which can reduce the blood flow to various organs, and this can affect the drug clearance. As an example, the clearance of vancomycin was found to be reduced by almost 1/5 in patients who are on mechanical ventilation. Extracorporeal membrane oxygenation, the membrane, the tubings that we use can sequester the lipophilic drugs. So drug adherence or drug retention on these tubings can actually lead to loss of drug in the body. Drug-drug interactions can occur if there are multiple concomitant medications are administered. And study has shown that if the number of drugs increases to 10 concomitantly, then the risk of drug interaction increases 8-fold. And needless to say, this is a population where up to 7 or 10 drugs is found extremely common. So just to state a few examples, cefuroxime population pharmacokinetics has been studied in the critically ill, where 160 samples were obtained from 20 patients. The probability of attaining the pharmacodynamic target, which is a 65% of the time above MIC to be achieved for the free drug, considering a MIC of 8 milligram per liter. This study evaluated multiple doses of cefuroxime. There was an intermittent dose given as a half-an-hour bolus, and then there were extended infusions for up to half of the dosing interval. One was every 8 hours and every 6 hours. And then there were continuous infusions for 24 hours. So this study showed that with a high renal clearance or with a normal renal clearance, as the continuous infusion is given, the probability of attaining the PD target is high. As we go for intermittent infusions, as we go for lower doses, the probability of target attainment actually reduces. And of course, with a reduction in renal clearance, the clearance of the drug itself is reduced, and there is likely to be an accumulation of the drug in the body. So this study concluded that intermittent bolus is not likely to achieve the therapeutic target. So for a drug like cefuroxime, continuous infusion at higher doses is a better alternative. Similarly, another example for vancomycin, a multi-center study was done on 42 patients from 26 ICUs, out of which 57% received vancomycin as a continuous infusion, and the remaining achieved as an intermittent bolus. The attainment of semen and AUC 0 to 24 hours was evaluated in this population. It was seen that overall, semen was attained in only up to 57% of cases and AUC in up to 71% of cases. More so, it was more likely to attain the target, both semen and AUC, with a continuous infusion than with the intermittent bolus. So, large variation was observed in the pharmacokinetics of vancomycin in this population. And they said that the current dosing regimens are insufficient to attain the target PD levels. A similar study was done in our own center by one of the previous PhD students, where the steady state vancomycin levels were evaluated in both pediatric and adults intensive care units. It was found that up to 66% of the pediatric samples and up to more than 70% of the adult samples were less than 10 microgram per ml, which is below the therapeutic range. So basically, we are underdosing our population. The reason could be fear of toxicity, but the risk is clearly there, a lack of therapeutic effect, which may further fester drug resistance and ineffective treatment. So this is a paper published in 2020, which I would recommend you to read, a revised consensus guideline given by multiple societies who have come together and who have given dosing recommendations for vancomycin. So timing when to start antimicrobial therapy in the ICU, there are various guidelines that have been given, but the simple dictum is earlier the better. So the black bars here show there are multiple studies which have evaluated delay in the initiation of antimicrobial therapy as shown in the black bar, and the white bars show early or timely initiation of antimicrobial therapy. The difference in the mortality rate is glaringly obvious. So earlier, the better. Certain recommendations mentioned in the literature, goal-directed pharmacotherapy. So when you start treatment in this critically ill population, you have a goal. You decide what is the PD target, what is the PK target that you want to attain. And previously what we were saying, one dose fits all is no more true. Rather, a better option is go for individualized treatment. How do we do that? There are PK-PD based decisions or algorithms which are available. And this is where we as clinical pharmacologists come in. A wonderful example was given yesterday by Dr. Sumit Mathew when he discussed the same thing. Best Dose is one of the softwares that they are using in JIPMER. There is another live software which is available. So there are softwares available which help you to decide on what is the optimal dose based on the PK-PD characteristics of that particular drug and even the patient and the disease characteristics. And as clinical pharmacologists, we always recommend TDM, at least for drugs like vancomycin, aminoglycosides, and voriconazole. These are the drugs where there is absolutely no doubt that TDM will definitely improve the outcomes. And as it is always said in any literature, any paper, existing literature is insufficient. Further studies are needed to get more information. Furthermore, suggestions which have not been definitively proven, but yes, can be tried. We may need local guidelines in ICU settings. So each, as we know, the pathogen pattern will be different in different ICUs. So we may actually need ICU tailored guidelines for antibiotic use. So considering the local antibiograms, considering the local resistance pattern, the local guidelines may have to be framed. Can rapid diagnostic methods be used? Maybe. Rapid diagnostic kits, which are available as point of care service, may help in deciding whether to start antimicrobial or no in a particular scenario. Can we use artificial intelligence, machine learning? Maybe. can be tried to develop the dosing algorithms. So to summarize my presentation, there are pathophysiological changes that occur in the critically ill population. There are organ support therapies like mechanical ventilation, ECMO. All of them can affect drug PKPD. A knowledge and understanding of this is important for a clinical pharmacologist for devising a proper dosing regimen for safe and effective pharmacotherapy in this population. The dose optimization and optimal timing of initiating the therapy, these are important predictors of outcomes, including mortality, and goal-directed therapy, which can be based on PKPD models, and therapeutic drug monitoring can be used for individualizing therapy in this population. So with this, I conclude my presentation. Thank you. On time, exactly. Thank you for listening. And if there are any questions, I'll be happy to answer them.
Morning shows the day. You finished in time.
Thank you.
All credit should go to you.
Thank you, sir. Okay. Okay. No problem. Okay. Thank you.
So thank you so much, Dr. Krishnamurthy, for your excellent speech, which I am sure will benefit all of us. Okay. So now now our next speaker. So I would now request Dr. Maulik Doshi to kindly deliver his speech entitled Interpreting Antibiogram. So Dr. Maulik, please.
Online.
He is in online.
Yeah, hello, good morning. Am I audible?
Yes, yes. Okay.
All right.
Maulik.
Yeah. Thank you very much, madam. So I'm just sharing my screen. Is my screen visible? Is my screen visible? Can anybody confirm?
Yes.
Yeah, thank you very much. So it's really great to be here. Unfortunately, I cannot attend the conference in person because of some personal commitment. So now, if you look at nosocomial infection in ICU, it is around 11 to 60% in India. Now, when we look at the economic burden of this nosocomial infection, so in ICU setup, so it is around 1,80,469. So it is coming very costly. And antimicrobial resistance, we can see it is rapidly rising, which Dr. Bhaskar has already mentioned. Now, when we look at what are the reasons for this infection and how we can reduce it and how we can reduce the economic burden, so there are multiple factors which plays into this infection and the antimicrobial resistance. One of the solution can be a judicial use of antibiotics, and for that judicial use of antibiotics, the important part is that the antibiogram program. So if you look at the government initiative, Government of India is also taking so many measures to address this antimicrobial resistance. Even if you look at the state-wise initiative, then Kerala becomes the first state to release an antibiogram. So nowadays, antibiogram profile, it is coming very needed, and all the states are anyway eventually following this solution, and this will be really helpful in curtailing the antimicrobial resistance. So with that objective, that solution, I would like to congratulate the organizer of ACPICon 2023 who have taken this session. And these are my disclaimer, standard disclaimer. This is the outline of the presentation. So first of all, we'll discuss on the introduction of this antibiogram. Then what is an antibiogram? then components of an antibiogram, then which are the factors which affect the interpretation of an antibiogram, then how to read an antibiogram, and then future trends and the technologies. Now, before going to the antibiogram, the key question is, what is the current knowledge, attitude, and practice regarding the antibiotic use? Now, let's look at from different part of India. So let's look at from publication from South India. So this paper, it discusses about knowledge, attitude, and practice related to the antibiotic use and resistance among the general public of coastal South Karnataka. And what this paper says that knowledge regarding antibiotic resistance and its causes is limited. The focus in the future should be on creating awareness among the public on the prudent use of antibiotic. Another paper from AIMS Jodhpur, Rajasthan, it says that the knowledge level of medical students was quite satisfactory. However, the attitude and practice which are concerned, there is a need for substantial improvement. So somewhere here it talks about the antimicrobial chemotherapy and its usage. So here there is a role of a clinical pharmacologist that in the curriculum only there should be a knowledge given to use of antimicrobial therapy. So now coming to the antibiogram. So it says now the M39, which is a guideline published by CLSI, it says the report which is generated by analysis of result on isolated from particular institution in a defined part of time, which reflects the percentage of first isolate, which is per patient of a given species that is susceptible to each of the antimicrobial agents routinely tested. Now, what are the components of antibiogram? So broadly, we can categorize the components of antibiogram into four: bacterial isolates, an antibiotic, and the susceptibility. So these three are the core component in any antibiogram from any institute. Some of the institutes in India as well as globally, they also give minimum inhibitory concentration. Sometimes they also give the clinical interpretation with the help of clinical pharmacologists. And they also give the epidemiological information about the resistance pattern in their particular region. So these are the four broader components of the antibiogram. Now, what is the purpose of antibiogram? It will actually facilitate the tailored antibiotic therapy for individual patient. So many a times when we have to do empirical therapy, we should be knowing that which antibiotic should be given. So it helps in that. And it will guide clinician in selecting the effective antibiotics, mainly for the empirical use. Then assist in curbing the antibiotic resistance by optimizing the antibiotic use. What are the key benefits? Healthcare provider, it can choose antibiotics which are more likely to be effectively treat the infection. And it will also minimize the risk. Column, these are the bacterial isolates. So these are the bacterial isolates patient. Now, these patients simply can own culture. Now, when we look at the results here, it can categorize into susceptible, intermediate, or resistant. So susceptible means now this part, it shows antibiotic, beta-lactam, cephalosporin, and the others. So these are the key components of the antibiogram in any institute. Now, many a times, as I said earlier, that antibiogram also gives the level of minimum enzymatic concentration. So now let's understand what is important part. So this is a case study. So there is a strain of Escherichia coli, which has a MIC of 2 microgram for amoxicillin and MIC of 8 microgram for cephalexin. So which antibiotic to be selected? So here it is showing the in vitro efficacy of amoxicillin and clavulanic acid. So this part shows sensitiveness in the MIC, intermediate, and the resistance. So this resistance is the breakout point. So this is tested in various concentration of amoxicillin, and this concentration, that is 2 microgram per ml, it shows the more sensitive MIC. Now another part, so this shows sensitivity at the 8 microgram per for any for any bacteria, it should be more sensitive whenever there is a patient. In this information, it is very helpful from the antibiogram from any institute. Now, there are various factors which affects the interpretation of antibiogram. So once we have the information about the susceptibility, then we come to the MIC part. So susceptibility, then the MIC. So one of the parameter is the age of the patient, then the underlying health condition. It's his allergic and immune status. Many times what will happen that the patient will be susceptible to, that part should be also considered. Then the severity of infection and its potential complication. So if the infection is more severe, then it may require sometimes the highly potent antibiotic. So with that, for that patient, the MIC value will be helpful. Then the site of infection. Different body sites, they will have unique bacterial flora and the resistance pattern. The antibiotic penetration and efficacy can vary on the infection location. So Dr. Bhaskar just mentioned earlier that there can be some antibiotics which are very much soluble in the lipid, so it can cross that barrier and reach to the penetration site. So that is why we should be knowing that at which side, whether it is skin, whether it is intestine, where the antibiotic, where the infection is there, and based on the site of infection and antibiotics profile, we should select the antibiotic. Then the PK/PD of antibiotics. So this Dr. Bhaskar has already mentioned that the absorption, distribution, metabolism, and excretion, it actually affects the effectiveness of antibiotic. And the PK/PD, it helps in optimizing the dosing for maximum bacterial cleaning. Local resistance. There are some regional variation in bacterial resistance profile which can the treatment option. Then co-infection when diagram, it may not show the co-infection part. So co-infection, if it is there, then there will be multiple bacterial species which can complicate the interpretation. So here, this is also when the clinician is trying to use any antibiotic, he or should be knowing the correct antibiotics. Now, how to read an antibiogram? So first step in antibiogram therapy is that we should identify the bacterial species. Suppose it's the Escherichia coli. Then we should select the antibiotic. Now in antibiotic, there can be various MICs, various sensitivity. So we should select the highly potent antibiotic, and that is based on the MIC and the susceptibility pattern. Then look at the susceptibility, whether it's susceptible resistance. Then consider clinical scenario. So in clinical scenario, as we discussed earlier, PKPD should be also considered, age of the patient, immunity status, all these factors should be considered, and then treatment plan.
Sorry, Dr. Doshi, we cannot hear you. And your slides are also not visible. There is some network issue, I think, from your side. Sometimes there is network interruptions are there.
You should unmute, really.
So please unmute yourself. Team Clarinet, can you hear us?
Dr. Doshi to unmute himself.
Yeah, am I audible now?
Yes, now you're audible.
All right, all right.
I think there is
Sorry.
issues in your network connection. So
Okay.
can you please sum up, because as we are running short of time also. So
And the slides are also.
slides are also not visible.
Absolutely, absolutely. Yeah, yeah. Is it now visible? My slides are visible or not?
Yes, now visible.
Visible, right? Okay, okay, fine. So now when we look at the future trends and technologies in antibiogram, so much is on the plate. The first one is the genomic based approaches. So utilizing the whole genome sequence to identify the resistance genes, and regular pharmacologists with the pharmacogenomic technique that can helpful in refining the antibiogram. Then there is a rapid diagnostic method. Then PKPD modeling, machine learning and AI. So this is a new buzzword across everywhere, machine learning and AI. So antibiogram is also part of this machine learning and AI. So predictive models are going to prepare. So what happens in this model is that whenever any hospital prepares an antibiogram, so it is having so much of data. Now, whenever any clinician is using the antibiogram, and if it works, then they share this data to the lab, which prepares antibiogram. And based on that data, that lab will predict that in the future, when they are preparing the antibiogram, what kind of updation can be there in the antibiogram. Then precision medicine in infectious disease, microbiome analysis. So here there is a role of patient's microbiome composition, impact of microbial communities on infection and the treatment response. Then another approach is
Maulik, we can't hear you. I think maybe you can switch off your camera. Maybe that might increase your bandwidth.
I think there is some issues with Dr. Doshi's net connection. We'll surely connect him. But I think I request Madam to proceed for the next session, as we will be delayed.
So Thank you, Dr. Maulik, for a great presentation. So now our next speaker, I would now request Dr. Professor Dhaneria, S.K. Dhaneria, to present his speech entitled Rational Use of Antibiotics. Please.
Can I start? Best. It's connected. Honorable Chairperson, my esteemed colleagues and distinguished delegates. At the outset, I express sincere gratitude to the organizers for giving me this opportunity to interact with you. Slide. In this deliberation, I will be sharing with you the topic need to rationalize the use of antibiotic and few points about the antimicrobial stewardship. There is a significant burden of infectious disease in our country, and our country is the largest consumer of antimicrobial drugs globally. Antibiotics are often overused in clinical practice. Antibiotics are one of the most commonly prescribed drugs, being responsible for 30 to 50% of hospitals' total drug budget. Antimicrobial resistance is well-recognized global threat to the human health. Antimicrobial resistance is closely linked to overuse and misuse of antibiotics. What are the situations where we are overusing and misusing the antibiotics? Use of antibiotic in every case of fever. This is highly unjustified because there are a number of non-infectious causes of fever also. Use of antibiotic for untreatable infection means using the antibacterial drug for the management of viral illness. When actually surgical intervention is required, we are depending on the frequent use of antibiotics. If there is an abscess, it is to be drained. If there is foreign body, it is to be removed. If there is renal stone causing recurrent UTI, the surgical intervention is required, not to repeatedly use antibiotic to treat the recurrent UTI. Unnecessary use of systemic antibacterial. If there is a superficial infection, cleaning of the wound and local antiseptics will be sufficient. There is no need to use the systemic antibacterial. Over-reliance on the parenteral antibiotic. Parenteral antibiotics are indicated when patient is critically ill. Our nature of antibiotic is such that we cannot use it orally. Our patient condition is such that orally drug cannot be used. Because unnecessary use of parenteral antibiotic will increase cost of therapy, prolong hospital stay, and also increase the risk of IV line infection. Many times antibiotics are used in very high dose in order to obtain a quick and intense effect, but at the cost of toxicity. Another scenario where antibiotic is used in low doses because of the apprehension of adverse effect. And this may lead to therapeutic failure and also increase the risk of emergence of resistant organism. Discontinuing the antibiotic just on the basis of clinical improvement without ensuring the cure may lead to therapeutic failure and also increase the risk of drug resistance. Sometimes the antibiotic is prescribed because of the patient. The physician may succumb to the pressure of patient to prescribe the antibiotic, and that too the injectable. Sometimes it is the irrational drug promotion by the industry which lead to overuse and misuse of antibiotics. Sometimes the microbiological information regarding the infection is not available, and because of that, the physician uses number of antibiotics to cover all the offending microorganisms. Antibiotics used for prophylaxis are often inappropriately chosen and administered. 30% of antibiotics used in hospitals are for prophylaxis, and more than 80% are given inappropriately for more than 48 hours duration. For prevention of surgical site infection, there are very clear indications when to be used. For clean contaminated surgery, contaminated wound, dirty wound, surgeries involving prosthetic material, heart surgery, neurosurgery, because there the occurrence of infection will be drastic, will have drastic complications, and immunocompromised patient. Cefazolin is universally accepted drug for prevention of surgical site infection to be used in the dose of 2 grams intravenously within 1 hour prior to incision. Mostly we require single dose, and alternative to cefazolin, if it is not available, it is the cefuroxime. But in clinical practice, we are using many antibiotics for prevention of surgical site infection and also for a longer duration. Antibiotic prescribing with misconceptions. Newer drugs are always the better drugs. Costly drugs are always the better drugs. Branded drugs are always the better than generic. So these are the misconceptions. Expensive drugs are more efficacious. That is wrong notion. Not always true. For prevention of surgical site infection, cefazolin is recommended, and third generation cephalosporins, which are expensive drugs, are offering no advantage over the cefazolin. New antibiotic is not the answer to every infection. The 5th generation cephalosporins, ceftabiprole and ceftaroline, have limited activity against the anaerobes. Tigecycline is not effective against the Pseudomonas. Polypharmacy is always better. It's a misconception. Polypharmacy is indicated when their patient is critically ill, life-threatening infections, chronic diseases like tuberculosis, leprosy, or polymicrobial infection. Unnecessary use of too many antibiotics will increase cost of therapy. There is a risk of adverse drug reactions, also drug interaction, and also there is a risk of emergence of resistant organism. Fixed dose combinations are always better. That is again misconception. Our market is flooded with too many FDCs. But if you go to the essential medicine list of our country published in 2022 and of WHO 2023, these are the antibiotic FDCs are enlisted in list: sulfamethoxazole, trimethoprim, amoxicillin, clavulanic acid, piperacillin, tazobactam, ceftazidime, avibactam, meropenem, vaporbactam. And the last one is added in the WHO Essential Medicine List 2023, the ceftazidime with the tazobactam for Pseudomonas. Now, about the antimicrobial stewardship. As per the Centers for Disease Control and Prevention, what is antimicrobial stewardship? It is the use of right antibiotic for the right patient at the right time with right dose, right route, and correct frequency. causing least harm to the patient and the future patient. WHO has also defined antimicrobial stewardship, and Infectious Disease Society of America has also defined the antimicrobial stewardship, emphasized on the responsible use of antibiotic. Antibiotic should be correctly chosen. Its dose should be appropriate and it should be given for adequate length of time. What is the goal of antimicrobial stewardship? Optimizing the antimicrobial selection, dosing, route of administration, duration of therapy to maximize clinical cure or prevention of infection. That is first. Second, limiting the unintended consequences like emergence of resistance, cost of therapy, adverse drug event, and promoting rational and judicious use of antibiotic, and also prolonging the lifespan of existing antimicrobial. So these are the goals of antimicrobial stewardship. Antimicrobial stewardship team is consisting of infectious disease physician, infection control officer, clinical microbiologist, internal medicine physician, clinical pharmacist with infectious disease training, antimicrobial stewardship nurse with infectious disease training, officer in charge of pharmacy, and now included clinical pharmacologist. So it is the team, antimicrobial stewardship team. This antimicrobial stewardship team is led by antimicrobial steward, who may be the infectious disease physician or infection control officer or clinical microbiologist. In large hospital, we can have more than one antimicrobial steward. So what are included in the antimicrobial stewardship program? We have to frame an antimicrobial policy in the form of handbook, easy to carry. Depending on the common infectious disease, we follow the syndromic approach, and from valuable inputs from the microbiology department, we prepare the antibiotic policy. Implement the AMS strategies, front and strategies and back end strategies, and also educate not only the healthcare professionals, but also the society for the rational use of antibiotic. What is the front end strategy? Formulary restriction and pre-authorization. So we divide the drug, non-restricted agents like access group. The agent for which the pharmacy supply does not require AMS team approval. It includes the first and second line drugs for common infectious disease. Semi-restricted agents, watch group, agents for which the pharmacy supply of more than 48 hours require AMS team approval. These are the drugs where the risk of resistance is more. And in restricted agent, these are the last resort agent for multi-drug resistant infection. And for their supply or prescription, the AMS team approval is required. If physician wants to prescribe the drug from watch group for more than 48 hours or want to use the drug from restricted group, he has to fill the form, pre-authorization form, and the AMS team will give the decision on approval or denial within the time. According to the WHO aware tool that recommends that 60% of all prescribed antibiotic must belong to the access group by 2023, means we should restrict the use of watch group and restricted group of antibiotic. What is the back end strategy? It is done by discussion between the MS team and clinical team on antibiotic prescribing practices. Advice is given on empirical, targeted, and prophylactic therapy. So here we can go for escalation. Suppose the organisms are sensitive to ceftriaxone, piperacillin tazobactam, and meropenem. Then if we were using piperacillin tazobactam and it is, say, sensitive to the ceftriaxone, we go for the step down approach, means de-escalation. Means from watch group, we will go to the access group. Suppose the organism is resistant to first and second line drug, including the piperacillin tazobactam, and sensitive to meropenem. We stop the piperacillin tazobactam and we can use the high line antibiotic like meropenem. So it will include narrowing of spectrum, removal of the overlapping spectrum. Means meropenem and piperacillin tazobactam, their spectrum is overlapping. So no need to use both. No need to add metronidazole to meropenem when there is mixed gram-negative bacillary and anaerobic infection. Meropenem will take care of anaerobes also. Once the patient is febrile, clinically stable, culture is negative, blood counts are normal, procalcitonin level has come down, we should stop the antibiotic. And we can switch from IV to oral. If organisms are sensitive to, say, nitrofurantoin and ciprofloxacin, in place of using the IV ciprofloxacin, we can use to nitrofurantoin orally. Then the change of antibiotic within line and across the line. Within line means we are changing between the access group or watch group or restricted. And across the line means we are changing from restricted to watch or watch to restricted. So there are a number of actions which are taken. Suppose there is allergy to beta-lactam, we should not use ceftriaxone. In children, we should not use tetracycline and avoid use of fluoroquinolone. If it's a meningitis, better to go for meropenem rather than using imipenem and cytostatin. In 1945, Alexander Fleming, in his Nobel oration, warned the world of danger of over-reliance on antibiotic and the threat of bacterial resistance. Paul Ehrlich mentioned about the problem of drug resistance. Drug resistance follows the drug like a faithful shadow. These words of Father of the Nation are true word by word as far as the antibiotic prescribing practices are concerned. Your beliefs become your thoughts become your words become your actions become your habit, and your habits become your values. When an organization is developing antibiotic, they usually feel that their investments goes waste because antibiotic is to be used for short duration. It cures the disease, and in due course of time, there is a possibility that this antibiotic may become ineffective because of the development of resistance. So we have only few antibiotics in pipeline. There is a limited resources of antibiotics. So antibiotics are very precious drugs. These are to be preserved, and there is a need to rationalize the use of antibiotics in interest of science and society. If we use antibiotics when not needed, we may have them when we may not have them when they are most needed. Antibiotics have saved our life for so long. Now it is the time for us to save the antibiotics. Otherwise, we'll end up in situation, bed bugs, no drugs. So this crisis of antibiotic resistance may revert the civilization back to the pre-antibiotic era. So I conclude my presentation with the words of great Greek physician Hierophilus. Medicines are nothing in themselves if not properly used, but the very hands of gods if employed with wisdom and prudence. Thank you very much for kind attention. These are my references. Thank you very much.
Thank you, sir, for excellently illuminating speech. So now any question, any doubt can ask.
Questions in the chat. I'm checking that, sir.
Good morning. I appreciate the lecture Dr. Bhaskar told in the morning, first lecture. Hello. Yeah. Precisely, it's okay what we discuss in meeting, in lectures and other thing, and what I listened yesterday also, Dr. Shoibal's discussion. We need to do practical works more, what we teach, PKPD, etc. It's essential to get the knowledge implemented in the clinics. And that is lacking. And that to be done to get the knowledge earned by the clinical pharmacologist. Dr. Hota is here. We are in the same talk in the Patna meeting also. That's why we started this group who should not be only theoretical clinical pharmacologist, in practical sense also, to get benefit of knowledge of clinical pharmacology to the patients. And for that, we have to work extra mile. Because sometimes we teach, take the exam, declare the results, means mainly all theoretical part as a teacher. And for that we are paid. But to make a mark, to do something extra, you have to work extra. Like clinical microbiologist, they are part and parcel of the hospital because they give culture sensitive report, and then the clinician, of course, they start empirical therapy first, but then finally they give honor to CS. But there we are lacking. We discussed TDM, but very hardly, very few places is there a TDM lab, like in PGI, I think, in JIPMAR. And sometimes it is that lab is not there, government is not support because of our lack of industry is also important. Like in microbiology, next generation sequencing lab in Crores, they are being given by the authority because I am an academician as well as now as a administrator. So I feel where is the lacking? Lacking is that is lack of interest of ourselves, I'm telling it. Unless we showed interest to the authority, they will not give the support. But it's still, it's a good sign that it's happening now. In our school, college time, when I was a student, that time it was exclusively only for teaching and learning in pharmacology. But now, many of us are joining in industry, means in the hospitals also like this, and giving some help. And finally, I tell that this town is the first pharmacologist. Colonel R.N. Chopra was here. I think in the history we call him father of pharmacology. 17th August was his birthday, 1882. And he worked in School of Tropical Medicine, the historical place. I visited many times there when Dr. Tripathi was there. And he started DM clinical pharmacology also here. And they have started the outdoor in clinical pharmacology. So that's the gist, and that is the starting. And now in the history, we also can quote, Dhaneria has quoted so many things. Gokhale told once that Bengal sings today, India sings tomorrow. So Dr. Tripathi and this young boy have a great expectation, Samajhdar. They have started good beginning here. And that should be circulated and spread all over the India. Then only we should consider that we are part and parcel of the hospital. Clinical pharmacology students should be posted like clinical microbiologist residents. They do journal clubs, they do the topics, lectures, etc. But simultaneously they are posting in lab. Clinical pharmacology lab should be there. Residents should be posted there regularly. Samples should come there to get the TDM or to get the only we are restricted now ADR and other thing, drug utilization, some studies are there. But that's due to compulsion of sending the reports to Uppsala and other thing. So with these few words, I congratulate this effort. About Dr. Dhaneria, your other quotes I appreciate, but about Father of Nation, as much as I'm reading, he is telling something this year and next year he is sending in mind thought another thing. So I have some reservation of about his quote. Thank you.
Thank you, sir. Just to extend, do I have the permission to say what Smita madam had taught me during my DM days? There are two areas where a pharmacologist can actually dictate a clinician: pharmacokinetics and biostatistics. If these two topics are strong, you can actually tell a clinician what to do and how to do. Thank you.
Now may I request Professor Nihar Vishwas sir, please felicitate Professor Chayna Sarkar. Now also may I request Nihar Vishwas sir to please felicitate Professor S.P. Dhaneria sir.
Colleague from PJ Chandigarh. Yeah. Very good.
Also, Dr. Bhaskar, please come.
Bhaskar is our student from AIMS. Engineers, huh? MDMs and PhD. So we can go
Thank you, sir. So for the next session, So for the next session, that Professor Ranjit Roychowdhury oration lecture. So now I invite Professor Urmila Thatte, madam. She is online. So madam, are you there?
Yeah, I'm here.
Yeah.
Yeah.
Good morning, madam. Welcome, madam. And also may I invite Professor Santanu Tripathi, sir, to chair the session.
Good morning, everybody, and welcome, Dr. Urmila.
Thank you. Shantanu, may I introduce Shoibal, please?
Yes, I am going to that. It's a proud privilege we are going to have this Professor Ranjit Roychowdhury oration. And the oration will be delivered by none other than Dr. Shoibal Mukherjee. I am fortunate we also have Professor Urmila Thatte with us online. And she will be introducing Dr. Shoibal Mukherjee. Before that, let me have a few words about Professor Ranjit Roychowdhury, in whose memory our association has resolved to have this oration every year. And this year, Dr. Shoibal Mukherjee is going to deliver the oration. I'll just read out. It's almost an impossible task to introduce Dr. Ranjit Roychowdhury in a few words. He is a legend by himself. But then it's customary to say a couple of words. So let me read out a brief paragraph about Professor Ranjit Roychowdhury. Professor Ranjit Roychowdhury, who established the discipline of clinical pharmacology in India, was among a rare breed, a leader, a charismatic mentor, and a firm believer in affordable healthcare for all Indians. He worked tirelessly towards passing legislation of free essential medicines to those who need them most. His philosophy and commitment to public service and health equity will continue to shape policy in the decades to come. His students and colleagues will carry on his legacy in the fields of clinical pharmacology, public health, traditional medicine, research ethics, and national health policy. A pathbreaker and a visionary, his list of accomplishments are long. He was a professor of pharmacology, dean, and retired as acting director of the Postgraduate Institute of Medical Education and Research, Chandigarh. He established the Delhi Society for Promotion of Rational Use of Drugs and was the founder director of the Delhi Medical Council. He was the first Indian doctor to receive a Rhodes Scholarship after his stint at Oxford University. He came back to complete his DPhil in pharmacology. He was also felicitated with an honorary degree of Doctor of Science from Chulalongkorn University, Thailand. He has been the advisor to the Department of Health and Family Welfare, Government of National Capital Territory of Delhi, and was nominated by the Ministry of Health and Family Welfare, Government of India, as chairman of the newly constituted expert committee for reforms in drug regulation and clinical trials. Professor Roychowdhury was also served as advisor to the Union Minister of Health and Family Welfare, Government of India. At the time his passing away, he was chairing no fewer than 10 committees at the Ministry of Health and Family Welfare. In recognition for his landmark contributions, he was awarded the Padma Shri in 1998. He was honored with a Lifetime Achievement Award 2013 by FICCI and the first Lifetime Achievement Award in Integrated Medicine by the College of Medicine, London, and the Saukya Foundation. His commitment to the country and public health was absolute. Without his landmark work, we would not have the clinical trials framework in the country and the awareness about the problem of antimicrobial resistance. The best way we can honor Professor Roychowdhury is to take his work forward while remembering his graciousness and depth of commitment that brought to the millions of lives. With these few words, I would now hand over to Dr. Professor Urmila Thatte, our co-chair today, to please introduce our orator of today, Dr. Shoibal Mukherjee. Over to Dr. Urmila, please.
Thank you. Thank you, Shantanu. Dr. Shoibal Mukherjee doesn't really need an introduction, but I think it is important for us to remember some of his special achievements. He has a postgraduate qualifications in medicine and pharmacology with over 30 years of experience in drug development and pharmaceutical medicine. He has headed medical and research departments in Pfizer India, Ranbaxy Laboratories, GVK Biosciences, and Quintiles Asia. He is, and I remember those days when we used to interact during the time he was establishing the Indian Society for Clinical Research. He was the first president of this currently very well-known society. He is currently involved in assignments across the pharmaceutical research and medical startup domains as an independent consultant with assignments in pain, tropical diseases, biologics, vaccines, and phytopharmaceutical research. He has been guest faculty for training and doctoral programs at leading medical institutions and is in India, and is a member of the research advisory boards and technical committees of various private and public sector organizations and institutions. Dr. Shoibal.
Welcome, Dr. Shoibal. And I request Dr. Shambo to felicitate Dr. Shoibal first, and then he can have the oration. I'll request Dr. Dhaneria to please come up and do the honor. Dr. Shoibal. Just a second, please. That's good. I think it's. So now Dr. Shoibal can have his presentation.
The presentation here. Is my hand?
Dr. Shambo, presentation, please. Please come.
Team can please mute others except us. Planet, can you hear us?
Yes, sir. Yes, sir.
So please mute others.
Sir, others are muted, sir.
Okay, great. Thank you.
Good morning, ladies and gentlemen. thank you to the chairpersons, Professor Urmila Thatte, Professor Tripathi, for the kind introduction. It's a great pleasure for me to be here this morning. I hope everyone can hear me. Is the voice clear? Thank you. Great honor for me to be here presenting the Professor Ranjit Roychowdhury oration. Professor Tripathi has already spoken about Professor Roychowdhury. I would just like to take your attention to a few specific points about him. Can I have the next slide? Can I change the slides from here? Yes, sir. So I'm wondering which. Great. Thank you, Shambhu. So obviously, we've heard about Professor Roychowdhury's life. I would like to pull your attention to certain specific points in his progress, in his pathway, his journey. He started off from Patna. So, here is this gentleman starting off from not that great, metropolitan center in India. And he from Patna moves to Oxford. He gets the Rhodes Scholarship and he moves to Oxford. Obviously, that is a very, very important period in his life, which I'm sure changed him. We can only speculate. But I'm sure, that changed him a lot. He came back. So many people who go to Oxford never come back. Here was Professor Ranjit Roychowdhury, who chose to come back. And at that time, this was in the late 1950s, that he joined the All India Institute. The institute had just been set up. And he joined it as an assistant professor and started teaching at All India Institute. 2 years at All India Institute, he's in the center of the country in New Delhi. And then he leaves. In 2 years, he leaves All India Institute and joins Ciba-Geigy. Now, Ciba-Geigy Research Center at that time was a major research center in India, the likes of which we are still to see in India come back. After Ciba-Geigy closed down, the Hearst Research Center closed down, AstraZeneca's research center, many of these international research centers closed down in India. We haven't had one come back to India till Novartis has set up this remote service organization in Hyderabad. But Ciba-Geigy used to be one of the best. He worked in Ciba-Geigy for some 4 years, I think, before he moved to PGIMR Chandigarh. And so he joined PGI in the year 1964 as the head of the department of PGI. And at that time, his age was 34 years. How many of us are already 34 here? I certainly am, almost, a good number. He was head of department of an institute like PGIMR Chandigarh at the age of 34. And of course, we credit him for starting the DM clinical pharmacology course and bringing clinical pharmacology, giving clinical pharmacology the formal position that it has in teaching and as a discipline. But we must remember that he joined in 1964 and the DM course was started only in 1978. So he had already spent 14 years, part of it being the head of department and then dean and then director. It's only when he became the director of PGI, just 2 years before he left PGI, that he was able to start the DM clinical pharmacology course. So I am quite sure that this would have been an uphill task for him. But I also understand that his time in Ciba-Geigy would have given him the perspective that he required to find it so important to start a course which will be focused, at least to some extent, on drug development, of course, also in patient care. So we need to understand how this great person foresaw the needs of the country at that point of time. And then, of course, he moved on from PGI in 1980, moved to WHO, spent the rest of his pre-retirement life with the WHO in various places in Geneva, in Egypt, in Thailand, and so on and so forth. In Rangoon as well, in Yangon. And then with retirement at the age of 60, he moved back to Delhi. And then he was involved, as we all know, because that period was a period when many of us already were associated with him in some way or the other and knew him closely as well. So we know all those things that he contributed to when he was in Delhi. Accolades, there are so many of them. The list is so long that it is very difficult to recount all of them. But the very outstanding ones are the Rhodes Scholarship in 1955, as Professor Tripathi just mentioned earlier. He was the first from India to get that scholarship. The S.S. Bhatnagar Award, this is it's in industrial research. And it was given to him for his, I think, for his work in Ciba-Geigy. Then he moved, he got the B.C. Roy Award, which is the highest award that a medical person, a medically qualified person can get in this country. In 1979, that was when he was director PGI. And then, of course, the crowning glory of it all, Padma Shri in 1998. My association with Professor Roychowdhury was brief and, unlike many more fortunate people, I have not had the opportunity to work intensively with him. However, I did contribute to that Ranjit Roychowdhury committee. He called me on the phone. He asked me to, look at how we could accredit sites. And so I formed this small subcommittee, and there were a few people from PGI, from AIMS, and from other major institutes who were on that small subcommittee. We submitted our report, then it was modified and then included in the RRC committee report, final report. That was in 2012 and going on to 2013. And then because of that association, I was able to, take the liberty of requesting him to be present and be our chief guest at a DIA conference we had in Bangalore. That very year, 2013. And I remember the episode, as the person who started the DM course from which I benefited, and also being the person who set up the department of PGI, Chandigarh Pharmacology. I thought, and an eminent person like him, it was obvious to me that, the tickets that I do for him should be a business class ticket. So I got business class tickets for him to Bangalore. And then at the venue of the conference, he met me, and the first thing he said, "Why did you buy business class tickets for me?" So, I was expecting a hello or something like that initially, but he just reprimanded me on that. So, "Why do you buy business class tickets for me?" I said, "Sir, I mean, a person like you, I can't have, it would be amiss of me if I did not do that." Then, no, I travel in economy class, and on the way back, please return this ticket and get me an economy class ticket. And that's exactly what he insisted on. So a person so down to earth, and yet his achievements are, something that we can only aspire to. So that much about him. I want you to remember that that clinical pharmacology and the person who thought about clinical pharmacology in this India, in this country, and started the movement in clinical pharmacology, did have patient care as well as, I think, the needs of drug development in his mind when he went about putting this course in place. So let's look at clinical pharmacology in India over the years. My topic today is, and let me just recount the topic, perspectives and prospects of clinical pharmacology in India. We've talked a lot about this. I hope I'll be able to summarize this and bring it together. The time for my presentation initially I saw on that was 15 minutes. Obviously, I can't do justice to this topic in 15 minutes, but hopefully I'll be able to finish in half an hour. As we said, clinical pharmacology was named a distinct specialty in this country in 1978. It's not as if other people did not contribute to clinical pharmacology here before that. Many people did, many people here in this city in Calcutta. But in 1978, because of that clinical pharmacology DM course, it became a distinct and recognized specialty. Most candidates thereafter remained in academia in the 1980s, but from the 1990s, the candidate count reached double digits only in 1990. So over 10 years, there were only 10 DM clinical pharmacologists coming out from PGI Chandigarh, which was the only place where that degree was given out. And by 1990, there were I was the 11th person, and thereafter, of course, we have two others who were contemporary with me at that time, Professor Biswas and Professor Tripathi. And then the movement to industry and the things, the important tools and skills that are taught to clinical pharmacologists that are so important for drug development began to be recognized. And this was at the time when India opened up to international clinical trials. So in 1995, we had two major events. One was the ICH guidelines being accepted by the major regulators across the world. So clinical trials done anywhere in the world would be accepted in the major markets. Together with that, of course, the pharmaceutical industry worldwide thought that India might be a good place to do clinical trials. And many of them, particularly, it so turned out that I was at that time working in Pfizer, and Pfizer was one of the first industry groups to start clinical research on a global scale here in India. So the movement to industry began, and it really gathered pace in the early 2000s. The course demand, therefore, and the demand from industry increased during the first couple of decades of this century. And therefore, more courses were set up, DM clinical pharmacology courses across the country in KEM and All India Institute and other new AIMS institutes that came up across the country. The diversity of opportunities as well as the complexity of the science has increased manifold in recent decades. So globalization and harmonization of regulations, growth and diversification of research within industry in India. So now it's not just, clinical trials, but there are many other things that clinical pharmacologists can contribute to within industry. Advancements in genetics and human biology have made the subject itself pretty complex. And rapid rise of information technology and data science, I think, opens up new opportunities for the future, which, of course, the youngsters in the audience should take note of, because that is really going to be the future, and clinical pharmacologists have to gear up to that. Now, I see clinical pharmacology today in India and perhaps elsewhere in the world as well as 2 or 3 distinct sections. One is clinical pharmacology for patient care. The other, of course, is for asset development, drug development, you can call it, but I call it asset development because medical devices are also included, other types of, so a product is often called an asset that you have to develop before you can give it returns. And of course, drug regulation is a third area where contributions can be made by clinical pharmacologists. So we are talking of patient care, asset development, and drug regulation. I will not talk too much about drug regulation. most of my slides are on patient care and asset development. And under patient care, there is this area of clinical pharmacology consultations, where I think clinical pharmacologists here in this city have really started a movement which many people have mentioned should hopefully be replicated in other parts of the country. Evidence-based medicine, that's another key area where I think clinical pharmacologists must contribute. Health informatics, as I said, and I will talk a little bit about this as we go on, and research leadership. So here you see that it starts with certain things that are very specific to clinical pharmacologists that only clinical pharmacologists can probably do, such as a clinical pharmacology consultation. You need to be trained in this subject. But as you go down this list, some of these things are not, the core domain for a clinical pharmacologist, but the area is open to clinical pharmacologists, and I think clinical pharmacologists possess the skills to excel in those areas and take those areas, take leadership positions in those areas. When we come to asset development, and here we are talking to an extent of industry, but of course, both these, patient care and asset development, it is not as if some of the things that we might need to do under the patient care head are not done by people in industry. They need to have those skills as well. And on the other hand, the things I've listed below asset development are also done within hospitals, particularly the operational parts of that. So while there's some kind of a division between the left side of this slide being more about hospitals and academia, and the right side of this slide being more about industry, but there is a good bit of overlap. So asset development is development strategy. Clinical pharmacology. Now, this might be confusing because clinical pharmacology is the name of the entire domain, but also there's something called clinical pharmacology, very specific to industry, which is about early drug development, phase 1 volunteer studies, and we'll talk about that also. And finally, development operations. So, patient care, let's look at that first, and the clinical pharmacology consultation. The use case, when does clinical pharmacology consultation become so important? It becomes important in the clinical pharmacology clinic, where you might want to take that consultation, or individual patients can take that consultation. And that would be for therapeutically complex cases where there is polypharmacy, there are multiple underlying disease entities that the patient is suffering from. Unusual responses to therapy, treatment emergent effects, including side effects of various kinds. That's probably the general use case for a clinical pharmacology clinic. Therapeutic drug monitoring is another area where clinical pharmacology consultation is important, and people in the audience here, Smita particularly, is very well versed in that area. And this is something that, key centers in clinical pharmacology have been doing exceedingly well. However, this is not something that is happening generally across the country in all clinical pharmacology units. And this probably should, in the future, progress should be there in this direction. More and more, there are some various specific therapies that benefit from TDM. And this skill has to be a general skill that all clinical pharmacologists should begin to have. Individualization of therapy, as we get into into genomics and into understanding the complexities at the molecular level of the newer treatments that are coming into use. Individualization of therapy will become more and more important. And we've been talking of that for more than a decade now. However, we don't see it happening in most disease areas, except perhaps in oncology at this time. However, it is going to move from oncology to other clinical domains, over the next few decades. And I think that is one area, again, because of its complexity, that clinical pharmacologists can contribute to. Now, all of these things require a knowledge base. So we come back to, if these are the services that we as clinical pharmacologists would want to provide, then what is the knowledge base that those clinical pharmacologists need to have? So knowledge of drug interactions, PK/PD interactions, food-drug interactions, traditional medicine interactions between traditional medicine and the modern medicine tools that we use. All of those clinical pharmacologists should be well versed with. And the last of these, interactions with traditional medicine, is something that only we can do here in India, because that's where traditional medicine is used. So this is a great area for research for us clinical pharmacologists. And I think, people should take that opportunity and work in this area to see what kind of interactions do happen, and what precautions, what consultation one should give to patients who are, taking both at the same time. Dose effect and PK/PD correlations, mechanism of action and off-target effects, pharmacogenomics. These are some of the things, the knowledge base that one needs to have to be able to provide consultation in clinical pharmacology. So what's the scope? I think the scope of this is very large. Clinical pharmacology consultation, I've used that word. What it means is, one, to offer consultatory services to other specialties across your hospital. But it also means that we can put together training modules. For example, we hear Shambhu and other colleagues here in Calcutta talk about case studies. A patient came, this is what happened to the patients. Cannot we compile a tome? And over the years, I think more and more such cases would accumulate, and we should have, somebody should write a book about this. And my request is to Professor Tripathi to start this around with the people who are doing practice, as well as clinical pharmacology practice, I would call it, here. Books and publications, we need to take this to the next level. Yesterday, we were talking in that discussion that we had about the need to build awareness and also to bring visibility to clinical pharmacology. How better to do that than to have useful books that would be of use to other specialties across your hospital? Books and publications, analysis of big data. So now many of us are working in private hospitals, and some of us are working in government hospitals, which do have some degree of electronic data available. Now, most big private hospitals are moving towards capture of patient data electronically as electronic health records. And over a period of time, and I'm currently working closely with the Medanta hospitals, and I'm trying to get them to understand that we need to remain with patients for a longer period than the short period that they are associated with the hospital. A patient comes to a hospital, gets registered, and his record gets into the hospital HIS, the hospital information system, and thereafter that patient might be an outpatient or an inpatient. Even if that patient is an inpatient, he's with the hospital for, probably he or she is there with the hospital for a period of maybe 7 days, 10 days, 12 days, 15 days. Then that patient leaves. And then you lose that patient for a period of time. If the patient comes back, maybe the same registration number is used. However, we do not have, that patient might go away somewhere else. That patient might have come from a great distance, and some local person is following that, local physician is following that patient up. Unless we can keep track of what's happening to this patient over some electronic system, we are losing that patient. We are losing the data of outcomes of that patient. What happened to this patient over a longer period of time? So that is one. But of course, even the short period connection that patients have with hospitals and the data gets into the hospital information system can be analyzed. This is big data analysis for which you need to have some familiarity with data science. And of course, clinical pharmacologists will never be doing this full-time themselves. It will be data scientists who will be doing the work, but it will have to be clinical pharmacologists perhaps who have to direct these data scientists to do the analysis and come out with associations which would then give you ideas for further research, case control studies, signal detection, and so on and so forth. Now, that brings me to the next slide, evidence-based medicine. Now, evidence-based medicine has emerged as a distinct cycle of research activities that has begun to drive the evolution of medical practice. We all understand that by now. What does that mean? We usually think of evidence-based medicine as meta-analysis and getting some conclusions out of one meta-analysis project. Obviously, that is the centerpiece of evidence-based medicine, and clinical pharmacologists need to be well versed in the techniques of meta-analysis, which is a little more complex than just analyzing a single study. In fact, it's quite complicated if you want to do it well. But meta-analysis is only the central piece of this. I think it starts with the identification of gaps in evidence. When you look at a particular aspect of therapeutics and you want to determine whether something does or does not help in this particular outcome, and you look at the data, there'll be many times that you will come across gaps in evidence. That there is no evidence, there is no good evidence, and yet we use it or we don't use something. Once you identify those gaps, you need to go on to designing and conduct of studies to generate the evidence that is required. Now, that's not always easy, but many times it is indeed easy. It's only that nobody has thought about it. And then it comes to the evaluation of all the evidence that is available across the world through meta-analysis, and then the compilation of that evidence and recommendations coming out from the compilation of all the evidence that goes into treatment guidelines and so forth. But once that those treatment guidelines are there, you need to see whether these treatment guidelines are leading to change in outcomes, improvements in outcomes or not. And if they are not, then you go back again in that cycle to looking at what gaps you still have in the evidence and how your guidelines can be improved. And of course, those are informed by new therapies that are coming in. The required skills in this area is the assessment of study designs, evaluation of quality of evidence, the various grades of quality of evidence, meta-analytical techniques, biostatistical techniques, research methodology, and technical writing skills, all of those. And these are, once again, therefore, skills that clinical pharmacologists must have. Now, health information analytics, I just spoke about this, about the hospital information system, electronic medical records, as well as registries. A lot of clinical groups work with registries, so they are more restricted than the whole gamut of hospital information that might be available. Registries are only for a specific disease. But then from those registries, you go on to analytics. Now, I'm not sure that the analytics is happening so well. A cardiologist might have a heart failure registry. And the cardiologist is only looking at what is of interest to cardiologists. Now, I'm not saying that the interests of cardiologists are any different from or should be any different from those of clinical pharmacologists, but the clinical pharmacologist has a slightly different angle to look at that same data. And I think would be a good partnership for the cardiologists to have with the clinical pharmacologists in the analysis of these registries. Once these analytics are done, you have the insights, and that gives you research ideas. And from those insights, you can develop predictive models, screening tools. These are not being done at the present time. These registries are not being properly used. I think I've had some experience with that at Medanta, but I see that there's a lot more that can be done. Signal detection, as far as pharmacovigilance is concerned, is very much within that. So signal detection today is done by big companies for the medicines that they sell based on the adverse event reports that come to them. However, signal detection, I think, can be done in a much better way when you have access to a hospital information system and you have the outcomes of patients in front of you and the medicines that they took. And of course, pharmacoeconomic analysis, because hospital data also has economic data. And pharmacoeconomics is certainly within the central domain of clinical pharmacologists. Skills that you require, once again, we are going into areas which are traditionally not part of clinical pharmacology, but I think they must begin to be now. Some basics of these things must be taught in clinical pharmacology in future. Big data analytics, statistical methodology, of course, we always did learn a bit of that. Pharmacoepidemiology, pharmacoeconomics, research methodology, again, pharmacology and specialty medicine. These are some of the areas and skills that you require to do justice to health information analytics and the clinical pharmacologist's role in it. The explosive growth of data science and artificial intelligence will deeply influence medical science and practice, particularly impacting clinical pharmacology and therapeutics. Go on to the next slide on patient care. We are still on patient care. But here we are coming to research support and leadership. So as the predominant source of clinical material in the form of patients, biological samples, medical imagery and data, it is the moral duty, I think, of healthcare institutions to contribute to the advancement of medical research. So institutions, healthcare institutions that are not contributing to research, I think are not in the morally correct position. They are the custodians of a huge amount of data, and it is imperative for them to contribute to medical research and to progress research and healthcare. They are not doing the full spectrum of service to humankind just by treating patients. They must participate in research. And that participation, I'm not saying that that does not happen. Almost, particularly in teaching hospitals, almost every physician participates in some kind of research. But that research needs to be organized. That research needs to be ethical, of course, and it needs to be efficient. So what I'm saying is that the individual research that individual physicians do in hospitals is not sufficient. That it needs to be a hospital-wide program, that the hospital-wide program must be directed towards certain specific goals. And of course, ethics is, I think, reasonably well managed through ethics committees, etc., but it needs to be efficient as well. I think the research that individual researchers do in hospitals falls short of the extent of efficiency that can be achieved. And I think the clinical pharmacologist is best placed to lead this effort within hospitals. One way to do that, or to begin to do that, and be recognized as somebody who can lead this effort, is to provide institutional research assistance and to form a unit. And perhaps the clinical pharmacology department or sub-department can probably be the center for this, an institutional research assistance unit. And that research assistance unit would have a lot of things to do. It would provide research methodology training. It would provide a grant proposal writing assistance. It could provide regulatory assistance. Yesterday, we were talking about it, and I think Professor Sandhya talked about it, that most researchers don't have any idea of what regulations impact their research. So regulatory assistance. Research ethics administration, including ethics committees or scientific review committees, research policies and strategy. So when I'm saying that individual researchers doing their own bit of research is not sufficient, we must bring it under a larger umbrella. Then what I'm saying is that there must be research policies and there must be research strategy within each institution. And then the research that is being done across the institution must be monitored and tracked. At present, academic research is not monitored at all. So individual researchers are doing it, and everybody assumes that it's being done well. But we can never be sure of that. So for anything to be published today in international journals, you require to certify that these have been done according to good clinical practice. And good clinical practice requires monitoring. And we do not have monitors. So it could be that the clinical pharmacology unit provides monitors, what are called CRCs in industrial parlance, the clinical research coordinators. In industrial setting, there are CRAs who do that job when it's a CRO overseeing this research. And then the data management and analysis, once again, at present, individual researchers do it in a manner which is now becoming more and more archaic. It needs to be done in a much more organized manner on electronic systems. So data management and analysis, and finally, publication support. So these are some of the services I think we can provide to bring visibility to the clinical pharmacology department in a form which gives it, preeminence in the research area and provides a service as well as gives an opportunity for the clinical pharmacologist to serve as a leader in this area. Now, those are some of the things that clinical pharmacologists can do within hospitals. So while we have been discussing all about how relevance of clinical pharmacology, I think those things can bring that relevance in. Now, let's look at asset development and what happens within industry, but of course, can also happen within institutions, medical institutions. I want to first talk about the clinical pharmacology unit. Now, the clinical pharmacology, many people here know about this. There are two pictures here. You see on the top, a clinical pharmacology unit. This is a picture taken from KEM, clinical pharmacology unit. And many people will recognize this one. And the one below is the bioanalytical section at CMC Vellore. So those are pictures taken from Indian clinical pharmacology units across the country. So some units are doing great work. The clinical pharmacology unit is a unit where volunteer studies happen. Of course, patient studies can also happen there. It's not as if, but it's specifically geared towards volunteer studies. And study design, study management, interpretation, and reporting are some of the things that are the specific responsibilities of that unit. And there are general responsibilities: study oversight, study organization, quality oversight, volunteer management, staff management. We are talking of phase 1 trials and VAB studies, basically. So let's be clear about that. Very important part of drug development. Once it goes through preclinical evaluation, and you know that we have the data that if it is given to humans, humans will not drop down dead, and they will not have severe adverse events which will threaten their lives. So once you know that it is safe to give to human beings, you come to phase 1, and that is a key and critical area. 30% of drugs get dropped off from the pipeline at phase 1 because of problems with pharmacokinetics and sometimes other kinds of problems, but mainly with pharmacokinetics. It's in phase 2 that they get dropped off, and phase 2 is even worse. 50% of the pipeline gets dropped off as phase 2, and that's mostly because of lack of efficacy. The specific training, and this is one area in industry where you cannot do without clinical pharmacologists. You require clinical pharmacologists and clinical pharmacologists alone. Right now, indeed, there are clinical pharmacology units being run with people who are not DM clinical pharmacologists and who do not have that much of formal training in clinical pharmacology. They have picked it up and they've been trained by their institutions and their companies. But I think this is a specific domain of clinical pharmacology, and if we can't kind of dominate this area, then what clinical pharmacology are we talking about? Pharmacokinetics, pharmacodynamics, one needs to know clinical science, one needs to have medical knowledge. Pharmaceutical science is important. You need to understand about the medicine and some pharmaceutics of the medicine, drug dissolution, drug dispersion, ADME, of course. You need to understand in detail drug regulation, research methodology, and research ethics. So all of this comes into the domain of running a clinical pharmacology unit. General skills that are required. Now, somebody who's heading a clinical pharmacology unit, and I am imagining that it's a clinical pharmacologist, he or she needs to have an understanding of instrumentation, because a major part of a clinical pharmacology unit in phase 1 studies is the bioanalysis. It's all about pharmacokinetics. So that person needs to have some good idea of instrumentation. Now, that does not come easily in the pharmacology departments. Even when there is an HPLC or an LCMS, the medically qualified people, it's the the technicians or the PhD students or the MSc students that are actually handling that apparatus. It's not the medical graduate who's doing that, and I think that needs to change. They need to have hands-on experience with these instruments, laboratory science, good laboratory practice, basic economics, because when you're running a clinical pharmacology unit, you need to be cognizant of what salaries are being paid, what is if you're in an industrial setting, of course, somebody is paying for that study. So are you getting remunerated? What should be the pricing, etc. People management, because people would be reporting into you, and crisis management, because crises do happen in clinical pharmacology units. I'm going a little fast. Asset development, again, we are on that topic, and clinical research operations. Here I would like to say, we see a lot of clinical research operation in this country right now. Clinical trials are being done. A lot of them are being done. Obviously, this is a big country and we can do many, many times more clinical research than we've been doing in the past. But what is being done currently is mostly clinical research operations. So often protocols for new therapeutic entities are being written abroad by the sponsor, and they're being implemented in our hospitals. The clinical pharmacologist does not really have a central or essential role in clinical research operations, except for some of the things that I'll talk of in a moment. Yet, clinical pharmacologists with the right skills can add value to leadership roles in clinical research operations. If you go to a CRO today in India, you will find very few medical people. Forget about clinical pharmacologists, very few medical people. And those medical people are slotted into a medical department. And that medical department has a very circumscribed role, not a very big role. They are not in leadership positions. That's because the general skills that they need to have do not exist. They have grown up as pharmacologists doing research on laboratory animals. And then, of course, they are medically qualified people, so they understand medicine as well. Many of them are not even pharmacologists. They are from other medical disciplines. And they do the role of medical monitoring, which I'll talk about in a moment. But I think there's no reason why they should be confined to the medical department of a CRO. They should be the leaders within the CRO. They should be, the chief operating officer and heads of various divisions within an organization, a commercial organization. So clinical pharmacologists should see clinical research operations as an area of opportunity to gain valuable experience in asset development. Now, I have seen that when you offer a job in clinical research operations, such as a CRA's job, these days in India, medical people don't consider that as something that they would like to take up. Obviously, at the starting level, salaries are not all that good, and probably there are better opportunities for medical graduates there. However, a CRA's job is the best place to start understanding the area of research. And 2 years or even 1 year as a CRA will equip the medical person with knowledge and skills that they need to have, an understanding of the process like no other role. And then you can grow on and go on to specific medical roles and specific leadership roles. But this could be a good starting area. The role of the clinical pharmacologist in clinical operations is in the area of protocol development. Of course, often somebody else, clinician, will also have to be involved. Protocol training, this is often done, and it's not only the clinical pharmacologist, it could be any medically qualified person can do all of these things. And that is why I said that it is not the specific domain of a clinical pharmacologist. So protocol training, medical monitoring, and medical monitoring is a very, very important job, which I think is underplayed in the industry. Medical monitoring is all about looking at the medical data that is coming in a clinical trial and looking and seeing that data, and without the aid of analytics, without statistics, without actually analyzing that data, just by looking at that data to make out that there is something wrong with this patient here. There maybe, he got a wrong dose. Maybe the inclusion criteria were not completely followed. You can just look at that data and you can, a qualified and experienced person will be able to make out what's wrong with that data and what's going wrong with this trial. So medical monitoring is all about that. Event narratives, so adverse events and the writing of what happened to that patient can only be done by a medically qualified person. The data interpretation, reporting, publication, and the skills that you need to have are all listed here. Good clinical practice, research ethics, medical data evaluation, narration, summarization, all these things. And these need to come into clinical pharmacologist's curriculum. And lastly, strategy. Request to those online at this time, please keep yourself muted. So this is my, I think, second last slide. Strategy. So now we are talking of having come away from clinical pharmacology in industry and clinical research operations. We are now talking of clinical research strategy in an industrial setting. And here again, I think the clinical pharmacologist is well suited to lead in this area. The responsibilities are as follows. Somebody who's responsible for strategy must be able to evaluate preclinical data. Now, this is a very interesting area because what happens is that 80% to 85% of the new product pipeline that is there within the industry is coming out from small organizations. These are not the big Pfizers or the GSKs or the Novartises of the world. 85% of new molecules are discovered either in a university setting or in a small industrial setting. And now, those people do not really, often these are chemists who have discovered the molecule, or they're researchers who know very little about the disease process itself or anything else about it. They know about the molecule that they have discovered. So the clinical pharmacologist brings medical knowledge, understanding of how to develop the product, the regulations and all of that. And believe me, I consult for a number of organizations. I find that there are people like, bench scientists there. There are people who are investment bankers because they bring in the money for that development. So they have the money to do the development and they have the science to develop the molecule. Thereafter, they don't know anything about development. And so the insights I can give them and the route that I can show them for development is very valuable to them. But for that, you require certain knowledge and skills. What are those knowledge? So pharmacology, toxicology, obviously, but regulatory science and global regulatory science, it's not sufficient to know what the CDSCO will ask you, because you have to sit in meetings with the US FDA. And the US FDA you have to ask the questions, US FDA will give you answers, but you have to be able to understand those answers and why they are giving you that. And sometimes, if the questions that you ask are silly, then they will give you silly answers. So, regulatory science. And I think not enough emphasis is there on that in our curriculum these days. Therapeutic area knowledge, pharmacometrics. Pharmacometrics is an interesting area. Pharmacometrics is a global kind of thing in which you look at PK, PD and things like that, but also ultimately evaluate whether this drug is worth approving or not. So the word has come out from the US FDA, so they have looked at it from their point of view, but companies and people running strategy in pharmaceutical companies need to be able to evaluate whether this product is worth taking forward or not. So that's called pharmacometrics. You, of course, need to understand clinical sciences, which is methodology, ethics, and practical considerations. This is very important, practical considerations of whether this study can be done or not. So in years to come, as innovation becomes an integral part of the pharmaceutical industry in India, which it still is not, some of the big companies are doing this, professionals skilled in development strategy will be much in demand. Clinical pharmacologists are best placed to meet this demand. So that's my last slide. I think the prospects for clinical pharmacology in India are bright, provided we orient ourselves to the opportunities and equip ourselves with the skills that the future will demand of us. So my presentation was basically to give you an idea of what we might need in the future and hope that people, middle-level people who are coming into positions of responsibility today are able to see this and able to orient our teaching to these opportunities, and that the youngsters are able to see these opportunities and prepare themselves for it. Thank you so much. It's been such a pleasure to and such an honor really to give this oration named after a great person like Professor Ranjit Roychowdhury. Thank you all very much. Any questions that I can answer?
So this being an oration, we are not allowing any question. But then I think it was unquestionable, the presentation. Okay. And so eloquently you have articulated that it is really particularly for the youngsters, for the newcomers. Yesterday we had experience that many of the young people who have joined clinical pharmacology, there was so much of confusion and there was so much of the so-called identity crisis. But then listening to your lecture today, I think you have clarified that where are the problems lying right now at this moment and how we should take it forward. What are the challenges ahead of us? And the way you have actually explained that these are not something which is unachievable to most of us. So there is no place for any kind of despair or frustration, and the prospect and the future is quite bright, which our orator today, Dr. Shoibal Mukherjee, has so nicely explained. And the more I hear Dr. Mukherjee, okay, it's a pleasure really to hear Dr. Mukherjee. It's a great way you have actually summarized. I understand that the organizers had given you 15 minutes, but when somebody is talking sense, there is no point in interrupting. In fact, it was great listening to you. Thank you very much. I has always been a great admirer of Dr. Mukherjee. So my respect and reverence to you increases every time I listen to you. Thank you very much, Dr. Mukherjee.
Thank you.
Madam is there, Dr. Thatte, I think she has left. She already sent a sent a message that she has some other commitment. So that's why I took this opportunity. So I thank you again, sir. So now we'll end this session by watching a brief video on Dr. Ranjit Roychowdhury again. Please.
For all of us, we believe that traditional medicine is on its way back to becoming the center point of therapy in India. And as I look after also the 10th country in the WHO region in the World Health Organization. How to prevent litigation. That's all what we want. We want our doctors to work in peace and not in harm. We want our patients to be happy. You cannot, based on my experience, you cannot regulate antibiotics. You cannot legally do it. You can try. It has to be from within. Yes, it has to be from within the industry. It has to be self-regulation. There is no other way in the long run. And that is why a code of conduct is so very important. Insurance in this country, we are aiming at providing 50 drugs, including diabetic drugs, as far as possible in number free to every citizen of India from birth to death.
So let me conclude this session. Just reminding ourselves that we are proud that Professor Ranjit Roychowdhury actually ancestrally hailed from this city. His ancestral house is only maybe 30 kilometers, 40 kilometers away from this place where we are standing today. That place is called Behala, Barisha. And he hails from the Saborno Roychowdhury family, which has a huge, great heritage in Bengal. And I think just one year prior to his death, he left us in 2015. He came in 2014 and he gave me the responsibility of visiting his relatives in his place. And then we spent a couple of days together in 2014. And I was accompanying him, and there was a ancestral temple of his which we visited. So it was a great memory to many of us who were fortunate to accompany him and share some few moments. He was, the other part of his personality is he was hugely affectionate, so smiling, and I have hardly seen him to express his annoyance, to be angry with anybody, to shout at anybody. He was a great personality. So thank you, sir. Your blessings will be always with us, and we'll take this association forward. Your life always reminds us what commitment we should fulfill towards the society. Thank you again. Thanks.
Next, we would like to inaugurate the abstract book for the conference. And for this occasion, I would like to invite our all respected dignitaries onto the stage. First, I would like to invite Professor N.R. Vishwas sir to please come to the stage. Professor Debashish Hota sir, please. Professor S.P. Dhaneria sir. Dr. Sanish Davis sir. Dr. Shoibal Mukherjee sir, and respected Professor Santanu Tripathi sir. It is a proud honor to inaugurate the abstract book for the second conference of the Association of Clinical Pharmacologists of India. Thank you so much, sir. We'll continue with the program, sir.
So So now we are moving towards the next session. And that is, initially we thought it will be on diabetes and clinical pharmacology because of some changes, some emergency happened to one speaker. So we had postponed that session. And tomorrow we have a talk from Professor Usha Rani Pingali, madam. We had preponed 2 talks. One is this session will be 2 lecture session. One is by Dr. Anand Srinivasan and another is Professor Debashish Hota sir. So may I invite now to chair the session, Dr. Shoibal Mukherjee sir. Would you please chair this session? And in the meantime, I just want to thank Professor Nilima Khirshagar, madam. Madam has made a comment in the chat box that congratulate Shoibal sir for his wonderful lecture. So thank you, madam. So we'll hear from you also in the session that is the theme lecture for this conference. We'll wait for that. So now I request Dr. Shoibal Mukherjee sir to start this session.
It's on. We've just crossed 12 o'clock, so good afternoon, everybody once again. We have 2 lectures in this session. The first lecture is, give me a second, please. Yeah, the first lecture is by Dr. Anand Srinivasan, Adaptive Clinical Trial Designs. Anand is an eminent clinical pharmacologist who I have had the good fortune to interact on several occasions. And every time I listen to him and his hold on the newer areas, some of the areas that I talked about in my lecture. So like Shambhu, Anand is another person that I'm always inspired by, and it will be a pleasure to listen to him. Anand, you're up for the first lecture.
Thank you, Shoibal sir. And I also thank the organizers for providing me this opportunity to talk on this topic, adaptive clinical trials. So let me move into the topic directly. So first of all, when we talk about adaptive clinical trials, of course, we can understand a lot of theoretical aspects of it by going through any review articles. Okay, but when it comes to the implementation and of adaptive clinical trials, especially in the academic settings, so people think that this is a domain of big pharmaceutical industry where we cannot do adaptive clinical trials, and it's just of some theoretical relevance to them. But here I just want to give our experience in conducting adaptive clinical trials in the academic settings. We'll share our own experiences. Of course, I'll also include certain other theoretical concepts which we have not yet involved in. So with this, let me go into the topic. So, of course, this audience does not need an introduction of what is the definition of a clinical trial, but still anyways, I'll go through it. So it's any study which assigns the participants randomly to interventions and evaluate the effect of these interventions on health outcome as per WHO and many other clinical trial definitions also convey the same message. However, when we talk about adaptive designs in clinical trials, okay, first of all, let us look into the traditional fixed sample design. What happens is whenever we start conducting a clinical trial, of course, we design a clinical trial and then execute it. Okay, so we plan and execute it as per the protocol. The protocol does not allow any flexibility during the course of the study. So that is the traditional fixed sample design. However, when we talk about the adaptive designs, okay, so we incorporate this flexibility itself in the protocol. Basically, studies as per the outcomes during the course of the study, the design will be altered as per the rules pre-specified in the protocol. So basically, we design the study, we conduct the study, we review in between, and then adapt and change the design of the study a little bit, and then move forward until the final analysis is done. So it has a lot of this concept of adaptive clinical trials has a lot of advantages. Of course, any concept with advantages will have certain disadvantages also. We will come to that later. Okay. So to reiterate, any clinical, any design which allows the change in the course of the study based on its performance in accordance with the pre-specified rules, which is what I was mentioning until now. Okay. So if we look into the broad categories of clinical trials, we can, divide them into parallel studies, crossover studies, and factorial design studies. However, when we look into the adaptive trial designs, it's usually applied in parallel designs. I'm not saying that it cannot be applied in crossover and factorial, but if you look into the publications, many of the adaptive trial designs will be adaptive designs will be based on the parallel designs. And let's also consider the other aspects of designs, which are randomization, allocation concealment, blinding, control, single and multi-center. These are the other considerations of when it comes to designing clinical trial. Of course, again, this audience does not need any explanation for this. In the other aspects of the designs, only randomization is where we can adapt and take the trial further. Now, there are innumerable types of adaptations, but all the adaptations are based on certain basic adaptations, which I will enlist now. We can, build other adaptations based on whatever the adaptations which I'm going to display. The first is group sequential testing. The second is adaptive randomization. The third is continual reassessment. Fourth is sample size re-estimation. Fifth is multi-stage design. And the sixth is population enrichment. Okay. So we will see one by one. We have experiences in group sequential testing, adaptive randomization, and continual reassessment. However, we have not yet tried the sample size re-estimation, multi-stage, and population enrichment. So first, let us talk about what group sequential testing is. So group sequential testing is nothing but explaining the concept of interim analysis in a deeper manner. Okay. So basically what happens is, so we do interim analysis in a group sequential testing based on or to determine or to evaluate either the efficacy, that is how much the drug is or experimental therapy is working. Futility, that is how much that is whether it depends on futility means that the drug is not working, and safety, it's understandable what safety outcomes are. Now, when we talk about the group sequential testing, it's always about alpha spending. So alpha spending is nothing but a concept where whenever we perform analysis multiple times in the same study, the concept of accumulation of alpha error over time has to be reduced so that all the analysis together will contribute only 5% of alpha error. So we spend certain amount of alpha at every analysis. Okay. So that is called alpha spending. So this concept of alpha spending can be defined by either Pocock's function or O'Brien's Fleming function. Yeah, we'll come to that. Okay. And this concept can be applied for your beta spending also, because both are different types of errors and it has to be distributed across various assessment points so that the cumulative alpha and beta remains the same as per our design. Now, generally, alpha spending is for efficacy parameter and beta spending is for futility parameter. So that's what the group sequential design dictates. So this is our one of experience in conducting an group sequential method, wherein we compared the in one of our students' thesis, Dr. Gayatri's thesis, where we saw. Let's say we will not look into the scientific aspect of it, but let's consider we had an experimental group and control group for a regimen evaluating the management of chemotherapy-induced nausea, vomiting. So in that clinical trial, what we did was we had planned for a total of 3 analyses. So the total sample size of the study was 94. So we can see that we have defined our So here we defined both the efficacy and futility boundary involving alpha spending. The red line is alpha spending and the blue line is beta spending. Okay. So basically the y-axis, the x-axis mentions the sample size which has to be achieved for the various interim analysis. So we had designed that the first interim analysis will be done at 44 and the second at 70 and the last at 94. And on the y-axis, we have the critical value or Z values. Okay. So basically, so whenever we talk about group sequential testing by defining alpha and beta boundaries, we always perform a one-sided test. It's 2 separate one-sided tests for both alpha spending and beta spending boundaries. So whenever both the Z values falls between these 2 boundaries, we take the study forward. And whenever there is a breach on either side, we stop the study. Okay. So if the Z value crosses the red line, then we stop the study because of efficacy. And whenever the Z value crosses the blue line, we stop the study because of futility. Okay. Here we didn't consider the group sequential testing for the safety part. And that's allowed, not an issue. So the thing is that this study is already completed, and we had to stop the study at the second interim analysis because the endpoint crossed the futility boundary. So basically, our experimental therapy was as good as the control or the standard of care. So this is one of the experiences in our group sequential testing. So next, we will go into this adaptive randomization part. So adaptive randomization can be either or can follow either the frequentist approach or the Bayesian approach. Okay, right. Now, when we talk about the adaptive randomization, what is the principle behind this adaptive randomization? The principle is being to reduce the exposure to ineffective treatment. Okay, so we adapt the randomization based upon the, so we, that is, we change the randomization. That means we change the allocation ratio favoring the better response group, of course, in a blinded manner. The procedure is the allocation ratio is changed as per the response, and the setting is can be both Bayesian and frequent test. Okay, so we have not done Bayesian adaptive randomization until now, but we have tried frequent test approach in adaptive randomization in one of the other thesis. Again, this is also, we had an experimental therapy against a control therapy for the management of chemotherapy-induced nausea vomiting by Dr. Madan. His thesis is also completed now. So this is the basic framework of adaptive randomization, which is combined with actually group sequential method. Okay, basically here we have, it's a combination of two adaptations. That is, we had combined both the group sequential method along with the adaptive randomization on a frequent test framework, not on the Bayesian framework. Okay, so what happened was, so in this study, there were 4 analyses, that is 3 interim and 1 final analysis. At the end of each interim analysis, we saw what the Z value was for efficacy. So this, again, this adaptive randomization was planned only for the efficacy outcome. So if the Z value at the end of the first interim analysis, if any interim analysis falls less than 1, then we did not change the allocation ratio. If it was 1 to 1.5, the allocation ratio change was 1 to 1.5. If it was from 1.5 to 2, the allocation ratio was changed to 2. And if it was greater than 2, the allocation ratio was changed, has to be changed to 2.5. Right. So, and how to change the allocation ratio? Because if you all understand the principle of the allocation ratio, whenever the allocation ratio is changed, actually the sample size itself will change. Okay, so how we will have to change? This is the way where we change the sample size based on the allocation. Now, again, as I told previously, this study had both the adaptive randomization part and the group sequential part incorporated within the same study. So in this study also, we can see that the total sample size was 84, and we had 3 interim analysis planned, 1 at the end of 30, 1 at the end of 47, and 1 at the end of 66. And if the Z values for both of these fall between these 2 lines, we will carry the study forward. And if the Z value breaches the boundaries, then we will stop the study, right? So in this study, what happened was, at the end of the first interim analysis, the Z value fell between 1.5 to 2. So we had to change the allocation ratio to from 1 to 2:1, where we that is we had implemented the adaptive randomization on the frequent test manner. And at the end of second interim analysis, the the experimental therapy breached the efficacy boundary, and so we stopped the study. So in the first study, we stopped the study because of futility, and in the second, even before attaining the complete sample size, we stopped the study because of efficacy. Right. So what would have happened? How the boundary would have looked? In both the studies, it was like we followed this O'Brien-Fleming boundaries, O'Brien-Fleming function to define the alpha and beta spending boundaries. So this is how the boundaries would have looked if we had defined both the alpha and beta spending boundaries, if we had used Pocock function. Okay. So again, the red line for efficacy parameter and the blue line for futility testing. Okay. So this is just an demonstration of how the alpha is spent at every interim analysis. Okay. So if it is Pocock, we can see that at the first interim analysis we spent 0.02, in the second it is 0.01, third it is 0.009, and fourth is 0.075. So basically, like, it's almost inverted in O'Brien-Fleming function. Okay, so basically, because the sample size is very less, we cautiously spend the alpha. We spend only very little alpha in the first interim analysis. And basically, if you add up all these things, it will become 0.05. So Usually people recommend O'Brien-Fleming more than the Pocock because the alpha is spent really in a small amount, that is conservatively, because the sample size are comparatively less when it comes to O'Brien-Fleming analysis. And I also missed to tell one thing, because we changed the sample allocation ratio to 2:1. The required sample size actually shot up from 48 to 54 because we changed the allocation ratio. Yeah, that's also that's all. That was also one of the change in the study design which happened. Okay, so this is an example where adaptive randomization was implemented on the Bayesian framework, wherein so they had compared 3 anti-cancer regimen in the management of adverse karyotype acute myeloid leukemia. So basically what happens with adaptive randomization on a Bayesian framework is at the end of evaluation of each and every patient based on the posterior probabilities, which are updated based on the response from the previous patient, the allocation ratio is changed. Okay, so what happened was in the study, after the end of 24th, after the recruitment of 24th patient, the third treatment arm was completely removed from the study, and the allocation ratio remained stable after the 27th recruitment, which favored heavily the idarubicin and cytarabine arm. So this is one example for adaptive randomization on the Bayesian framework. So the next adaptation is continual reassessment. That is, again, this continual reassessment is usually done in phase 1 studies. So we helped in designing a phase 1 study. Still, it is not yet started. In this phase 1 study, that based upon the initial data from the preclinical studies, we assumed certain prior probabilities, and then using the empiric Bayesian modeling, we updated the posterior probability for the various doses which are planned in the study. So, and after the end of evaluation of each and every participant or volunteer, the posterior probabilities will be updated based upon the response or based upon the incidence of adverse events from the previous participants. And thereby, the thing is that with this approach, we can achieve the, the 33% ADR rate soon, very soon, because when a dose indicates the probability of, say less than 0.2, we can just skip that dose and go to the next dose. So thereby, the dose escalation will be steeper and fast. Okay. So say, for example, in this study, if the scenario was something like the first dose, there were 2 participants without any adverse events, and in the second dose, there were 2 participants where first had 1 event and second had no event, and if the third patient had no event with the first participant, and the second patient or the third dose had some adverse events, the updated posterior probabilities were something like this, wherein you can see that after the third dose, the fourth dose showed probability of greater than 33%. So it is not advised to escalate to the fourth dose. We should stick to the third dose and start giving the third dose to more patients to fulfill the regulatory requirement. So basically, here you can observe that the dose escalation has happened really fast with less number of participants. So that is what this continual reassessment method in phase 1 studies are about. Okay. So then we have this concept of sample size re-estimation adaptation. And this, what happens is it's straightforward. As it mentions that sample size re-estimation, what happens is that after every interim analysis, the sample size can be recalculated. But the difference is here is in the previous example from one of our thesis, I told that after the first interim analysis, we recalculated the sample size because the allocation ratio was changed. Here, the difference here is Here, the allocation ratio will not be changed, but the effect size will change based upon the interim analysis so that the sample size can be recalculated. So this is one form of adaptation, and it can be allowed provided we define this adaptation in the protocol itself. So there are many examples for this. So I'm not putting in any example. And this adaptation, multi-arm and multi-stage, is actually forms a framework for your seamless transition for phase 2, phase 3 studies. And those seamless designs actually follow this adaptation only. Okay. So usually this adaptation done in dose finding studies. So as simple as that, the dose which is effective is selected and the evaluation is continued in the next stage. And the ineffective dose arm is dropped post the interim analysis. So this is a protocol from a publication where telmisartan and insulin, telmisartan was evaluated for insulin resistance in HIV patients. This trial called Taylor. So here we can see that in the stage 1, they had planned to study all the 3 dosages, that is telmisartan 20 milligram, telmisartan 40 milligram, and telmisartan 80 milligram daily. And in the stage 2, they mentioned that post the interim analysis, they will drop the study arm. And if the drug was very effective and recommended for phase 3, or if they will drop it if the, the dosage was not working, and they will evaluate further a little bit more before recommending it to the phase 3 if the efficacy was between satisfactory and unsatisfactory, so that they can finally decide whether the dosage can be taken up for phase 3 or not. So population enrichment, this what happens is in this design, if you want to, in this adaptation, if you want to put simply, even after the randomization has occurred, the investigator can determine whether the participant can get into the study further or not. So one of the, of course, there are various tools which are used, but however, the simplest example here will be the removal of placebo responders. Here, this is an example of population enrichment adaptation where rizatriptan was evaluated in pediatric migraine. Here, you can see that after the randomization of patients, when they found that there were 100 responders in the placebo arm, so they were removed before randomizing them further with the rizatriptan and placebo. So this is one form of your adaptation technique. So basically, based on these adaptation techniques only, the specialized cancer clinical trials for personalized medicine are being conducted. That is, we have Bhaskar trials, we have Urmila trials, we have platform trials, and these are, if you actually look into these 3 designs themselves, require a big lecture and big discussion. So I'm not going to discuss about these designs, but if we go through the designs of these studies, you can find any of these adaptations being incorporated as the study progresses. So if you look into the actually advantages of the adaptive clinical trials, of course, when it compared to the fixed sample design, we definitely, the amount of resource required is less. Even for example, from our thesis study only, where we had actually stopped the study in between so that we could save a lot of resources and also the time to complete the study. So the trial was, we were able to complete the trial yearly, and also limited exposure to either suboptimal efficacy and ADRs for the participants. And this is very important from the ethical point of view. Basically, it is definitely unethical for exposing the participants to suboptimal therapy or to ADRs. However, the limitations being the expertise availability, of course, it is to implement this. Actually, many of these, whatever the adaptations we did, actually we implemented with the help of our programming language, because there are no pre-specified tools openly available, and the pharmaceutical companies may have their own proprietary tool within their system, but there are no open tools available for making this simple. So we need to code the group sequential designs, adaptive randomizations, or the continual reassessment with the help of our programming language. And this is not a very big limitation at the academic setting, but resource redistribution will be an issue when it comes to multicentric studies for a big pharmaceutical company. So yeah, that's all about an introduction to the adaptive designs in the clinical trials. Thank you.
Any questions for Dr. Srinivasan? Yeah.
Clinical trial design, wherein we incorporate a stoppage criteria for utility or pure efficacy. Will that be considered as an adaptive design? Because designs like this have actually been practiced previously also.
Of course, it's practiced. I never claimed that it is never practiced. Of course, it is practiced.
So
Yes.
it is
So provided we define based on these boundaries, alpha spending boundaries, not without including the alpha spending. If we just define an interim analysis without considering the alpha spending, then it cannot be considered actually.
okay.
Yeah, that's what my take is. Yeah.
Okay. And sir, for the considering the criteria for the stoppage, is there any criteria for selecting O'Brien, Fleming, or Pocock, or is it more of a convenience?
It's not about convenience, it's the way you look. It's about, again, the perspective. As I told previously, in the O'Brien Fleming, the spending, that is the error spending, be it alpha or beta, in the beginning, when the total sample size is less, is very less, which is preferred actually, because that will be less prone to errors.
Okay.
In O'Brien. But Pocock, it usually what happens is similar amount of error is spent throughout the study. So that is the thing. Otherwise, it's about if we can justify why we are using it, it is fine. That's the thing. Yes.
Okay. Thank you, sir.
Any other questions for Dr. Srinivasan? Are there any questions in the chat box? Who has access to the chat box?
No questions.
No questions there. No. Right. So, yeah, please.
I am MDPGT student.
Closer to your mouth, please. Yeah.
I am
very close, very close. Yeah.
I am second year MDPG. I have a question. What is posterior factorial? You mentioned in your lecture.
Posterior probabilities.
Probability.
Posterior probabilities is a concept in Bayesian design, Bayesian analysis. So what happens is, in the traditional frequentist approach, we don't take the previous knowledge while analyzing the data. So but when it comes to Bayesian analysis, we take the previous knowledge into consideration, and from the results of the present study, we update the previous knowledge with something called posterior probabilities. So that is called posterior probabilities, and it is specifically related to Bayesian analysis. Yeah, not the traditional statistical analysis which we perform. Yeah.
Great. So I think we come to the end of this presentation. Anand, thank you so much once again.
Thank you
for your the insight into this, all of this that you carry is fantastic. Thank you so much.
Thank you, sir.
The next presentation is by Professor Devashish Hota, and the topic is Principles of Palliative Care Drug Use. I have known Debashish for many, many years, more than 20 years now. And it's such a pleasure to see him rise. He's now the head of department at AIIMS Bhubaneswar. Debashish, we look forward to your presentation.
You, Dr. Shoibal. And good afternoon to all. Professor Dhaneria, nice to see him after a long time. Dr. Vishwas, Shanish, and all my dear future colleagues, my colleague, present colleague Anand, Shambhu, etc. I missed Dr. Tripathi. He must be busy in organizing certain things. Yeah. Yeah. But मैंने भेजा था WhatsApp में और I have the pen drive also. Can I put it here or इसमें ढूंढना पड़ेगा थोड़ा. Better. The topic is somewhat neglected topic. What happens to this end of life care? So people send them home. Patient admitted into the ICU. Then they say there is point of no return. Patient sent back home. So this appears little inhuman, unethical. But hospital also has its own limitation. The physicians have their own limitation. They prefer to spend more resources and time on a younger person or younger patient rather than a patient who is old, debilitated, and who has no meaningful life left. But we cannot leave a patient as such. Death is inevitable, no doubt. But managing the end of life care is also important so that he can make a meaningful and peaceful exit from the earth. So that is what all about the palliative care, and we will, have you got it? Yeah. And here is something to confess. And this is the first publication I made during my second year of MD. Professor Salil Bhattacharya was professor in BHU. So he told me, you write this paper in 15 days. I have no idea where to collect the material, what to do and how to proceed. But he was very good enough to give me few books on palliative care. And I have to write 15 pages out of it in double spacing typewritten. That time we didn't have computers. We have to submit the handwritten manuscript to someone and he will type, we will edit and re-edit and re-edit. So this is something very close to me, and when Shambhu requested me for this, I agreed. Slide is not moving.
Somewhere down there, there is no, there.
Sorry. No. Okay, yeah. Right. So there are models. What is palliative care? I will discuss on that. Objectives, components of palliative care, symptoms, and the most common symptom that the end of life patient needs is treatment for pain, dyspnea, GI symptoms, nausea, vomiting, constipation, and psychological symptoms, especially delirium and anxiety. And drugs are also no saints. They also have their own share of adverse events, and we have to manage that also. And finally, I will summarize it. So this is something, the active total care of patients whose disease is not responsive to curative therapy. That means patient is refractory to all kinds of treatment, and basically we need to control the symptoms what he is having, because we know the path is now blind and there is point of no return achieved. So there is sociological, psychological and spiritual issues that may be there, and we have to look into all these. So models of therapy. So there is a curative therapy, that this blue line, I didn't get that. Yeah, this curative were disease specific and restorative, the first dark box. Then there is a palliative care where that white big triangle, that is supportive and symptom oriented. So where we can control the symptoms without having a specific cure, we can just manage the symptoms. And first, once the death occurs, there is how to manage the family members and bereavement symptoms. So it is, yeah.
Other people can see.
Okay. Then, so this is with persons with illness, there may be cure or there may be death. And after death, there is supportive therapy for the caregivers. They also need assurance because they lose someone very close to them. And the disease progresses and finally the inevitable happens. And what is the goal? To provide a quality of care. Here we miss certain things. There is no specific therapy for this. You cannot conduct any clinical trial for palliative care services because you know the disease is irreversible. Only symptomatic and supportive care is permitted. And we cannot experiment on a patient who is almost dying. Of course, certain cases we can go for it, like cancer therapy. So most of the therapies are limited and we can do that. Like a person with meningeal metastasis, we can go for certain therapy like radiation therapy or something. That is actually not a palliative therapy, it's suppressive therapy. But palliative therapy comes after that. If everything fails, then we'll go for that. And the history of palliative care starts with this British lady, Cecily Mary Stokes Saunders. And she was actually a nurse and she was giving care to a Nazi survivor who escaped from Auschwitz from Poland, and he was admitted. Finally, she fell in love with the patient and she developed this specialty. So this is the hospital and she started. Now it has become a worldwide phenomenon to provide palliative therapy, but there are certain riders. In India, palliative care is actually non-existent and there must be something to be done because hospitals are overburdened, doctors are limited and time is very, very less. And patients also do not know that this palliative care, what do they do? Once the patient is discharged from the hospital, there is a big crisis at home. What is to be done next? They just appoint one nurse who just does the basic life support, like changing the linen, changing the diaper, and all those things that she can do, or giving the medicine as prescribed. That is something the family expects, and that also takes its own cost. Then communication, how to communicate the bad news. Here the role of the caregiver comes that yes, you have reached the point of no return and you must be prepared mentally for the situation. Symptom control, because varieties of symptoms can occur because there are problems of end organ damage, problems of drug adverse events, problems of psychological issues and family issues, negligence, all those things that are to be addressed. Then rehabilitation, is there any possibility of recovery, or patient also, if he is conscious and is understanding the situation, yes, he can be made to understand the situation. And terminal life care, support in bereavement, family members, because now doctors are continuously attacked by the caregivers or their family members, but the patient was alive and very much talking, conscious, and in the hospital you have given medicine and you killed my patient, my parent or somebody else. So that has to be, again, because of the communication only, where the doctors are not tuned how to communicate and how to convey the negative news. If it is cure, everything is fine, surgery is successful, they go happily. But if something is not possible, despite giving all the best therapy available at the moment, so that has to be communicated to the family members and the patient's relatives. And education is needed for both the physician and the caregivers and also the family members. They all need to be educated how to behave in a situation like this. You suddenly cannot convey that, yes, we have done whatever we could have. Now it is point of no return, take back your patient. That will create some anger, some frustration among the family members. That is, again, will be reflected very badly in the media or in the direct action on the hospital. And research, here I emphasize, research is very, very limited in the palliative care setup, and it is a basically neglected area of research. A lot of things can be possible by pharmacologists and clinical pharmacologists, because you have variety of disease, variety of organ dysfunction, variety of symptomatology, and variety of drug therapy and drug-induced adverse effects. So a lot of things are in sequence and a lot of things are still unknown. We cannot do a magic, but we can still provide some relief here. So to domains which we need to focus: physical symptoms, especially the pain, anxiety, delirium, psychological symptoms that come next to it. Then social needs, interpersonal relationship. So when all the relatives start visiting the person who is dying or person who is just discharged from the hospital, that also creates anxiety. We must limit the number of visitors. We must, that so much live sympathizers, that must be limited. And patient must be given adequate freedom to express his views. We only just see one side of the story, that the doctor has come and given some medication and discharge. But what happens to the patient himself? Have we taken any opinion from the patient? That makes some difference here. And existential and spiritual needs, although that is a WHO definition, physical, mental, social, spiritual, all these things come together. Therapeutic part comes only one domain. So common symptoms, what the patients usually have: pain, lot of symptoms they are focusing on or related to pain, dyspnea because of this cardiac or respiratory problems, constipation because of the drugs or because of the disease process the patient is having, nausea, vomiting, that may be part of the disease, part of the drug, anxiety, delirium. These are the 6 major symptomatology, but anything else can be possible. There can be heart failure, there can be edema, there can be renal failure, other things that will also ensue. So almost 2/3 of the patients with advanced cancer, they experience pain. It can be meningeal metastasis or metastasis to the bone or any other soft tissue. So 30%, they relate it as moderate to severe. That means 1/3 of the patients they perceive as moderate to severe and they need therapy for the control of pain. So it can be either nociceptive pain, like achy, throbbing or dull pain, or it can be neuropathic pain. There is damage to the neuron, or where there is a repetitive firing from the dorsal root ganglion, which continuously stimulates the pain sensitive pain receptors in the brain, and that needs a different form of treatment. Then assessment of pain. Pain is more when the person is alone, where pain is relatively less when the person is in the company of his loving family members. Then timing of the pain, when the pain starts, when the pain wanes up, whether it is a continuous pain or whether it is a dull aching pain which comes off and on. Then the severity of pain. And we don't have a measure of pain except the visual analog scale. So we can quantify the pain. and how the patient describes. If the patient is in a position to describe, it is a good situation. But many patients, suppose a person who has undergone resection of the tongue or who has just developed some signs of Parkinsonism or psychosis, he may not be able to describe the symptoms he is having. Then location of the pain, where the pain is located, nature, that has to be ascertained so that we can do something. Maybe a nerve block can relieve the pain if it is located to a particular site. Then what are the precipitating factors that can aggravate the pain or relieve the pain? Then radiation, if it can be assessed that it starts from a particular organ, then it radiates to others. Like a cardiac pain usually originates from the sternum, not from the left side of the heart, what movies show, and it goes to the left shoulder or left limb. Then how much functional aspect is impaired due to the pain? Maybe he's unable to move his side, maybe he's unable to lift his limb, or if he is unable to take his feet, how much care he needs because of the pain, that has to be assessed. Then nociceptive pain, non-opioid analgesics are usually the first choice, usually paracetamol, but with a word of caution, if the liver function is good, we can give paracetamol. There is a limit, not more than 2 grams a day. Then NSAIDs, because they have their own adverse effects, they have renal adverse effects, GI adverse effects, and cardiovascular adverse effects. So we have to again be very, very careful about use of indiscriminate administration of NSAIDs. And WHO pain scale, it has step 1, 2, and 3. Step 1, that is non-opioid for mild pain, nociceptive pain. For mild to moderate pain, there is weak opioid and non-opioid adjuvant therapy, that means mixture of NSAID and mild opioid. And moderate to severe pain, when it is refractory or not responding to mild therapy, so we have to go for strong opioids, then we'll go for this last. And in refractory pain, there is no limit of opioid dosing. We can increase because we know that pain is not responding. We cannot leave the patient unattended without relieving the pain, or he can take as much opioids he can. So there is no maximum ceiling dose to opioids, and it should be titrated, of course, that what is the lowest dose that relieves the maximum pain and makes the patient comfortable, and how much adverse effect the patient can have. Because one of the possibilities that there can be dyspnea or breathlessness, then if the patient is prescribed opioid, that may aggravate. The problem is opioid silence the respiratory center. Patient may not get the symptoms of this carbon dioxide accumulation. So that is a problem. It makes the respiratory center insensitive to carbon dioxide, which is the potent stimulus to the respiratory center. Is it over or can I continue? Yes, sir. Okay, thank you. So after initiating every dose of opioid, the patient needs to be evaluated for both pain relief, efficacy, and the adverse effects. Common adverse effects that everyone knows is constipation, which can be troublesome in a patient who is bedridden, or it can be respiratory depression, which can be more troublesome. And how to escalate the dose? For mild to moderate pain, 25 to 50% dose escalation may be appropriate, but in severe pain, 50% should be the starting next dose to access. Then neuropathic pain, that is my area, my focus is on neuropathic pain throughout. So tricyclic antidepressants like amitriptyline or SNRIs like duloxetine and alpha-2 delta ligand agonist like this pregabalin and gabapentin. And second line, we have traditional analgesics like tramadol, tapentadol, that is a more NRI, that is more is mu opioid receptor agonist and norepinephrine reuptake inhibitor like SNRI. So it has dual function. And third generation therapy for this neuropathic pain is opioids, oxycodone or morphine. But again, be prepared for the adverse effects. And designing analgesic regimen. So scheduling the round the clock, if it is continuous pain, then round the clock analgesia has to be given, then rather than as needed, because round the clock is beneficial. It suppresses the pain that appears before, that suppresses the pain before the pain reappears. So that has some benefit. And all analgesics work less during pain. So if you can give the pain analgesic before the pain appears, it has a better control over the pain. So long-acting or extended release analgesics, opioid analgesics are preferred for round-the-clock pain control. And for breakthrough pain, we have short-acting opioids that can be given along with the long-acting opioids, so that we'll have a better control over the pain. But be prepared for the adverse events. So continuous pain, long-acting opioids, then for breakthrough pain, short-acting opioids, and these are the problems. Opioids are very well known for their adverse effects, that constipation, which can be very, very troublesome, sedation and confusion, and respiratory depression. So it always preceded by sedation. Thus, one has to be very, very careful about it. We have some relief for the constipation. We have GI specific mu opioid receptor antagonists like albumopan and methyl naltrexone. So that will take care of it. And dyspnea, advanced cancer, particularly metastasis to the lungs or the great vessels that can suppress the respiratory or airway function. Then advanced cardiac and pulmonary disease, heart failure, COPD, they can produce dyspnea. And dyspnea management, again, opioids, although they can produce dyspnea, we have to be careful, but they have excellent effect if it is due to ventricular failure. And if the dyspnea is due to the left ventricular failure, it creates oxygen deprivation, carbon dioxide accumulation, and opioids, by suppressing the respiratory center, they can decrease the anxiety. So the sympathetic flow will be reduced and the heart will get some rest to provide the relief. And by that, we can indirectly stimulate the parasympathetic system, and that will be beneficial in this scenario, but it is only for a brief period. It cannot be given continuously. So for refractory dyspnea, it can be used. And second, third line agents, benzodiazepines along with opioids, but preferably short-acting benzodiazepines can be preferred. We should avoid drugs like diazepam or lorazepam. We should go for short-acting, like midazolam, that can be useful. Then this dyspnea. So basically, it reduces the sympathetic drive, vasodilatory effect in the pulmonary vasculature, so it improves the oxygenation, then changes in the effect on carbon dioxide, oxygenation and inspiratory flow, in the resistive loading on ventilation. So these how mechanisms how affect the respiratory function and improve the respiratory function, even if there is severe dyspnea. And non-pharmacological, like use a fan to create air movement across the patient face, so that helps little bit. And frequent repositioning of the patient to prevent the stasis of blood, particularly in the lower part of the lungs. And pulmonary rehabilitation. As you can remember that during COVID, patients with severe respiratory dysfunction were asked to reposition themselves in the prone position, because that allows more ventilation. And this mechanism can be applied here. And supplemental oxygen, if the PO2 is less than 25 millimeter mercury, so that has to be again be handy. Constipation, so this is not due to this IBS, it is the drug-induced constipation, or it can be the disease-specific. So we have to manage. If it is due to disease-specific, we have to look for specific drugs. And if it is due to opioids, we can have management like GI-specific mu-opioid receptor antagonist. So for disease-specific, obstruction to the gut by cancers, maybe obstructive symptoms, electrolyte abnormalities. So we have to check for that. Impaired venous flow due to heart failure and gut wall edema all can affect the GI motility, digestion, and the movement. And drugs, opioids are the most notorious, but tricyclic antidepressants, which are used for neuropathic pain, they have this anticholinergic adverse effect, atropine-like. They can also produce constipation. Then antiemetics, they can have this constipating effect. Anticholinergics, of course, they have their own set of side effects. Then what the patient will have, patient will not pass any stool. So there may be hard stool, so painful or infrequent defecation and sense of incomplete evacuation of the bowel. But if he strains, there will be more pressure on the venous system, heart, and the things can go worse, particularly patients following myocardial infarction. Straining is absolutely not required, but we have to manage the bowel. So non-pharmacological like intake of fluid, but intake of fluid cannot be indiscriminatory, because if he has heart failure, then, or if he has pulmonary edema, we cannot increase the fluid intake. Fluid intake should be increased to a limit that does not worsen the dyspnea, but improves the bowel movement. So some kind of physical activity, maybe some kind of passive exercise is advised. Laxatives, but irritant laxatives are to be avoided. So lactulose, senna, magnesium hydroxide is actually an stimulant laxative that has to be restricted, but may be required in certain cases along with liquid paraffin. Then dioxide sodium sulfosuccinate, doxate sodium plus senna. And but there is no difference in their efficacy, so it has to be given because constipation needs to be addressed. And those receiving opioids should receive prophylactic stimulant laxatives, because we know that opioids are notorious agents for causing constipation. Then there is role of methyl naltrexone, as I have described. It is a gut-specific mu-opioid receptor antagonist that takes care of the GI movement suppression of the opioid, but it will not affect, because they are not absorbed from the gut, they will not affect the analgesic effect of the opioids. So these are the drugs: methyl naltrexone, naloxone, and albumin. They are all approved by the FDA and CDSU, so we can use them. So these are peripheral opioid receptor antagonists, and they also take care of the pruritus by the opioids. Nausea, vomiting, that is another big area. So nausea, vomiting, most drugs cause nausea, vomiting. Any drug crosses the blood-brain barrier can cause nausea, vomiting, that the traditional pharmacology treatment says. Also, there may be meningeal metastasis to various parts. Even if there is some metastasis to the vomiting center or the CTZ, there can be persistent nausea, vomiting. And the taste, there can be the GI effect on the drugs. They can also induce nausea, vomiting. So D2 blockers like haloperidol should be considered. And we have to give some drugs which will not affect the GI motility, but all these drugs like haloperidol, although it is very effective suppressor of nausea, vomiting, it can also produce gastroparesis. So that can be again aggravating effect on the nausea and vomiting. So we have so many drugs like opioids, antimicrobials, antidepressants. So they target this receptor, D2 receptor, then 5-HT3 receptor, NK1 receptor in the CTZ, and impaired gastric emptying, 5-HT4 and dopamine 2, and 5-HT3 acetylcholine muscarinic receptor. So we have certain drugs like ondansetron here or aprepitant, then fosaprepitant, then prochlorperazine, promethazine. So they can be used here in case of nausea, vomiting. Then others like cranial, intracranial pressure, CNS. So we have chlorpromazine or promethazine or D2 receptor antagonist. So scopolamine, promethazine, they're not
Devashish, I need to
available.
go a little fast. How many
Yes,
more
yes,
slides?
only few are
Few
left.
more.
Yeah. Anxiety, benzodiazepines are excellent drugs for treating anxiety, but we will go for only alprazolam, not the long-acting benzodiazepines like diazepam, although it has good effect. And maybe combined with SSRIs, but no drug is a saint. Every drug has its own set of adverse events, so be careful about the adverse effects. Delirium, so uncontrolled pain, or there can be constipation, infection, electrolyte abnormalities, opioid withdrawal. So lack of sleep, all can induce delirium, and that initially people take it lightly, but should not be viewed lightly. So acute decline in attention or consciousness with cognitive dysfunction, that is there. Management, benzodiazepines or opioids, anticholinergics. Then first generation antipsychotics are excellent agents to control delirium. But if it is due to hypoxia, oxygen therapy may be administered. Then while prescribing medicine, as the traditional pharmacology says, the risk versus benefit. How much benefit do I get? The benefit must outweigh the risk. That is why then only I can go for a drug therapy. And when there is a terminal event, we usually administer so many drugs and they have their own set of adverse effects, and more than 25% of the adverse events are attributed to the drugs itself. So what we can do, reduce medication burden. So decrease, so that can be deprescribing. So drugs which are not producing effect, we can deprescribe. So that will reduce the medication burden, decrease mortality, reduction in the hospitalization, and possible improvement. I cannot say there is definitive improvement, there can be possible improvement. And candidates for deprescribing, those who have no indication, like PAN 40, that is the common drug which is prescribed in most hospitals without any indication. Every patient hospitalized is prescribed pantoprazole. I don't know why. Now people are switching over to rabeprazole, stating that it has a better effect. I still could not understand what is the better effect is. So we can de-escalate. If only there is hyperacidity, we can think of using that. Otherwise, we should avoid. Then beneficial drugs will be kept, and those who are not producing effect, we should de-escalate or deprescribe. Then end of life care, that intesol formulation, this intesol we have dexamethasone, so only high concentration oral preparations are there, which are well observed and which are well documented to be effective. So they can be given. That is the end of life care. And goals of care, what we exactly mean by goals? We should achieve a peaceful exit from this immortal or mortal world. Nobody is immortal. And spiritual consideration, people call maybe the priest to give some end of life advice like citation of Gita or Bible. That may also help to make a peaceful exit. And symptom management, then attention to the quality of life and alignment of the treatment with patient identified goals. And palliative care must ensure that the treatment provided to the patient with serious illness are consistent with the patient's goals of care. Patient must ask for something, patient may not ask, but the physician must also visualize certain things from his own experience. So that's all about the palliative care, but we are still missing many points, and every patient is different. No drug fits all. So we have to individualize the therapy, and the palliative care for a patient with heart attack may not be similar as a patient with cancer. So it has to be discriminated, and specific therapy must be instituted, and we must individualize every patient for its care. Thank you. I took little more time because I got little emotional because it was my first publication. Anyway.
Now,
Thank you.
wonderful presentation, Debashish. Thank you so much for such an important topic. It's so important because, many of us here sitting here are in an age group where we have very elderly parents, and so this personally affects some of us. I have a question for you, first of all. So opioids are so important for palliative care. They take care of pain as well as dyspnea. Many patients will require opioids. Yet, the regulations around opioids are so tight that often, they become unavailable to patients who are being, end of care or palliative care is often in the home setting. Getting those opioids becomes difficult. So what is the latest regulations around opioids? If I have a patient at home, and I have a prescription from a doctor, can I procure opioids, and where can I get them from? How to do it? Can you
True,
just
sir.
give us?
They are not available in the market. Only specific anesthesia department people are authorized to dispense. Not even the pharmacist can dispense. So the pharmacist will take the permission from the anesthesiologist who is in charge of that hospital. And a committee is usually there for opioid dispensing committee in many places. They will distribute if it is needed. And
that's where the problem is, because the patient is a Calcutta patient, has gone to Tata Memorial Hospital in Bombay, got treatment from there, got a prescription for opioids for palliative
that
care,
is
comes
the
back to Calcutta.
point, sir.
Where is the hospital? I can't go every time to Tata Memorial Hospital to get the opioid. And any other hospital will probably not give that
They
to
will
me,
not
because
give.
their anesthesia department will say you bring the patient here.
These
Is
are
there something
some
being done
gray
about this?
areas, I understand. So there is no straightforward answer to your question, actually.
Can, yeah, please. You're in a good position to react.
No, in fact, there is some provision, like when I was in IGMS, means he's absolutely correct that this anesthesia department, they do the palliative treatment. And you have to take an extra permission from the authority that we are treating these patients. And there are supplier also need some extra work to do, because as it is drugs which may cause abuse, misuse. And that's why this regulation is there. Otherwise, anybody can go and can buy from the market and do some.
Yeah, well understood.
So that is one problem. Yeah.
But the issue is, on the one hand, to stop misuse, something which is so important for palliative care, and you're talking of elderly people in their last phases of life. If you can't do this much for them, then what are we good for?
No, there is way. No, people are getting. Either they are not going through.
I know, but
Through proper
I'm
channel. Yeah.
I'm telling you the most situations in which patients find themselves. At that point of time, the patient is not in a position to move. A. Number two, his family is harassed, hassled, is going through a very difficult time. And that point of time, it can't be got from the nearby pharmacy. I think at least this much can be done, that if a prescription is there from a bona fide hospital, then another hospital must be made to honor that prescription. They cannot say that you have to bring the patient here.
No,
and we will see
it's
them.
not there. You don't need to get the patient to the. If you show the doctor's prescription, it is available.
But
Maybe
that's
you're
what I
not-
wanted
Yeah,
to
it's
know,
available.
because there was
It's
a time when it was
available.
not available.
Yeah.
I recall that
It's
you
available.
have to go to a government hospital, get something from a superintendent,
available.
they will supply it to you.
Okay.
But it is a lot
because-
of pain, actually.
Time is short, but
Yes, sir.
just few points
Sir.
I noted down. It's really important, as you told in the beginning, that it's very neglected. But there should be something to do, because very few places this MD course is there. He names Dr. Sushma Bhatnagar, who is now head of the IHCS. She started MD course in palliative medicine. So NMC should take care of it. Like NMC is now giving more importance for emergency medicine. It is a must, mandatory in every medical college to start MD. And super specialty DM critical care medicine is also there. They should take more initiative to do more, at least if there are MD course, so student will be there and it will spread throughout the country. And very few places are there, like in AIMS in the ring road, you have seen that Santi Avant Ashram, Santi Vedant Ashram. They do this type of hospice and other works. When I was in Patna, now we have also started on the palliative management in the Mahavir Cancer Hospital. But there should be more like that to take
We
care
have
of
to involve all
palliative
the
care.
practicing
Yeah.
physicians to
Yeah.
take care of this,
Yeah.
because patient cannot move around and the attendants also cannot move. So we have to have a mechanism so that they can get the uninterrupted supply of the essential drugs that they need.
All right. Thank you.
Thank you, sir.
Thank you, Devashi, for the wonderful presentation. Very important topic. Let's, progress, and I would encourage you. You are in this, or at least have thought about these areas. Work towards changing or improving our systems so that these things become much easier for people who are
That
really
is
in
the
need.
legal and technical aspect of this opioid
Absolutely,
distribution and management chain.
Absolutely. Thank you so much for your wonderful presentation. Thanks. So we come to an end of this session. Are we breaking for lunch or?
Yes, yes.
Huh?
Just. So may I request Dr. Shoibal Mukherjee sir to please felicitate Dr. Anand Srinivasan. Thatte. Also, may I request Dr. Shoibal Mukherjee to felicitate Dr. Devashi Sudha sir. Thank you, sir. Thank you very much. Yes. So now we'll have a break for lunch, and after that we will have the keynote lecture. So may I request our online participants and online faculties that we will take a break. We'll be back by 2:10. Thank you all.
আমি এই মুহূর্তে একটা বুঝতে রয়েছি একটু আমার সময় হবে না এই বুঝতে যখন তখন আমার মাথায় আসতে হবে তো তাই বললাম যে আপনি যারা করবেন বুঝতে পারবেন নামটা Pharmacology. তাদের জন্য শিক্ষা করছি তারাই একা করেছে আমার যদি মাঠের সমস্যা
আগে আমার বসের সাথে আমার ছবি না তুলতে পারছি আমার বসকে আচ্ছা ঠিক না আমার যদি ছবিগুলো ওগুলো একসাথে গ্রুপের মধ্যে দিও না মানে গ্রুপের মধ্যে ওগুলো আমাকে আলাদা করে পাঠিয়ে লোকে আবার গালাগালি করবে একদিন লোক দোকানে দেখেছ বসকে বসের সাথে একটা ছবি না তুললে না বসের সাথে আপনি জানেন আমি তো মাঝে কৃষ্ণ তোমাকে কেন্দ্র করে তো আমরা রয়েছি কত বড় ট্রায়ালে আমাদের নাম নিয়ে দিলে ভেরি থ্যাংক ইউ ছবিগুলো দিয়ে দেবে একদম এই তোমার পিপিটিটা দিয়ে দাও পিপিটিটা কিসে দেবো ওই যে ওটা দিয়ে দাও না নড়ে গেল মনে হ্যাঁ বলছি এইটাতে ইয়ে করা আছে হ্যাঁ ঠিক আছে ইয়ে আসবে Good afternoon, all. Welcome you back to this post-lunch session. And I think the offline participants are there and also the online participants. So we have now the theme lecture, and we are really honored to have with us Professor Nilima Kshirsagar, Madam, to chair the session. Madam, are you there? Yeah, Madam is joining. So also, we are really privileged to have with us Professor Nihar Vishwas sir to chair the session. So may I invite Professor Nihar Vishwas sir. Please focus, Madam. Good evening, Madam. Can you hear us, Madam? Madam, you have to unmute yourself. Yeah.
Yes, good evening. I can hear you. Thank you very much. Thank you.
Thank you, Madam. Thank you. So we are really privileged to have with us Professor Nilima Kshirsagar, Madam, who needs no introduction, who is a living legend in the field of clinical pharmacology in India. So we are really blessed to have you, Madam. And now may I request Professor Nihar Vishwas sir to kindly felicitate Dr. Sanis Davis, who is going to give deliver the theme lecture. Sir, please.
Congratulations. Yes. Thank you very much.
Thank you.
Now over to Professor Nilima Kshirsagar, Madam, and Professor Nihar Vishwas sir.
Thank you very much to all the organizers and particularly Dr. Shambhu, who has been so diligently following up. and also to Dr. N.R. Biswas sir, who is co-chairing with me, and also Santanu, Tripathi, and many others. It's a great pleasure to introduce here Dr. Sanish Davis, who has achieved many things in clinical pharmacology, and he is the president of the ISCR, and he is also the executive director at J&J right now, and he has immense experience, and he's a very erudite speaker, and most importantly, he has been associated with us in many ways, including for the SAC ACCP. And I must congratulate the organizers for inviting such fantastic speakers for this conference. And I hand over now to Dr. Biswas to take the proceeding forward. And also the organizers must be specially congratulated for providing us this opportunity to contact online. And thank you very much for all this opportunity. Over to you, Biswas.
Thank you, ma'am. Thank you. And good afternoon, all of you here physically and who are online. It's just customary to tell a bit in detail about Dr. Sanish. Already, Madam has told Dr. Sanish Davis has been in the clinical research industry for over 17 years and has worked on both sides of the fence in academia as well as in pharmaceutical industry. He is currently R&D Director, Global Clinical Operations, Johnson & Johnson, India. He has worked in the domains of clinical development and regulatory strategy for development of compounds for emerging markets. He has an active interest in external environment, shaping activities in clinical research and in operationalizing ethics in industry research. He is also president of Indian Society for Clinical Research, a nodal multi-stakeholder group in clinical research in India. He has a postgraduate degree in clinical pharmacology, DM, and postgraduate and graduate degrees in pharmacology and medicine. He is also a fellow of American College of Clinical Pharmacology. With this brief introduction, I invite Dr. Sanish, who is also in our group in the executive committee of our society. And his lecture is on the theme lecture, this clinical pharmacology, relevance, potential impact on human health and global visibility. For the last 2 days and also in the last meeting, we have discussed that we have to do something now. Enough is enough to propagate this clinical pharmacology. And now as India is to be leader in the coming decades, why clinical pharmacology will be behind. So with these few words, I invite Dr. Sanish to do the job. I hope you will do the best job. Thank you.
Thank you, Dr. Biswas, and thank you, Dr. Shivsagar, for your kind words. Before I actually say anything, I think that the organizers of this conference actually deserves a huge round of applause. I think superb job, Dr. Santanu, and I won't actually take everyone's name because I always had this feeling that sometimes people get very nervous if your name is not taken. But if you are part of the organizing of this meeting, as also a fellow traveler, I think you've done a fabulous job. I know how difficult it is to organize meetings of this nature. So we are growing as a community of clinical pharmacologists. Our journey has just started, and I'm sure there is a long way for us to travel. So thank you to the organizers for this opportunity to talk about very high level stuff, but I'll try to make it much more realistic or much more ground level with regards to what clinical pharmacology would mean for us in many ways. And these are my disclaimers as to how we can enhance all this thing. So for our consideration, here are some themes that I had in mind. And thank you, Shoibal, for actually proceeding with a wonderful talk. So I can actually skip a lot of what I'm going to say and jump to some very specific topics that I have. So one is we as clinical pharmacologists need to think what is our core capability, right? That's one of the most important thing. And once you actually think through that, I guess the relevance of what you are doing and what your specialty is and how you can actually help in, you could say, human health comes to the fore. And then from there, the next question is that how do we and where do we serve the community? Ultimately, it is all about how do you serve the community? I mean, it's not just one individual, because if you're a practicing clinician, it is just that one patient that you're looking at. But if you are a clinical pharmacologist, I think it is much more than just an individual. It is more like a community and even looking at the nation, because there are elements of activities which actually have an impact on even the nation by the things that you do. So as a clinical pharmacologist, you can be part of all these different forms of, you could say, committees or groups or societies or associations, etc., each having its distinct requirement and each having a need which can be fulfilled by a clinical pharmacologist. So for those of you youngsters who are here, who are either finished their DM, are in the process of doing DM, or are in the early stage of their career or in the mid stage of career, I'm going to throw a lot of these things at you to say that your day actually can be more than 9 to 5, right? There are a lot of things that you can do, you can contribute, you can bring value to the table. And when you actually go through all this, that's the impact on human health that you bring to the fore. And then ultimately, instead of just thinking about what is my relevance or what am I doing, you need to also think about, as a clinical pharmacologist, what value are you going to bring to the table? Because everyone is assessed on value. And on that value also hinges your personal motivation, your self-drive, your hunger for actually doing something, your hunger for, you could say, pushing forward the clinical, the specialty of clinical pharmacology, etc. And that is where visibility actually comes in. While the topic talks about global visibility, I will restrict myself to the Indian visibility that we need to have as the clinical pharmacology community. And when we talk about our core capability, we sometimes get confused. What am I? Am I a pharmacologist? Am I part of medicine? Or what kind of species do I actually call myself? And there are also a lot of these questions which come as, can a pharmacist do what you're doing? Or are you a clinical pharmacist? Are you somebody who's like maybe a PharmD person? There are a lot of these confusions, or there are a lot of these career questions that sometimes get thrown at you, sometimes at very places of unease. And when I say places of unease, these are like when you're with your clinical colleagues and somebody says, oh, are you a pharmacist? And that kind of like makes you so unhappy and annoyed with yourself. And then you have to correct people to say that, no, I'm a medical person, but trained in clinical pharmacology, right? And they would again ask you, do you dispense drugs? Right? That's the next question that I sometimes hear. And then you have to kind of like think of what is your core capability. And I would always put this as, you're somebody who actually is able to bring whatever is the capability that is there of an internal medicine person with your sound knowledge of pharmacology and apply that knowledge to the domain of medicine. And within that, you have all these capabilities that are there, that you're part of medicine, you can provide leadership in very specific areas in therapeutics, which need strengthening. We have had lectures. Dr. Dhaneria was talking about antibiotic stewardship. We had Smita who was talking about TDM. There are others too who spoke about it. There is a huge field of drug safety in which many of you would say that, okay, that's the domain of maybe the pharmacology folks. But the reality is that clinical pharmacology actually encompasses all that. And then the bigger field of clinical development, which is not just industry specific. If India is growing into doing all these things, you need people in academia who can actually do clinical development, right? So that's how things are. And ultimately, you need to embrace these opportunities in order for you to demonstrate the value. So sorry if I kind of like make myself seem very pontifical about this, but we also need to understand that we need to explain our journey to people. And sometimes I feel that the journey is not a very easy one. So for example, you have, you could say, the opportunity to be in academia, industry, practice, or a hospital, clinical pharmacologist, etc., even after your MD. And then you continue to actually go further and further, and then again go into the same format that is there. And then somebody might ask you, what is the difference between an MD person doing these activities and a DM clinical pharmacologist doing this activity? And that's where I think you need to bring in your differentiation, the value of your education and training, and say that, okay, what is the differentiation that I bring? So bringing that, you could say maybe a little bit more specific. As a medical professional, we came into this profession with the intent to actually provide patient care. I don't think many of us, unless you are born in a very rich environment, many of us actually come from modest means, right? As students, as you could say, our parents, our community, etc. We come from places with modest means. And we always came into medicine just because we wanted to serve patients, right? And we liked only life sciences. We wanted to also have a good quality of life, and also esteem, fame, and all these things, which is all very valid. But like every profession, motivations of many of us might be different. Many of us might have actually come into pharmacology because of sheer chance, or because we thought that this is the pathway that might be better than clinical medicine. Whatever pathway it was, we need to embrace that pathway. And my personal journey itself was that I had a lot of challenges embracing that pathway for the first 15 years of my career within clinical pharmacology, right? To sometimes have that conviction that, okay, this is the right pathway. You need to have mentors. You need to have people who have gone before you. You need to kind of like follow that path and believe in yourself that this is the pathway that you would want to follow. So to embrace the role of the clinical pharmacologist, probably half the journey covered. Sometimes many of us struggle with that thought process, that am I in the right path, or am I kind of like not in the, you could say, the way that I should actually develop my own career. And you have to realize that you're part of a member of a healthcare team in a hospital or a college. And once you start embracing that role, that you are part of a healthcare team, then the relevance of or the relevance of your degree, or the relevance of your training, as well as sometimes your own relevance, will actually come to the fore. And then you have to work in order to move from providing relevance to actually delivering or demonstrating the value to the healthcare system. So that's my brief about, you could say, relevance. And now coming to where and how do we serve the patients, the community, and the nation. And like I initially pointed out in my first slide, there are a plethora of roles that can be taken by a clinical pharmacologist. Shoibal has actually talked, you could say, extensively about many of them. I will only concentrate on those which I have, you could say, direct connect with on a day-to-day basis. And these are the last four things about which I'm going to talk about. The subject expert committee membership, being a clinical research director in an academic institution or even in a private hospital setting, data monitoring committee member, and maybe setting up a clinical research secretariat, which also is there. And we have within this room itself, people who fill into all these buckets and who have done tremendous work in all these different subjects. But I want to actually kind of, you could say, provoke you a bit, kind of like make you, for many of you who are working in institutions of national importance, or people who are working in institutions where you can contribute more. I want to provoke you today, and I want to stand myself, you could say, at that crossroad and say that, sirs, you can do more. You can bring more value, and we need that value, because otherwise, I think as a nation, we will not progress in this field. So the first one is as a subject expert committee. So this is a requirement within clinical development in India, that every company who either has a clinical trial, whether it is phase 1 or whether it is phase 4, or they have a new compound which they are kind of like getting a approval, has to go through a subject expert committee. It is also true that sometimes some of the academic studies which might have a drug which is interventional in nature, there is an opportunity for it to have some marketing tangible for that, also has to go through this subject expert committee. And subject expert committee members are currently only restricted to national, state government institutions, right? That's the moot point. Now, if that is true, the clinical pharmacologists in these institutions have a big role to play in this one, right? And one of that is that you are, as a clinical pharmacologist, you are a core member of the review team within the SCC. And I wouldn't want to, Dr. Hota is here, who actually comes on several SCCs. And he's one of the more enlightened folks, as I would say. And the reason for that is because many members on SCC have no experience at all doing even a normal observational trial. But the kind of pronouncements that they make in these committee meetings make you really wonder that what are they trying to kind of like make. And it is a big loss for the country, right? It's not just the loss for the country, it's a loss for even patients, right? Many patients actually benefit from being part of clinical trial. And I'm not just saying about oncology or immunology or some of these rare diseases, but even normal ones. I mean, being a participant, actually there is some benefit to the patient and not just the company who does these kind of studies. So the person has to be a key member who brings forth the knowledge of regulatory science, clinical pharmacology, and medicine. Now, this is where I think clinical pharmacologists have that unique ability to actually have leadership role in a subject expert committee, to kind of like tell people that, okay, why is it necessary to do this in a particular way? Why do you think that if you do it in this particular way, it can lead to any risk or any benefit for the patient, etc.? And the first thing that I would actually request my esteemed clinical pharmacology colleagues who are from government institution, please raise your hand to get included in the CDSU SCC list. Oftentimes, many of the good people are sidelined. And it's a very sad thing because it sometimes kind of like questions the whole process that is followed. But I would honestly request my esteemed clinical pharmacologist colleagues, please do raise your hand to be part of, you could say, the SCC, this thing. We need good people because otherwise the discussion goes in different directions. We need informed experts rather than people who just kind of like are part of the crowd or says yes. It's also a great learning opportunity for somebody who's in a mid-level or even at the junior level in your career, that you can learn a lot of things by being part of the subject expert committee. You also know about the changing landscape of drug discovery and development. It could be things like which you would actually immediately be able to kind of like translate in, say, for example, in your postgraduate training and education for your students, or even for DM trainees, etc. It's a great opportunity to actually bring about. Discussions about newer study designs, newer endpoints. All of these are things that you would do on a daily basis, right? So what is required of somebody who comes on an expert committee? You need to, of course, devote time, because sometimes these meetings, as Dr. Hota will remember, is going to be very, very long. I mean, the day can be very long. It can start at 11 o'clock and sometimes it doesn't even end at, you could say, in the 16th. So you have to devote time. You have to have a general understanding of regulatory science. This is not rocket science. You can read documents and you can actually test your own hypothesis in sometimes these meetings, because you learn when you actually talk about these things. So you also need to kind of like start thinking about how to review these packages. Phase 1 data, when you have phase 2 data, we will not have a lot of preclinical data kind of studies which will come, which means that we don't have too many phase 1, etc. So all these are studies where phase 3, phase 2 are being done. So you are kind of like reviewing. There are places like going to the TGA website or the EMA website, which gives beautiful examples of clinical pharmacology packages being reviewed. That's all that we need to, you could say, follow or replicate here. Deciding if the drug has any potential to behave differently in Indian population. There's a unique thing which a clinical pharmacologist is probably the only person who can take that decision, right? And that's a question which has to be asked by the SCC. ability to review data to kind of like see for the risk benefit, etc. So I'll skip this one because this thing. The second is if you want to do, or if you want to develop your clinical trial site, or if you want people who actually would be interested in doing clinical trial, one way is to actually, you could say, set up clinical research institutions in your hospital. Apart from all the things that are there, I'll concentrate on these 3 or 4 things which I feel will happen. Pharmaceutical industry studies is a great way to actually get ideas to do your own research. Sometimes it can be a spin-off research, which you could say the pharmaceutical company will be interested to help you out. Say, for example, my own experience, and Dr. Shirsagar is here, Madam's understanding of what can be done in malaria. Some of these were spin-offs from pharmaceutical company trials that were there. It can give you topics for your PG's thesis. That's also a great thing which many of us would want. Funding for the department so that your department can run bigger and better things, right? That's ultimately the key thing. And of course, be part of collaborative research. So a lot of those are also going to happen. And why industry is going to come to a government academic institution? The reason is simple. This is the place where you can actually do these kind of studies. It's not in private centers that we want to do these kind of, these are studies where we want to do in government institutions, because that's where the talent is, that's where the expertise is. And a clinical pharmacologist being at those centers can guide all these things in a better way. Currently, we don't do this because the government centers take 6 months for their contracts to get approved. And that's a no-brainer. Then nobody will come there. But if you have this interest, or if at least some of your juniors have interest, please kind of like encourage them. We will kind of like work with you to actually make sure that many of your systems and processes with your institution can be fast-tracked. I have in fact gone to some of these institutions, talked to people in the administration to say, why is it important for your hospital to be part of this? And sometimes they then have that light bulb moment when they actually say that, oh, isliye aap aa raha hai kya? Because they otherwise are just getting this document and they feel that some company is trying to get some money from the institution. Whereas you are trying to kind of like give money back to the institution. They think that we are trying to kind of like get money back from this thing. So there is a synergy between, you could say, pharmaceutical industry research and academic research. Many of these individuals that I listed at the bottom have all kind of like have done pharmaceutical industry studies and have done spin-offs in their own areas of interest. And so that could be a good one. And for, you could say, the hospitals and others, it's also a very important thing because you can actually develop your institution better. And we all kind of like then, you could say, be part of this Make in India and Made in India, because ultimately, if India has to develop these drugs, it's not just the industry which needs to develop. The industry also need to have committed investigators who will be there. Now, those investigators are not people who always have the knowledge. So that's where another part of clinical pharmacology coverage or expertise can actually help. And ultimately, the clinical pharmacologist can also be a research director. And there are a lot of roles which actually the traditional clinician who's an investigator will not be able to manage. So building a team, that is a research effort. Building the team is not just for pharmaceutical research, but for academic research, so that you have a team of people, you can bring in more research, you can bring in more collaborative work, and ultimately, what I say, research that matters to the patient in your area, that matters to patient in your community. And then, of course, all these other things in private will happen, that when there is more research, ultimately more patients actually come to those institutions. And there are several examples in India which is there. And lastly, I think you need to establish what is called as a clinical research secretariat, which will actually channel in all the benefits of doing large-scale research in one particular department. And a clinical pharmacologist uniquely positioned to actually guide this activity. And Shoibal did mention about this in a big way. So as a society, what do we need to do? If we need to have a seat on the table, example, the very recent NMC decision on generic drug prescribing, drug safety, etc. As a society, we need to have a voice. We need to have a white paper. We need to kind of like build something and we need to send it out. And I'm ready to commit myself to actually be part of that task force which would want to write that paper. And we need to write it within the next couple of days, because that's the only way that somebody will hear our voice. We need to elevate the quality of regulatory science, as I said. I talked about antibiotic stewardship, doing action rather than just lip service, because that's such an important thing. And Dr. Hota was talking about drying up of antibiotics. But if we don't have newer compounds, at least let us preserve what is already there so that we can extend the life of that thing. And to my young friends who are there in early stage career pharmacologists, here are my top 3 picks for, you could say, putting in your research effort or putting in your, you could say, career. There are a lot of gene therapy products which are coming out. India is itself doing a lot of gene therapy study. We don't know the long-term safety of any of these things. This is a great area for somebody to actually concentrate. Rare diseases. There is a lot of investment, a lot of excitement at the government level to push through rare diseases. But many of these drugs, if they are going to be manufactured in India, would require a lot of significant handholding, a lot of good clinical pharmacologists who can actually do these early phase studies for these compounds. And then geriatric clinical pharmacology. Within the next 10-15 years, India will go into the China way, where we'll have more of people who are in their mid ages and later ages. We need geriatric pharmacology as a big specialty for managing many of these. So these are some of my thoughts. And I would end by saying that as a role of as being a teacher or a mentor to DM trainees, I advise you also and sensitize them on some of these things which I actually talk about, which are not those often topics like regulatory science, translational medicine, how to review preclinical data, clinical pharmacology data, statistics and data analysis. And at least whenever you get an opportunity, expose them to industry in a good way for ideas, for thoughts, for newer things that are happening, because you don't want them to feel as if they are only being able to kind of like talk through in their curriculum. So with that, thank you for a patient listening and happy to have questions.
Thank you, Dr. Shanice. It's really, it's a fantastic lecture. And Madam is here. You'll speak something about Dr. Shanice, Dr. Nilima. Yeah.
Yes, thank you very much, Sanish, for putting it in a nutshell very, very nicely as to what clinical pharmacology is, and a very good message that you have given to the young clinical pharmacologists. And I'm sure all would have noted these, and particularly interesting are the combination of internal medicine and pharmacology with application of this to real life. I would also say that it's very important for academic institutions to, as he correctly said, to have an advocacy for this at various levels. And you are the next torch bearers, Sanish, and all the youngsters who are there. And I'm sure that with this kind of conference and the messages that are being given, it would be something that we can very much look forward to this discipline getting its due recognition and also being highlighted at various places. So I also look forward to this sort of a white paper. And I'm sure, I think one of the important things which he mentioned is that you should closely interact and be part of the healthcare team. And that is something which is important. I just had a few days back, one of the students who had called up and said that what kind of mentorship guidance that he wanted. And one of the things that I told him was that, be interactive with the clinical department and be able to collaborate with them very well. So thank you, Sanish, for all that wonderful presentation. And I'm sure Dr. Biswas will also have some comments to make. And I'm sure the students will have some questions. And thank you. Great, Sanish. All the best to you.
Thank you. Thank you very much for your comment. From the audience, any important points to highlight? Or
I really appreciate you have, particularly your lecture, and prior to yours is Dr. Shoibal Mukherjee's lecture. It has absolutely clarified the landscape and the direction, has shown the pathway, how as clinical pharmacologists we should make our fresh journey. Okay, we have a long journey, but then time has come and the need of the hour is a little different. So we have to change our direction now. So thank you very much, Dr. Sanis, for showing us the path and the directions. Specifically, what you have pointed out, that in just coming 4-5 days, what we should do as a group, how we should respond to the most recent NMC directives. It's a difficult task, no doubt. And we have to be very balanced also, because we can be also misunderstood. Okay. This is a challenge, and as we had discussed last evening also together, but then we have today, and we place to take it more seriously. If during our meeting, we can again have a small sub-meeting, maybe 10-15 minutes, to chalk out the plan, how we should take it up in the coming 4-5 days, or maximum maybe a week or so, and then how to actually present it in the public domain. So with this, we take this up as immediately to be done agenda for us. And thank you for stimulating that further. Okay, over.
anybody from chat box means who are online? Yeah, please. Then I'll give my final comment. Yeah. Chiranjeev.
Dr. Bagchi, do you want to speak out?
Yes, sir. Yes, Dr. Sanis, yeah, nice presentation. I congratulate you because I am a bit physically ill, so I cannot attend personally. So anyway, I congratulate you for an excellent presentation. So I appreciate you, as I have heard you earlier also. So it's a eye-opening for the new investigators, as well as the existing investigators, as well as the upcoming students of clinical pharmacology. And for your kind information, I am telling you that with the blessings of Dr. Tripathi, who has set an example there at our department, I am also acting as a phase 2 clinical trial in principal investigator, and my fellow colleague HOD, he is also acting as a principal investigator in number of clinical trials. We have developed a clinical trial site, active clinical trial site at our department, and we are working on the new molecular entities, and we are working as a team. We have developed a team with the help of also blessings and guidance of Dr. Tripathi. He has taught us how to develop a team. So we are working in this direction. So thank you very much. We want to collaborate with you. And we are here also in academic institutions. We have many patients. We have developed that collaborations with the clinical counterparts. We have an excellent ambience. Please collaborate with us. We are here to collaborate with you. Please. Thank you. Thank you very much.
Thank you, Chiranjeev, for your input and good initiative. Precisely in 2 minutes, I'll just highlight few points. And he correctly told that this clinical pharmacology is an integral part of internal medicine. And if we go to the history globally, in worldwide, as in UK, they first become the physician, and then they become clinical pharmacology like any other super specialty. That's and we are by and large, British are left, we are following their methodology here also in India, but in US it is different. There are many people, PhD holders, they are also doing excellent job as a clinical pharmacologist there. But here, after MD and DM, this question sometimes comes that what is the extra? Because if you have another degrees, naturally you are more informative, you are more knowledgeable, and you have to show that, and you have to make yourself indispensable. Any hospital, say this type of hospital, why not like a medical superintendent is appointed, medical director is there? Why not a clinical pharmacologist should be appointed as a part and parcel of any hospital? So that's why we can be recognizable and we can show our importance, and we have to come forward for that. Like sometimes in private, some advantages there, like Balaji More, he also came from KM. I think around 2000 he did his DM. He is with us now. And we have given him nearly 40 clinical trials he is organizing. And in private institute, there is no problem giving degree. We have given in medical director research like that and doing fantastic job. But anyway, in government hospital, there is some limitation, post creation and other thing. But at least who are appointed in the Department of Pharmacology and having DM degree, they have to show their importance, not like any other pharmacologist and just teaching and taking exam and going home. It's not like that. You have to show your indispensability, and then only you will get the importance. People will give a chair, you have to earn the chair, you have to snatch the chair. It's a joke. I know one person, Mr. Nasha, he was somewhere in Delhi in the pharmacy council or like that. He used to come to the meeting, and if no chair and no name is in his name, he used to take a chair and he used to go to the dais and sit. It's joking. So you have to do that. You have to do your job just like such a thing that they have no other alternative to appoint you as a clinical pharmacologist. So with these few words, I again congratulate for your good lecture, Dr. Sanis. Thank you very much for the organizer for calling me here.
Now we are moving towards the next session, the invited lecture 1. And to chair the session, may I invite Dr. Arunabha Vishwas. Dr. Arunabha Vishwas is now currently as an associate professor at Kuch Bihar Medical College. Please.
A very good afternoon to all. With continuation with today's program, the next session invited lecture is on biosimilar development, challenges and its solutions in India. We all know that drug development itself is a very tough issue, and among them, development of biosimilar agents is especially area that we need to really know, and what is the current status of such a development of molecule, and what are the challenges that we are currently facing, and is there any solutions to those challenges or not. Our speaker, Dr. Shubhadeep Sinha, is going to present on this topic. So without wasting any more time, I will request Dr. Shubhadeep Sinha to come off the dais and start his presentation.
Thank you very much, Professor Biswas, Professor Santanu Tripathi, Professor Shoibal, Dr. Sanish, Professor Hota, all the seniors and my colleagues. I am the only non-clinical pharmacologist here. So bear with me if there is anything not clinical pharmacology here. So what I believe and truly believe what my mentor, Professor Tripathi, also tells me. Yes. Yeah. That's why I proudly put that so that he says there is always a practicing clinical pharmacologist, which and he has been guiding me for the last 12 years in my organization as a DSMB chairperson. So before I go into SEC Viva of Dr. Hota, I get a Viva of Dr. Tripathi, and he was complaining I had too many applications, but that is how we have been developing our phase 1 studies. And I've met sometimes Sanish in some of these meetings, and we were both like what Tripathi sir is doing like this. So we were also in that situation. What is going on? I remember precisely Dr. Hota's this Pandy comment that was, why is Pandy being given to everybody? It has become like a paracetamol of today, which is very true. It's one of our concomitant drugs was Pandy. It was my study. And it was true, and we kind of then reprimanded our CRO to change their procedures, not to give. It's become a habit. And there are these SEC meetings are not just for it is a lot of educational. It's a lot of education. I have attended about 350 of them, and each time it looks like a viva to me. And again, I'm standing in front of seniors, and I'm feeling just the same. So anyway, so here are some of the. I hope it changes. It doesn't. It has come. It's coming. So there are three parts to the session. One is the biosimilars basics, challenges and solutions in global versus India. So I have not restricted myself to India because India there is very little to speak about in terms of guidelines. There are very sketchy ones, especially in terms of clinical pharmacology. But a lot of our work is derived from the global guidelines. And first and second part is more directed towards the emerging clinical pharmacologists who are sitting on the backside. And and I declare that I am not, these are all my personal opinion, but biosimilars have become now the norm of therapy, and it is shown by and it is because of the fact that a lot of them are coming off patent. And 10 years back or 12 years back, there were only about 18 companies which were developing. Today, 91 different companies are developing biosimilars. And if you look at the next 10 years forecast, I think there are a few pointers that even after all the global development, Europe still holds the key, but there are other countries which are coming up. India is way behind. We are only doing 1% of biosimilars globally. So we have to, and as clinical pharmacologists, see, I often struggle in my department because a lot of us, the staff we get are less. One is non-medical, second is mostly MBBS, and pharmacologists are very rare to want to come. I mean, clinical pharmacologists. I was asking our friend, he said that there are about 250, 150 clinical pharmacologists, or 120. Out of them, probably about, starting with a few exceptions like Shoibal sir and Sanish sir, only about 20-25 of them are in the industry. And the industry needs clinical pharmacologists, not just academics. We really need them because during protocol development, during study conduct, during study report, during DSMB presentation, everywhere we have to depend on pharmacological and clinical pharmacological, and also not just that, also in medical marketing, real world studies everywhere. Clinical pharmacologists are required, and very few are coming forth. And primarily because there are a lot of, we are not able to afford them because the DM students are getting quite a bit of salary, and they are not able to accept the starting salaries what we get. But then you need to start somewhere. The sky is the limit. You can reach where Sanish has reached, or where Shoibal has reached. Anyway. So again, market focused oncology diseases still hold the key. Monoclonal antibodies again hold the key. So these are the three top areas of research in biosimilars, and it has, earlier insulins used to be the main thing, but today, because monoclonal antibodies have been accepted more and more in the clinical practice, and it has become integral part of the regimens, obviously the biosimilar development will be on those areas. And as you know, all biological products are protein structures, and there are definitions which also define, it's not just definitions, which also define how the biosimilar will be developed in those regions. So for Europe, it is a version of the active product which is similar to the reference product in terms of quality, activity, safety, efficacy based on comprehensive comparability exercise. So this is very important. There is a comparability exercise throughout the development of the biosimilars, whether it is when the CMC is getting developed, whether it is preclinical, whether it is clinical. But in biosimilar, the CMC is the clinical, because if the analytical similarity is not established in the right way as per the guidelines, no amount of preclinical or clinical is going to save the molecule. So, but in US, they acknowledge that there could be minor differences in clinically inactive components, and there are no clinically meaningful differences in terms of safety, purity, and potency. So what does India define? India define it as a mix and match of the quality, safety, efficacy, and there is a comparability. So basically, India also saying the same message in terms of definition, in terms of which also tells you how the development should be done. And biosimilars are reverse engineered from a reference innovator product, which is first characterized. Their critical quality attributes are defined, and then a unique cell line. Then the biosimilar candidate is characterized, and then there is a comparability with reference product, and that's how you get a biosimilar candidate. This whole process takes about 5 years to 7.5 years on an average. To come to a stage is almost like a new chemical entity to just come to the preclinical entity. And these are the step ladder approach from analytical studies to animal studies, clinical, PK, PD, immunogenicity, and additional clinical studies. So this is the reverse pyramids. And for an innovator product, they are first developing the analytical method, so they don't have to compare it with any other product. So the bulk of development is in the clinical, whereas for a biosimilar, the analytical is the proof of concept, because the analytical has to be comparability has to be proper. Clinical studies are only bridging studies. They don't prove anything new. They just see that they are comparable or not. Whereas the analytical and then the preclinical are the ones which needs to be robust. So there is a totality of evidence at every stage, totality of evidence in terms of structure, function, non-clinical studies, human pharmacokinetics, dynamics, safety, clinical effectiveness, immunogenicity, and a very, very long REMS and pharmacovigilance cycle. There's a direct comparison against the authorized and licensed reference product. So this continuous comparability exercise goes on till the entire life cycle of the product, and it can fail at any point of time, and it can be withdrawn from any point of time. So biosimilar manufacturing is a highly risky proposition, and it requires a continuous activity. So there's an extensive structure and quality equivalence, preclinical equivalence, clinical pharmacokinetic equivalence, dynamic equivalence, phase and clinical trial, where there are equivalence studies, and immunogenicity is there through and through, from the preclinical to the phase 4 as well. The guidelines vary from country to country. So the analytical is primarily based on the protein structure, the amino acid sequence, the higher orders, then the biological activity based on the complement dependent cytotoxicity and other activities. Impurity profile also needs to be comparable and not, there is no margin of error, no margin of difference there. Stability has to be there, degradation profiles have to be proper. So there's a lot of, and even after all that, finished formulation can fail the product. The finished formulation where a rubber stopper can fail the product. So thereby it's just not creating the product, but also the formulation which has to be spot on. Similarly, biological functions, as I mentioned, CDC, ADCC, target-induced apoptosis, because most of these act by causing cell death, and those are all compared in terms of number of studies. So it's like a fingerprinting. You have to fingerprint in terms of the reference product, and in terms of sequence, higher order structure, bioactivity, glycoforms, impurity profile. After 5 years of so much of work, then you can go into the clinical, preclinical. But then even after that, if that company decides there is a change in manufacturing process has to be done, again, there are risks involved. So If there are minor changes which say example, which does not, I mean, just a method of characterization is changed. So not much has to be done, and limited physicochemical studies needs to be done. But if there are major changes, you need to redo the entire work, entire analytical characterization, and you have to start from the scratch one. So next is a non-clinical evaluation. Of late, European authorities and other authorities have lobbying to basically waive off the preclinical, because especially in case of immunogenicity, it does not give you the full idea, and it does not reflect at all whether the in patients also similar antibody activity will be seen. So therefore, at least one repeat dose toxicity study in 28 days in rodent species, and in India, another non-rodent species study is required. As far as clinical studies are concerned, now this is like an ocean and an iceberg. So any of these biosimilar entities have multiple indications, whether it is cancers, multiple cancers, rheumatology, autoimmune diseases. You don't need to do all the studies in all the indications. So therefore, efficacy and safety in only one indication, the most sensitive indication, which has best placebo-adjusted response rate. Certain pharmacokinetic studies in healthy volunteers and patients, pharmacodynamic studies, and limited immunogenicity in one indication. But this is only the tip of the iceberg, because it is believed that every biosimilar is a new product. And therefore, new indications, you may want to justify by what is known as extrapolation of indications, by saying that they are same mechanism of action, same receptor. But even there, they may not agree, may have to do additional clinical trials on these. And in the US, there are specific requirements on interchangeability, where you cannot automatically switch from an innovator to a biosimilar in terms of prescription. You have to prove the interchangeability studies. And then as it gets prescribed, new immunogenicity, new safety data, new risks get identified, very, very peculiar probably to that of the biosimilar, not seen in reference product. And that also needs a long characterization throughout the life cycle. And you can obviously not predict hypersensitivity and immune response to your product. So it's a long-standing game and a very limited data. Actually, more than even generics, more than chemical entities, biological entities, the amount of data that comes out, clinical data that comes out, safety data that comes out after the marketing of the product, when it goes into the market. So therefore, post-approval studies are very, very important. And here, real-world evidence studies need to be factored in. A lot of, although biological innovators do a lot of real-world studies, but biosimilar companies do not. And thereby, these real-world evidence studies are very, very necessary now that needs to be factored in. So again, in clinical comparability exercise, you have a phase 1 study, or not really a phase 1 study, it's more of a comparative bioavailability, comparative pharmacokinetic studies. Then you have comparative clinical phase 3 studies and the most sensitive indication, and a long phase 4 study. No phase 2 dose finding studies, because there is no doses are already understood. So there is no need for a phase 2 study. Therefore, but then phase 2 studies have to be adequately powered, randomized, no 100-patient studies. These are all have to be properly sampled, statistically powered, and some, because of the limitations of, the constraints, etc. So non-inferiority studies are also acceptable, and most of the guidelines define the level of non-inferiority. In fact, country to country, it varies, from 5% to 15%. Africa, there's a stand, but the margin varies significantly. Reference product, again, country to country, it varies. Some of them require you to use the innovator reference, and innovator reference also could be different in Europe and the US. So you may end up doing a 3-arm study. And in certain countries, they want the local first approved product as the innovator, as the reference, and also the innovator reference. So it becomes multi 3-4-arm studies. Also, we have done a 4-arm study in Argentina, if I remember very clearly, because the product which is approved in Argentina for a colorectal cancer product was not the innovator product, but a biosimilar product. So we had to take that as a standard, and then the innovator also had two further, one in Europe and one was in with a slightly different specifications. Oh my God. So a lot to do. Phase 1. So there is a PK endpoints. These subjects have a large intra and intra-subject variability, and 90. So the standard 90% confidence interval 80 to 125 range. Again, as I was saying, there could be a 3-arm study. US and EU could have different reference. Large sample sizes are required. Most of them are, you need to do both single dose and multiple dose comparative parallel arm studies. Because most of these drugs are given for a long period. So it is not a single dose which is given. Unlike, for example, a drug like tenecteplase, only one dose during myocardial infarction over. But most of these drugs are for chronic diseases. So you need to have steady state PK studies also to be factored in. And endpoints should also have pharmacodynamic endpoints only if they are defined. In certain cases, like I have just mentioned those names, they are it is known that this drug will act at that receptor, that CD20 molecule or VEGF, and it is very well characterized that with the usage of a drug, the levels will decrease. But it is not so in most of the. PD is only necessary when there is a well characterized PD endpoint. And combined PK/PD studies are done. Often it is combined even with the patient phase 3 study. Study design are usually parallel because long half-lives and usage of, and there is an anti-drug antibodies immunogenicity, and thereby, and there is a single dose, multiple dose studies, both are required. Route of administration should be one most sensitive to show the differences between the biosimilar and the innovator, often subcutaneous route and and the extravascular routes, because this is where you will get a potential pharmacokinetic differences. Dose selection, most sensitive dose needs to be selected. Often what we do in phase 1 studies are the lower dosages, which are able to detect the differences more than the therapeutic dosages. Give an example, bevacizumab, and a very popularly used biosimilar. The therapeutic doses are somewhere between 5 to 10 milligram per kg. But for pharmacokinetics phase 1 studies, we use 1 milligram per kg. And that is where you get the best comparability. Study population, healthy subjects most of the time, but patients in case the drug is too toxic to be done in healthy subjects, and thereby PK in patients are done in those cases. Study design, usually the parallel design, because most of the drugs have long half-life and an immunogenic response. So if you do a crossover, these same antibodies can cause changes in pharmacokinetics and pharmacodynamics. Bioanalytical methods are not similar to that of the chemical entities because they're not usually suitable. So you need some other, usually LCMSs are not used for the biosimilars. These are probably sometimes ELISA is used, sometimes some other methods are used. But all these methods should be accurate, precise, specific, sensitive, and reproducible. Standard qualities for any bioanalytical methods. Phase 3's comparative clinical trials. Now, I'm just putting this picture because most of the cancer studies, survival is a primary outcome. Now, for a biosimilar, the survival need not be proven. It is the surrogate markers or secondary markers like the overall survival rate, progression-free survival. Those are the primary endpoints because there's nothing new to be proven. It is to be compared, and comparability-wise, overall response rates are better than comparing the survival rate. So even you have to show the differences between the biosimilar and the reference product, overall response rates are better in terms of cancer. Similarly, in terms of other indications like rheumatology, where the endpoints are same. I mean, the ACR20 changes in ACR20, the comparability of the ACR20, ACR50, ACR70. Those are the response rates again, not the how long the RA patient has survived. So most of the comparative clinical studies are on those. And there are a lot of challenges, and I'm not going to describe them because of lack of time. But then I'll say that inclusion-exclusion criteria have the most sensitive study indication, have the best placebo-adjusted response rates. We have to look at, for example, rituximab would be useful in both CLL as well as the NHL. But we'll have to look at also the incidence of the patients in these cases. Whereas in bevacizumab, you have NSCLC and colorectal cancers, both equally sensitive. Now, which you want to do? So obviously, often companies take a stand that, okay, in NSCLC will have more mortality, let's go with CRC. Have same sensitivity. And then extrapolation. So there is a bit of play around that is done. Each to his own company. But then another company might say that NSCLC, I have more products in lung cancer, so I will do an NSCLC. So I have to have it in the basket. So that kind of strategy is also employed at this stage. Across, and the study indication has, and the primary endpoint, as I mentioned, not the same primary endpoint as that of the innovator. Study design is of equivalence is better because you can show the differences better, but because of the large sample sizes, some bit of non-inferiority designs are also allowed, and most of them end up doing that, and there are certain guidelines for the same. Immunogenicity, these drugs being proteins will cause anti-drug antibodies. Depends on which type of proteins, and there are product-related factors, treatment-related factors, and patient disease-related factors. All of them cause the change in the immunogenicity of the product. I'm coming to that. It affects both efficacy and safety. So this is a formula of product probability and severity. So if the biological entity is given in immunosuppressed patients, likely lower probability, a greater probability if it is an autoimmune disease. If it is more human, and there is a terminology UMAB, it will have lower probability, whereas foreign ones will have higher probability, subcutaneous will have higher probability, purer substance will have lower probability. Severity wise, if there is already an endogenous version, like insulin, like erythropoietin, there are more likelihood of having immunogenicity, more severity, likelihood as well as severity will be more. Chronic diseases, it will be more than end-stage diseases. Replacement therapies and anaphylactic responses will obviously be more severe. So this is how we can guess what the immunogenicity will come out. It is seen that monoclonal antibodies have very, very low immunogenicity, and only excepting infliximab, the other mAbs are often lesser, more human ones, because we are moving towards more human biological entities, thereby they have less. The analytical methods are based on ELISA. Again, very, very unique, and there are other. This is a topic for another day. And operational challenges are many now, because in India itself, although we contribute only 1%, we have a lot of competition to recruit patients. And poor patient compliance, because patients are now started getting the biological entities right from government pharmacies. If they're cancer patients, they get biosimilars or even the innovative products. So they say that if I'm getting the drug free, why would I participate in this clinical trial? So it takes a lot, especially I've seen that in Chennai, southern, and even in Kerala. Drugs are given free of cost, even the biological entity. So thereby it finds, when these are long studies, it may go up to 6 months, 1 year, 2 years. Patient interest, maintenance of that interest is also and high. There's also high placebo response rates especially in pain indications, where 30% of them can show high placebo response rate. 40, correct. So and there is a lack of coherence between. Now this is where it's US and Europe differ so much. If you generally for chemical entities, if you have approval in Europe, you are sure that you are more likely to get. But here there is no such likelihood. If you have so there are, even in the global map, there is US-like countries, that is US, Brazil, and certain of South American countries. Europe-like countries. In the same South America, Mexico is more Europe-like country. So you have that there is a lack of coherence between guidelines, and India is somewhere between. There are a lot of operational challenges. Ethical committees are very less experienced, and clinical trial, again, SECs, he was highlighting SECs. Most of the, sorry to say, but they don't have experience with biosimilar or even biological products. So to get proper guidance, it becomes difficult. We go to the SECs for guidance. We really go to the SECs for guidance, and that is where we don't get it. We end up scratching our heads. What should we do next? And then there are standard of care evolving, which is evolving. And for example, I just saw in case of rituximab way back in 2014, CHOP was the standard of care. Now CVP, mini CHOP, it has changed. Whether that data will be relevant for this regimen, we don't know. So then again, we need to do further studies. So there are certain operational challenges, and patients and physicians are not educated. In 2023 itself, Joe Biden signed a education bill for the patients and the physicians, especially for biosimilars, and which is a landmark that after what they had Affordable Care Act. So that again helps. And post-approval studies, you have to do both post-approval efficacy studies and post-approval safety studies. And in India, post-authorization studies, you have a mix of, you need at least 200 subjects, so as to have a total of 300 subjects on the test drugs. That is the formula. But that formula should not be employed. I think we need more data on India. Biosimilar data in India is very scant. Safety studies in India, you have long non-interventional studies which needs to be done. What in India, what we do is active PMS, very ill-defined. We don't understand what active PMS means. The PMS, who is active here? So we need to define properly how many patients have to be done, what type of studies need to be done, whether ethics committee permissions are required for this active PMS, whether DCJ approvals is required for active PMS. So there is some bit of ambiguity. So in terms of the post-op. So there is the last point was an interchangeability. Interchangeability is a very specific guideline where it says that the risk in terms of safety or diminished efficacy of alternating or switching between the innovator product and the reference product is not greater than risk of using only the reference product without such alteration. So if you are able to prove this, that means a lot of safety needs to be proven even after the approval. The approval only gives you a biological approval, but switching studies are required between the innovator and the biosimilar, where it is called the reference to test switching and test to reference switching. And even that in the test will have, the innovator will have two types of product. One is European reference, one is the American reference. So test to test switching and reference product will also have two kinds of products. So reference to reference switching. So a lot of switching studies need to be shown. And then is alternating, meaning that test to reference and reference to test. So if the prescriber has to write your biosimilar in place of the innovator over a period of 6 cycles, three are in innovator, fourth one is biosimilar, you need to have this proof of constant that this switching did not lead to any change in safety, did not lead to change in the pharmacokinetic parameters had not changed. So there are crossover designs that are available. So in summary, in clinical development, the biosimilar clinical studies are mandatory if regulation across in all regulations across all countries. Phase 1 and phase 3 studies are required. No phase 2 studies are required. Phase 4 studies, long phase 4 studies, efficacy studies, safety studies are necessary. Immunogenicity is there across the clinical life cycle. There are indications which needs to be chosen very carefully during the phase 3 studies. Interchangeability is a specific US FDA definition, but it helps everywhere. There are other concepts of biosimilar safety not discussed here, such as naming, unique naming is there, traceability. There are coding of the biosimilar products. So moment that the patient buys and the QR code is used, it goes into the HMR and then EMR, and then they know that which product has been taken. So that batch to batch tracing is done. And then very extensive PSURs, RMPs are necessary. In terms of US, again, I've mentioned all of it. There is a 510A and 510K. 510A is the innovator path and the 510K is the biosimilar path. Most of these companies do go with a biosimilar path, but even a biosimilar company can go with the innovator path and not claim any biosimilarity. Instead, it can say it's a new product, new biological product. Europe is again has a overarching guidelines and guidelines on product specific, and there are also guidelines on monoclonal and antibodies as of today. And finally, you have our 2016 guidelines, which has come all the way from 1990s to 2012 to 2016. And this needs, I think there is another draft which is coming up on the biosimilars, and this is needed. Here, similar principles have been given, like selection of reference biologic, preferably the innovator ones. Manufacturing process has to be robust. The cell line that is used as the same as that of the innovator. Full quality dossier has to be there. This is very well defined. But what is not very well defined is the clinical part. The clinic, you have to go through the IBSC, you have to go through the IAC, RCGM, DBT route. Pharmacodynamic studies are well defined. So these are all there as similar to that of the preclinical toxicity studies, where there is a very much required for 3 dose levels: low dose, medium dose, and high dose, 1x, 2x, and 5x. Sometimes even 10x we have to do. And in one of these arms, you need to have an innovator as a reference, not all the, so local tolerance, because it's, most of them are injectables. So preclinical studies are also okay, but then, which is where the pharmacokinetic studies have been to either healthy volunteers or patients. Yes, we need to do that. Phase 1 studies. PD can be part of the pharmacokinetics and surrogate markers. It can be also part of the phase 3 studies. Now, there is a problem. Phase 3 studies in not less than 100 patients on test arm. Is that enough for a phase 3 study? And that is what is often done. And everybody uses this loophole: 2:1, 3:1. And you have 100 patients in test arm, 50 patients on reference arm, 20, 30 patients on reference arm. So this needs to be looked at, and this is not needs revision. So again, there's an extrapolation criteria which is same as that of which is used in Europe. Same mechanism of action, same receptor, scientific justification have given. One indication, it is already proven, and disease profile includes chronicity, life-threatening status. All this needs to be explained. There is a lot of pharmacovigilance plan needs to be given, and phase 4 study. This is important because this is good, but this is also not well defined. Now it says that primary endpoint could be safety, secondary endpoint is efficacy. Why secondary endpoint should be efficacy? It should be the primary endpoint. Immunogenicity, so phase 4 is again 200 evaluable patients compared to historical data of the reference biology. So it's a non-comparative study, fine. But again, safety, and most of, if you look at the applications of biosimilar phase 4, people take the approval, they don't do the studies. That is a fact. And if they, if we do the studies, they don't submit the. So how many of, as an SCC member, you would see that you won't find many CSRs, clinical study reports, being reviewed of the phase 4. This needs to be implemented, because we are saying that because we have to submit this data also to the other countries where they want our review done in your home country, and that is where this needs to be seriously looked at. And I'm not talking about vaccines, I'm only talking about the biologicals. I think their thank you slide has come, and thank you very much. This was actually my last slide. I hope you got an idea of why biosimilars are important, and it is, India has probably about 50 odd biosimilars being marketed in India, and by about 10 odd companies. Similar proportion like an NCs, there are only about 10 odd companies which are doing NCs. So more companies need to come up, and there are about so for example, we have gone to about 30 countries. Now the thank yous come. We have gone to about 30 countries, but then the entire 200 countries are there to be explored. Most of these populations, especially in the emerging market, need our biosimilars because we can give them the most cost-effective biosimilars for making them their healthcare affordable. Dr. Melvin, sorry, I forgot your name.
Thank you. Thank you.
Thank you.
Dr. Shubhadeep. You have really done a great job. It is a very broad topic, and presenting in a very nutshell is, I think you need a big applause. Quick 1 or 2 questions from the audience. Anyone want to ask anything?
Sir.
Definitely pertaining to the regulators. Although I am not a direct part of the regulator, I am an invited member. Thing is, this active PMS, what you mentioned, they want detailed investigation regarding the safety part. Efficacy is already there. That is why they got the marketing permission. So DCGI does not care about the efficacy. And regulators really focus more on the safety. So after approval, the more important point becomes the safety. So they are very particular. I will give the example of favipiravir. They initially, when they got approval in 2020, the hype was that it is a wonder drug, only drug, immediate approval, emergency use approval. So fine, they got it. Then we insisted you must provide an active PMS and at least 1,000 patient data. And there was an interim data submission which was showing some superiority over the placebo or other treatments. But when they submitted the whole data, there was no difference, only the symptom relief of about 6 to 8 hours. That means 1.5 days. That means as good as placebo, there is no benefit. So that happens. So people are buying like anything. And one more thing, that 1600 milligram twice daily for first day, then 800 milligram BD. I asked the company, because my student is there, Monica, in Glenmark, why you are going for a loading dose? Plus, sir, viral load is there, so we'll reduce. Well, do you have any proof? No, sir, it is developed in Japan by Fuji. So they have used this dose, so we will use. What is the scientific rationale? Please explain to me. They didn't conduct even the PK study in India. Because the hype was so much that we are desperate to have a drug. So whatever was available. In Ramdev Baba also sold more drug than any other company. Coronil. Everybody used it in rural areas. So that is how endemic or pandemic make them rich. That should not be the idea.
Coming to active PMS, sir, yes, the mention is there.
Yeah.
But probably description of how to do, what are the methodologies, whether, again, the problem is when we go to some of these government centers say, no, we have to take ethics committee. But nowhere it is written, it is required ethics committee.
Any study to be conducted in patients require ethical approach.
Correct. So I would, it would be ideal if all these are clearly defined, like whether do you need to seek the CDSU permission for that?
CDSU
I
has
didn't see
already
that.
given you permission.
No, for active PMS, again, you have to apply or not.
If they have given authorization that active PMS is needed, that's it. You have to submit the report.
Yeah. No, but the point, what happens, sir, if you have to register it in CTRI, they want a CDSU approval. They will not register if you don't have.
That letter has sent 1,000% data.
That is where we struggle between them. They don't register. They said you get a proper approval of this study. This study is not approved. You have to do that. Instruction is there.
I think tomorrow Dr. Pradhan is coming, so
Yeah.
you can get clarification. Okay, he will be online.
I have a couple of quick comments. First, in this kind of a mixed audience, many times we take things for granted that it must be whatever I am saying that. Is there anybody in this thing? I think in the first couple of slides, he has mentioned about CMC, the full form. What is full form of CMC? So that's why I'm being a teacher. Okay. CMC is chemistry, manufacturing, controls. Okay. Now, here lies, it's important. You are talking of biologics, biosimilars. You're talking of chemistry. Why? One question to you. The second is about, again, reference to the NMC's thing of generic prescribing and biosimilars. So think about it. Again, Dr. Sadis has given us the task. So you have to think about this. How to prescribe a biosimilar when the government is asking for generic. Thank you very much. Thank you.
I have a couple of very simple questions
Sir.
that I wanted to ask just for clarity. So, as we go into the future, we'll have a lot of RNA therapeutics coming in, I suppose. Will the same guidelines work for RNA?
No. You have to be more specific and
more specific, right?
Yeah.
So, I think one thing for the regulators to do is to begin to work on how to approve RNA.
Quota sir is on target.
The second thing I wanted to ask is that, I don't know whether hetero is selling in the US but these switching studies.
Right.
In what percentage of the biosimilars that you are developing, are you also going in for the switching studies?
So as of today, we are not in US, but I know for sure Dr. Reddy's does. They are doing currently, they are, I think, one darbepoetin and one more product. Both they have been asked to do switching studies.
They asked in the sense that it's voluntary, of course. If you don't want to claim switching.
If you don't want to claim biosimilarity, it will, if you want to claim biosimilarity switching study, without that you cannot claim. It will not be allowed that. So you can claim it's another biological product. You will neither get a biological innovator, like as I said, there is a biological innovator pathway. If you develop that, you don't need this interchangeability. Another thing, if you do the biosimilar pathway and do not do interchangeability, you still do not get biosimilar designation. You just get a biological product active in, say, rheumatoid arthritis.
But you can put it into the market, right?
Yeah, it can be put in the market, but the problem is, see, in a patient who's, there's also a question of insurance. Now, the insurance company will not recognize that this can be utilized. They will not reimburse it. So, a patient, imagine a patient of a cancer, of a, say, a breast cancer who needs 8 cycles, and he cannot afford, she cannot afford, say, the Herceptin. Now she can afford, say, Biocon's whatever product. At that time, she cannot take it because.
So what you're saying is switchability studies are important because of the economic considerations, in the sense that reimbursement will not be there unless you can show switchability.
Europe is slightly different, sir. Europe, there is no switching studies required. But again, each country needs to identify this product as a biosimilar, and it is also left to the prescriber. It is also left to the patient whether they want to take it. So there is a very lot of difference how Europe accepts it.
Right. The third question is about the host organism that you are using. So often, you can get a biosimilar from one host organism, or you can get the same molecule, the same protein from another host organism. Now, in your experience, does it make a lot of difference in the sense that are your chances much better if you have the same host as the innovator, or?
It's not, it is almost mandatory that you have to use whatever reference biologic has used them. Secondly, more and more, they are all going on CHO cell line. So cell line has to be the same, at least. So E. coli based products are now phased out, most of them. Most of them are CHO based. So, and whatever.
Sorry for that. CHO is what? I'm backseat.
I am also wondering. I don't remember the full form. Chinese hamster ovary. Yes.
Okay.
So but it is for this, because it's part of the CMC package. You need to have whatever innovator has done at that time. If innovator changes, you'll also have to modify.
No, but 1 second. So in the definition of a biosimilar, you have to have comparability of the molecule.
Yes.
Comparability of the molecule. Now, where that molecule
comparability of molecule in terms of quality.
In terms of quality.
Quality, safety, and efficacy.
Efficacy, everything. So quality, basically, safety and efficacy comes later. So quality comparability has to be there. But it doesn't say that it has to come from the same host.
Correct. I agree. But often when the regulator looks at it, they first refer the innovator product. And throughout the development, if you are comparing against the innovator, your product manufacturing has to be same as that of the innovator. So most of them don't take the chance of changing.
Don't take the chance. Okay, got it. Yeah, got your answer.
Coming back to your last sentence about that manufacturing will be the same. How can you vouch really in every subsequent batches, the manufacturing will be exactly the same.
No,
And
you
how
cannot.
that is going to be overseen by the regulator? That is not done.
There is a concept of residual uncertainty.
Uh-huh.
So there will be always some bit of uncertainty in terms of the product, as well as batch to batch variations have to be also within a certain.
But that is being overseen.
Yeah,
by the regulator.
yeah. You have to submit the batch to batch variation record
All the time.
all the time. You have to continuously submit till you get the, because it does not end there. Even after post translational modifications and scale up modifications are also to be submitted.
And that's not only unique for biosimilars, also important for biologics.
All biologics. Yes, of course.
Yeah, so when you change manufacturing location, what are the requirements from a regulatory end?
I'm not the expert on that, but yes, manufacturing locations.
To what extent have you
So there are classifications. I know that there is a minor, major, and critical. So if there are only with the manufacturing location, if there are only characterization methods which are getting changed, then there is not the entire spectrum has to be done. But if in the new manufacturing locations, and see what happens even for the innovators. It took some, like, take the example. It's a 20-year-old product. The innovator also has changed the location, changed the method, and it needs to, we cannot depend on the old data. We have to do comparability against the new data as well. So, moment this changes, the biosimilar company is not okay. Bana diya, chhod diya, nahi. We have to again do the entire comparability exercise.
Quality comparability.
Quality comparability. Not the clinical is in any way. Yes, sir.
Okay, thank you. It was really a great interactive session, and we have enlightened us a lot. Thank you. This session close over here.
Now may I request Professor Devashi Shota sir to kindly felicitate Dr. Arunava Vishwas. Also, may I request sir to felicitate Dr. Shubhadeep Sinha.
Yeah, this is the only instance where I will get felicitated by you.
I know what people are saying. Thank you, sir. Thank you. Yeah. So we'll have the dinner here only because of we know the NMC regulations, and unfortunately we had a sponsored dinner today at some place, but it was cancelled by that MNC due to NMC's new regulation. But we are really fortunate that this institute, they are providing us the dinner. So it will be from 7 p.m. onwards. The dinner will be served here. So I request all of you to stay with us for the dinner here only. So we are moving towards the next session, and that is on pediatric clinical pharmacology. And we are really privileged to have with us today Professor Shoilendra Handu, sir. So welcome, sir. Welcome, Professor Shoilendra Handu, to chair the session. He is the head at the Department of Pharmacology at AIIMS Rishikesh. So welcome you, sir. And also we have with us Dr. Shabnam Ara Begum. She is also a clinical pharmacologist and pediatrician too. So welcome, madam. So madam is now the associate professor at Arjikor Medical College. So over to Professor Shoilendra Handu, sir, and Dr. Shabnam Ara Begum.
Okay. Good afternoon, everybody. So our topic of Symposium is the pediatric clinical pharmacology. We all know that pediatric population or pediatric group, they are not small adult. They have their own unique physical growth, and also their physiology is different. Their absorption, metabolism, excretions are different, and also they're not miniature adult. So, and this is very sensitive issues. The lots of drugs are extrapolated from adult to pediatric population. We all know that. So these very sensitive things that this clinical part, pediatrics clinical pharmacology is very important. And without much delay, now I hand over the mic to Sir Handu Sir, Professor Handu Sir, to introduce our speaker.
Thank you, Dr. Shabnam, and thank you, Dr. Shambhu, for inviting me and giving me this opportunity. I am really happy to join you all. I would have been happier if I could have made it to the conference, but that was not possible due to prior commitments. So I'm so happy to be with you and joining you for this session, which is on pediatric clinical pharmacology, which is an area of immense interest for clinical pharmacologists, both for reasons of conducting clinical trials in pediatric population and also the special needs of children as far as prescribing is concerned. So I'm sure that this would be an interesting session. I'm also delighted because I am joining in this session my dear colleague who will be presenting, and also 3 budding clinical pharmacologists from our association. So I request Dr. Shabnam to initiate the session. So back to Dr. Shabnam.
Thank you, sir. Our first topic is first lectures on nuances of pediatric clinical trial by Professor Dr. Puneet Dhameja. He is professor at AIMS Rishikesh, and he has done his MD and DN clinical pharmacology. Over to you, sir. Online. He is presenting online.
Yeah, thank you, the organizers, for giving me this opportunity to present this topic of nuances of clinical trials in pediatrics. Changing, if I'm. Can you see this slide? I have shared the screen. And is it visible, or do I need to do any other modification?
Yes, it is visible, sir.
Yes. Okay. Thank you, ma'am. Now, this topic of pediatric clinical trials is so interesting in terms of because it involves lots of clinical, like you had said in your opening note, that the pediatric population is not the same as adults. They're not small adults, but they are actually individual entities which have their own pharmacokinetic, pharmacodynamic differences, and including pharmacogenetic differences itself. So what we need to do is we need to understand why we need to do clinical trials separately in pediatric population. And in the next few minutes, I am going to discuss about the challenges which are faced when we plan any studies in pediatric population. So I have divided my presentation in 3 aspects, 3 broad areas: the challenges which are scientific in nature, the challenges which we see are which are ethical in from the ethics point of view, and the third is from the regulatory challenges, the challenges which are posed by the regulatory bodies, or the challenges which are seen by regulatory bodies for promoting clinical trials in pediatric population. Now, moving on to the first slide. If we look at the WHO, the burden, report, the most recent report of 2019, the burden of disease in the population in the world. Now, if we look at the top 10 global causes of death in 2019, lower respiratory tract infection, neonatal conditions, and diarrheal diseases were the most common causes of death. And all these three causes are usually seen in pediatric population, although lower respiratory tract infection definitely they can be seen in adult population also. And then if we look at the global causes of disability adjusted life years, they are again what we see is that pediatric population is again the more common reasons, which includes neonatal condition, lower respiratory tract infection, diarrheal disease, and congenital anomalies. Now, these are the most common reasons for disability in the population. Now, if we topmost reasons for either the death or the disability for which the medical therapeutics need to find answers. But if we look at the number of clinical trials done for all these diseases, we see that hardly, if we compare the number of clinical trials done in adult population, in pediatric clinical trials are less than 10% of the adult clinical trial, total clinical trials which are done in adult population. So that is why we need clinical evidence which is specifically required in pediatric population, because there are many diseases which affect specifically only the pediatric population. The drug use in pediatric population can have long-term consequences in terms of physiological and the psychological outcomes, which are seen in later in the development phase. Then another major area why we need to do some clinical trials or the evidence, generate evidence in pediatric population is because there is a development of age-appropriate formulations, which are being developed for pediatric use in pediatric population. And these formulations need to be tested and tried in pediatric populations only. Then definitely we all know that there are physiological differences in pediatric population which affect the pharmacokinetics. And then drug use can lead to specific ADRs in pediatric population. So we require different types of studies which cannot be short-term, which have to be long-term to detect some specific ADRs which can affect the growth and types of the studies, the design of the studies, and the conduct of these studies are specific for pediatric population. Now, what are the scientific challenges and what can be the possible solutions for these problems? The first issue which is faced in pediatric population, like we have seen that there are a good number of congenital diseases which lead to disability. Now, congenital diseases are rare. So if there is a low incidence of disease, we may not find the adequate sample size. Finding adequate sample size becomes difficult for generating the generating convincing results. Now, what are the possible solutions for conducting clinical trials if the disease incidence is low? The first solution is use of registries and use of longitudinal studies. Now, this is one of the areas which has been exploited significantly by the pharmaceutical industry, but not much by the academics. Then the other way of conducting studies in rare diseases is use of modified endpoints, not the conventional endpoints. Now, these endpoints could be biomarker based, could be patient reported outcomes, or could be time to event endpoints. But yes, these such endpoints will require time to event endpoints. They will require long-term studies, which may not be favored by the pharmaceutical industry. But yes, biomarker based, if it is validated, they can be used as a substitute for hard clinical endpoints. Then the choice of control groups, because if the disease incidence itself is low, what all control groups can be used? The first example, in many countries, and I've come across a couple of regulations where they promote use of external or historical controls, especially when the studies are being required to be done in pediatric population. So this is one of the solutions, use of external or historical controls. Then the another solution for conduct of clinical trials in low incidence with rare diseases, multicentric approach. We all know that it can help. And then there could be novel trial designs like N of 1 studies, which definitely N of 1 trials require the same approval process, same protocol writing, and it involves the similar kind of testing. Then the latest development as far as conducting studies in low incidence is the data sharing across clinical trials. Now, FDA and European regulations both are promoting the data sharing across the trials when the incidence of disease is low. Now, this could be one of the solutions which we can see in future. Then the another critical issue within specifically for pediatric population is pediatric dosing. Now, the most important issue is what is the right dose for pediatric population if we want to do a phase 2 study. Usually what is given in the regulations is that 80% of the adult phase 2 dose can be used, which is rule-based dosing. But currently with the availability of calculus or the technologies or the modeling, continual reassessment method models are being used, which is basically adaptive dosing models, which are being promoted by regulatory bodies, which can be used. And a number of studies have been done recently, which are using this kind of adaptive dosing models for identification of the right safe pediatric dose. Then another thing which we all know is all about the pharmacokinetic guided dosing. Now, how pharmacokinetic dosing, kinetic guided dosing differs from continual reassessment method is in continual reassessment method model, it is the pharmacodynamic parameters are also considered. While when we talk about pharmacokinetic guided dosing, it is only the pharmacokinetics which are considered for identifying the safe dose pediatric dose. Then whether we should be relying only on the dense kinetic modeling or sparse sampling method. Now, sparse sampling, because in pediatric population, the amount of blood drawn could be an issue. The frequency of pricks and all those things could be issue. It is not the same like for adults. So sparse sampling based dosing, pharmacokinetic dosing is also being promoted. Then utilization of adult pharmacokinetic data. Yes, that is there. And then the most, now the another recent development is the use of simulations and modeling. Now, for identification of the dose. Now, whether regulatory bodies are open for accepting the data from simulations or the PKPD modeling, which are basically based on mathematics and calculations. So now that is evolving, and we should see the use of simulations and modeling as one of the solutions for pediatric dose, identifying the right dose. Then use of pediatric appropriate formulation. Now, this is again going to be a chicken and egg story, whether we need to develop the formulation first and test the formulation, or we need to identify the safe starting dose. So this is another area which requires specific deliberation. So use of specific pediatric appropriate formulations is another challenge for which probably we can see some kind of solutions in future. Then another scientific challenge, or we can club it as an ethical issue also in pediatric clinical trial, is use of placebo. Now, everybody understands, because being a parent, everybody understands that if somebody tells us that our child may get the active treatment or may get a placebo, it is going to create a lot of apprehensions. So what is required is informed decision making prospectively. So new innovative and methods are being designed in seeking the informed consent from the parents whenever it is a placebo controlled trial. So informed consent decision conventionally are taken on the basis of the meetings, and those meetings, especially in pediatric age group, may take a series, can be a series of meetings rather than one time or two time meetings, which will give us the results, which will from after which the parents can give the consent. Then another solution to use of placebo in pediatric clinical trials is, if the protocol mentions providing effective treatment at the end of the trial, if it is proven to be effective, and use of interim analysis. Definitely, we will not get into the statistical details because of lack of time. So providing effective treatment at the end of the trial is going to give some confidence to the parent that at least the child is going to be treated. This is one of the areas by which we can convince the parent about use of placebo. Then another solution to this problem lies in the use of Zelen randomization technique. which is practically seeking the consent if the patient or the subject or the participant gets into the placebo arm rather than getting it into the active control arm. So this is use of Zeland randomization is documented in the current recent literature. These are the solutions where possible solutions, but yes, there are other issues also as far as pediatric clinical trials are concerned. Then the other issue is the sample collection. Yes, in pediatric population and the blood volume. Sample collection requires that in pediatrics, there should be a reduced frequency of sample collection, the reduced amount of samples, which should be less than 3% of the total circulating volume, which is not, while for adults, it is less than 5% of the circulating volume. Then alternative sampling techniques like finger or heel pricks, and this requires the development of special analytical methods also, which can be used in pediatric clinical trials. And if we want to avoid the use of sample collection, use of pragmatic trials or design is one of the key solutions which can be used for this problem, where the sample collection will required will be less. Then what outcome measures are required for developing a drug, for approving a drug for in pediatric population is one critical issue is that if we have a subjective outcome, it becomes difficult to assess because the child may not be able to tell us about the severity of headache, nausea, vomiting. So use of subjective outcomes is difficult to assess. So what could be the solution is this use of scales or FACES scales, which can be used in this situation. Then use of age appropriate tools, like for neonates, because pediatric population is from neonates to adolescents, where the growth and maturity level changes. So use of age appropriate tools in a particular specific age group and as outcome measure can be one of the solutions. Now, there could be studies where heterogeneous age groups are required. Like I discussed in the beginning that some studies will require long-term analysis. And over a period of time, the pediatric population or the participant evolves in the development from neonate or from infant to maybe a toddler to that. So use of age appropriate specific tools is required. Then can we use proxy responses from family members? Now, this is one of the solutions provided the clinical situation or the problem can be answered by the responses the solution could be found by family members. So use of proxy responses can also be used as one of the solutions for outcome measures. Now, what are the ethical challenges? Most important ethical challenges comes in the form of informed consent, where we seek proxy consent by the parents or the guardian. Now, in this situation, although assent has been documented and that assent should be taken from the participant, but if we look at the actual scenario, whether the child or whether the consent should be taken from both the parents or from the single parent, assent should be taken from the child. If the child is not ready, if the child is not convinced, after one session of interaction with the physician or the investigator, how many sessions should be devoted for that? So these are the actual ethical challenges. Then emotions, understanding, and experiences. Again, these differ between adults and a child. So there could not be any major solutions for seeking the informed consent, but except for the better interaction at the recruitment, then goodness of fit consent procedures, according to using the age appropriate consent forms and using the age appropriate method and the study and the procedures as per the study design and the study design. Then seeking assent from children. We cannot have major solutions for getting the informed consent from which are innovative as far as informed consent is concerned. Then another challenge is ethical challenge is payment for participation. Whether the participant or the parent should be reimbursed only, or they should be compensated for any kind of injury, and how much should be the compensation. Then should there be an appreciation for participation, and should there be incentives for participation in the study or not? Now, regulatory bodies definitely discourage use of incentives for participation in trials. But for pediatric population, since we do not have the data, should this be promoted as well? Should incentives be promoted? And appreciation. How to appreciate the participation in clinical trials, in pediatric clinical trials, because it is usually, we know that we need data, but until participation is encouraged, we will not get the result. Then another issue is safety monitoring and protocol reviews of pediatric clinical trials. Yes, in both the situations, it is required to have pediatricians who understand the child. And when we talk about the review of protocol reviews, laypersons with experience in pediatric rights and well-being should be encouraged, should be invited. So there are some modifications. These are just brief modifications about the safety monitoring and the protocol reviews, and specifically for pediatric clinical trials. Now, what could be the future directions in terms of, we have seen the challenges which are there in scientific areas. We have seen some challenges which are in the ethics, field of ethics, and what could be the solutions? Now, clinical trials have got many scientific and ethical issues. More regulatory initiatives are required for promotion of pediatric clinical research with focus on specifically pediatric dosing studies with innovative designs and with innovative methodologies. One major area where the solution lies is accepting data from simulations and modeling, using adaptive trial design and adaptation. This is coming up like anything, and we are moving from using Bayesian, using frequentist statistics to Bayesian statistical models. Then promoting use of technological advances, which could be digital in nature, and use of devices, and the feedback form which are friendly, which are child friendly, because most of the child are now glued to they use better. They are better at using smartphones than the adult population. And continual re-education of researchers and reviewers is required. Like in the previous session, we discussed that it was discussed that the subject expert committees and the ethics committees, especially for biological use of biologicals, they need to be trained. And in the same way, researchers and reviewers need to be trained for analyzing and assessing the use of the clinical trials in pediatric population. So this is all that I have, I could present, but yes, there are many other issues which are there in pediatric clinical trials, which needs to be discussed. But this was just a snapshot of what we, briefly what we can see.
Thank you, sir. It is a very insightful and very enlightening sessions. And all the things are very meticulously highlighted. So in short, you have said there are certain things and what are our future directions. Main things you have mentioned, I think, are like ethical considerations and other thing also. Now, I'm requesting our participants, if they have any, both online and offline, if they have any 1 or 2 questions. So, sir. Sir, I have one question. You have mentioned many things, but one thing is also important, the formulations. Formulation for pediatric age group, because for liquid suspensions and that kind of tablet should be disintegrated, orally disintegrated tablet. That is also a challenging thing. And also for ethical issues, if the clinical trials are for prolonged period of time, then when their child, their guardians are giving their consent, but after they are attaining 18 years and or they have given assent form, then they should be taken that informed consent form. That is also challenging, whether they will they will stay in that trial or not, and also long-term safety. That is also.
Yeah, yes, the first point that pediatric specific formulations, Now, when we were child, we never used to see such kind of formulation like which are strawberry flavored or banana flavored and all those things. Now we see even paracetamol comes in multiple flavors. Now this is one area of development. Now what all, how much research and how much data should be generated for approving such formulations? And what is the regulatory requirement? That is one thing. Second thing is that if the drug is new, if you're and the drug development takes at least 4 to 5 years or of clinical development phase. During that clinical development phase, if the formulation changes, what should be the starting point? What all how much data should be accepted by the regulatory authorities? And when the formulation changes, like the flavoring changes, now that is again an area which needs to be discussed. And yes, you have very rightly said, as the child grows, his or her experiences and thought process change over a period of time. So if the child is an adolescent, he has given some kind of, he has given assent. There is a provision of seeking reconsent. Yes, it is documented. And if the child was too young to give assent at the time of enrollment, assent has to be taken as soon as he attains a specific age.
Yes,
age of 7. So these are inbuilt. And but whether at the age of 7 years, child actually has got a mental ability to give assent or not, that needs to be assessed further.
that is the things. Yes, sir.
So Puneet, you spoke about incentives and you mentioned that this must be discussed, but you did not give your own views. I would like to hear your views on providing incentives for participation of children in clinical trials.
Sir, what I could come across the literature, what was published, is that it is a gray area actually. What it says that incentive should not be actually inducement for participation, because parents might enroll the patient subject in the clinical trial just to get some inducement, which may not be right. So the quantum of incentive that is to be given should be approved by ethics committee from a time to time. And it should be on the basis of pro rata basis, how much, for how long the child is participating in the study. But if without incentive, if giving the incentive, again, I would say that it will improve enrollment into the studies. And we will be able to generate the data which is required for scientific decision making. Until participation is, yes, sir.
Yeah, thanks for those inputs. I do think that, in a country like India, where a lot of our patients that come to especially government hospitals, they are in a socioeconomic category where even small incentives might be an inducement. And when the thing is not happening to you yourself, it's a child, and we've heard of stories about children being all kinds of things can happen with children because it's not happening to you personally. The pain is not happening to you, and sometimes parents may not even understand the degree of hardship that a child might go through. So in my mind, if somebody was to ask me, I would say, we should be distancing ourselves from incentives for child participation in a clinical trial. How desperate are we? How many products are there that are only for children? If we don't give incentives for adults, then why should we be giving incentives for children? That is my thought process. But as you rightly pointed out, this does require a lot of discussion, I suppose, and there would be other points of view, and it would be good to know those. Thanks. Thanks,
Sir,
Puneet.
maybe, sir, I just taking clue, sir. Maybe like, let's say we have a rare disorder, and we are enrolling patients from registries. So the patient or the participant or the parent may not be willing to come again and again to our center because ours is a tertiary care center, maybe where this trial is going on. So in those situations, maybe incentives could be justified basically because since the disorder is rare and it has to be decided on a case-to-case basis. We cannot have a blanket statement for that. This is what I feel, sir.
I agree with you. So depending on the rarity of the disease and how difficult it is to get patients for that. And therefore, certainly reimbursement of travel and things like that are absolutely necessary. Maybe we should go beyond that to think of, if a parent is accompanying the child, then the loss of wages for the parent, and that needs to be reimbursed as well, which we normally don't do for other kinds of trials. And, to some extent, we might go beyond that as well. Agreed.
Thank you, sir. It's an excellent discussions with you, and your presentation is very good. May I now, without any delay, I switch over to our next speaker, Dr. Orkopal. He has done MD and DM Clinical Pharmacology, and he is an assistant professor at AIIMS Kollani. And his topic of discussion is clinical pharmacological considerations and challenges in pediatric prescribing. Thank you.
Thanks a lot, madam. I really thank the organizing team for giving me this opportunity. And after 2 days of intensive clinical pharmacology related discussions, I think my topic, the way I have prepared it, is mostly focused to postgraduate residents per se. So my topic for today is clinical pharmacology considerations in pediatric prescribing. And it's great to present after Punit sir and Handu sir being one of the chairpersons. They are my mentors from my DM, and some of my faculty, like Dhaneria sir, Tripathi sir, with whom I have worked for a long span of time of my infancy career. So I have recently joined AIIMS Kalyani as an assistant professor. So I am a very newbie in the faculty life, and this is my first talk after becoming a faculty. So I'll start. Yes. So one of the residents here was I was talking to him, and he was saying that the topics which we have are very advanced in our conference are very advanced, and those kind of things will not come in their PG exam questions. So I can assure you that the most of the topic discussion which I'll be doing will be based on the basic pharmacokinetics and dynamics, and we'll try to correlate with all the clinical research aspects also. So firstly, this is my brief agenda, and we'll be focusing on certain very basic kinetic parameters, and then the importance of irrational prescribing in pediatric population. And lastly, we'll conclude our talk with certain tools for rational prescribing, which were developed in the past. So recent mishappenings have been a point of concern for all of us, and this is one of the very recent ones. Like as of first week of August, this report was presented in one of the newspapers. Like WHO has issued a caution against Indian cough syrup, and this time it is in Uzbekistan and not in some African country like the previous ones. So these have become very common. And the coming to an ideal medicine for a children. So WHO states that any medicine which suits the age and physiologic conditions and body weight, and it is easily delivered to a child, should be considered as an ideal medicine. And now coming to all the pharmacokinetic and dynamic parameters, as we know that pediatric population, pediatric age group, or the pediatric body per se is very significantly different from an adult body. And there are various kind of, physiological changes which incur with passage of time from a neonate to an infant and to a children to adolescent. So these kind of changes are very, very important in understanding the functioning of a drug in the body. And so the kinetic parameters are altered, as well as the dynamic parameters, specifically the number of receptors, their activities, the affinity of the receptors are highly variable. So these changes with disease severity, with comorbidities, various age-related factors also. So now coming to certain, we'll just rush through some of the points for with consideration to absorption, the pharmacokinetic parameters like liberation of a drug from a formulation. It can significantly differ the gut transit time and the intestinal fluid composition also, and these can affect the drug dissociation. A very simple intestinal transit times are very higher. These are shorter in younger children, which may reduce the amount of drug transport, as the drug will be very fastly moving through the intestines, as well as there is change in the gastric pH. Okay, and the gastric pH in the newborn is very alkaline, where over time it becomes acidic, and bile secretion is also altered in the first 2 to 3 weeks of life. It is known to be poor with luminal concentration, which is much lower than that of the adults. And the intestinal permeability is also very different. So these affects the absorption and distribution of the lipophilic drugs as well as the hydrophilic drugs in the body, and large volume of distribution in infants is seen with lipophilic drugs as compared to older children. Now coming to a very important factor like drug distribution, what happens is, if you see in the neonates, there is a reduced number of the reduced concentration of total proteins, plasma, albumin, globulin. Apart from unconjugated bilirubin and free fatty acids, all the plasma proteins are reduced, and over time the gradual normal levels are attained in the and as soon as as soon as the age increases, all these convert into adult concentrations. So now but some points pertaining to metabolism of the drug. So microsomal protein content in the liver increases with age, and this is very, very important for metabolism of the drug. And we can see from this image, and this has a very significant impact on pharmacogenetic considerations. As we can see, if you see the blue line is basically normal metabolizers, normal metabolizing protein expression, it increases as the child grows from neonate to infant to child, to a child, then preteen, and it attains adult level, whereas the poor metabolizers remain low. So the difference in concentration of the drug in a neonate is very similar to each other, whereas there is a difference as soon as the age increases. Now, if you see the elimination perspectives, the GFR gradually increases, and it from the neonate perspective, it increases, almost doubles within 1 week and reaches adult value by the end of first year of life. So these are certain. So to summarize, all these parameters significantly influence the effect or the absorption, distribution, metabolism, and excretion of a drug, and basically alters the effect. So now a formulation, because we have discussed so many events have occurred, formulations play a very, very important role, specifically the taste, odor. As sir was saying, there are different types of preparations, various flavoring agents are being used. The excipients have become the talk of town because of the severe impurities which are affecting, which are causing these adverse reactions. Then dosing, frequency and product stability has been a lot of concern. So I found this guideline, the STEP database, that is safety and toxicity of excipients, specifically for pediatric age group, is a STEP. It is a database which aims to improve availability and access to public, published information pertaining to excipients. And these develop a platform for systematic assessment of excipients. So this database is present, which can be used as a guideline for the industries for a quality control of these kind of formulations. Now, what are the challenges in pediatric medicine pertaining to pediatric prescribing? If you see, the developmental changes impact the pharmacokinetics of the drug in a child. Pharmacodynamic activities are also influenced. If you see taking an example, suppose a GABA receptor are very limited during the early period of life in the neonates and infancy, and gradually over a time of the first 3 to 5 years, they attain normal levels. So GABA agonist cannot be used in the early period of the child's life. So children receive a very big problem in our situation, especially in a resource deficient country, is the children are receiving medications from different settings. So some children can go directly to a general practitioner, some go to a unorganized sector, some go to quacks, some the fortunate ones can go to trained pediatricians or a specialist hospitals. So the number of medications which they are exposed to are extremely high, and the experience of the prescriber is also of a varied level. Some of them are exposed to experienced pediatricians, which the fortunate ones are actually exposed to experienced pediatricians. So their expertise are also variable. So what are the challenges in pediatric prescribing practices? So prescribing appropriate medicine of appropriate dose duration is very, very important. And another very important point is overzealous use of antimicrobials. Because these days viral flu are very common, and the treating physicians often prescribe a antimicrobial drug, which is obviously not always necessary. So overzeal of antimicrobial use for prolonged period of time can lead to a lot of unwanted side effects. Then designing better pediatric formulations, as Sir was discussing in the previous presentation, lot of improvements have been made in the recent past, which was not present before. So, and minimizing drug administration errors is very, very important, and obviously minimizing unwanted exposure will lead to reduction in adverse effects. And improving drug compliance. Since our country is a developing country, there is not much regulation, the people are not well literate. So improving compliance, the counseling of the patient is as important as delivering the right medications, so that the patient or the caregiver is trained on how to use the drug and how to avoid misuse. Then again, rampant self-medication practices is also very, very common in our country, as the caregivers, the parents are always itching to, give the children treatment for any minor symptoms, which are not always necessary. Now, drug evaluation, if you see pediatric drug evaluation, evidences are generated from various sources, and evidence from adequate and well-controlled investigations, specific to pediatric indications, are different from indications approved from adults. So if you see the first point, so this is like developing a new drug through a whole chain of drug development process to approve a drug which is different from pediatric indication, and it will incur a lot of cost. But commonly what is done is the evidence is generated from pediatric population to support the same indication approved for the adults. And studies in adult populations have additional information in specific pediatric population. So basically you conduct a trial in the adults and you extrapolate those data to pediatric population. We conduct a trial in adults and we do some add-on studies in pediatric population just to validate the use in pediatric population. So the second and the third point are most commonly performed in routine practice, while the first one seems to be ideal, but it is always not feasible, and it is extremely expensive, as well as is not always ethical, as Sir pointed out earlier. So now coming to rationale of extrapolating approaches, if you see the EMA and FDA approaches, the adult data, whatever data we have from an adult use of drug in adults, these data are reduced by drug based on scientific rationale, and these data are extrapolated by using PK/PD studies, using PK/PD modeling, and using simulations. So these data are extrapolated to pediatric population. Similarly, FDA has also followed a similar approach where the adult data is modified according to the disease and responses to treatment, and exposure response relationships are very, very similar, and these are actually integrated into PK/PD models to infer a different dose for pediatric population. So the similar is shown in this table, where validation and extrapolation in pediatric subpopulation are basically categorized based on the data which is available in adults. And these validation methods are the usual ones are the modeling approaches, the simulation approaches, and the PKPD studies which are done. And hence the data from adult is extrapolated to the children to accurately predict, to approximately predict the dose which can be effective in children. Now, the challenges in pediatric research is not limited to only the dose finding. There is limited data on efficacy and safety also, as well as the unfamiliarity with age-related developmental pharmacology in pediatric group. And obviously, there is ethical consideration with conducting a pediatric research, as Sir had earlier pointed. So this paves the way for off-label use of drugs in this age group. And we have seen the term therapeutic orphans. The children are often, they are pointed out as therapeutic orphans because there are no specific trials or research directly on the children. And there were unavailability of pediatric oral formulations. But nowadays, there are a lot of preparations which are coming up. And there is obviously our country being a developed country, unequal availability of drug across different countries also an issue. And interesting use is unlicensed use among this age group. Use of unlicensed drug is very high. Then what are the challenges in off-label? If you see the point I want to highlight in primary healthcare settings, the incidence of off-label prescription in India has ranged from around 30 to 50%, whereas the prevalence can be as high as 90%. So this is the extent of which the off-label prescription is practiced in India. And this is a concern, and the pediatric dosage regimen are usually linearly extrapolated from adult dosage regimen, which is not often the correct approach which should be followed. This leads to obviously inappropriate dosing. It can be overdosing or underdosing, since the developmental changes in the pediatric age group is not always linear. Now, lastly, coming to some of the rational prescribing tools. These tools are, I have taken these tools from a systematic review on prescribing tools in pediatric population. These are mostly focused on Western data, but I wanted to highlight this. So there are POPI scores and modified POPI score. So POPI stands for Pediatric Omission of Prescriptions and Inappropriate Prescription Tool. And there is another tool which is known as Indicator of Potentially Inappropriate Prescribing in Children. So the first tool developed was the POPI one, which had a 125 criteria. From that, it was downscaled to a modified POPI tool where around 80 criteria were present. And the 2019 PIPC tool had around 25 criteria. So these criteria were given according to the disease per se. They were developed by an expert group by a Delphi's consensus in unspecified healthcare settings, where the specific focus was on rationality of pediatric prescription. And they had pointed out the correct drug dosage, duration, drug interactions, then over prescription, under prescription, and based on that a scale was developed. But there was no focus on food drug interaction. So these were mostly developed based on Western databases. So lastly, obviously we have to do risk benefit analysis of off-label use specifically and these kind of vulnerable population. And a clinical pharmacology presentation is not complete without a safety, a slide on safety parameters in pediatric prescribing, especially where multiple medications are very commonly used. So adverse drug reactions are one of the most commonly underreported. It is even more important because off-label use of drug is high, and inappropriate and irrational drug usage is also on a rise. So, summary to conclude, pediatric dosing is a very complex interplay of physiological and anatomical changes, and optimized therapy is need of the hour, and polypharmacy, especially in our settings, has to be reduced. And as Madam had introduced, every child are not mini adults as considered in many cases. So that's all. Thank you very much for the patient listening. And before I conclude, that we had an extensive discussion yesterday regarding the clinical pharmacology services and all the services which can be delivered. So our institute is a very new institute. So I am attached for the last 7 months. So it's a 3.5-year-old institute, and we are happy to say that we have started TDM services in collaboration with biochemistry department. So they are doing the analysis and we are reporting. They are doing the assays and we are reporting and doing the clinical modification. We have started for 2 drugs as for now, lithium and valproate, and pharmacovigilance and other services have also started, and we are planning to open the clinical pharmacology OPD. So hopefully the things will run in a good path. And my mentors are here, Professor Handu sir and Punit sir, my mentors from my DM days. So in AIMS Rishikesh also we were fortunate to get funding from central government, and there is a full functioning clinical trial unit set up where around 8 to 10 people are working. There are CRAs, trial project managers, and data entry operators associated with the clinical trials. And as of now, around 5 to 6 trials are underway in collaboration with oncology, hematology. So it's although there is a lot of scope ahead. So these are some of the points I wanted to share. Thanks a lot for patient hearing.
Thank you.
Sir? Ramji sir is here. Yes, sir.
Thank you. It is an excellent presentation. May I now request Professor Shoilendra Handu sir to say something? Sir? Sir, please unmute yourself. Yes.
Good evening, sir.
Yeah. Okay. Yeah, I think it's a moment of pride for me that our dear student Dr. Arkapal is presenting, and so I'm so happy. And I think you can carry on with the discussion. I think it was an excellent presentation by Dr. Arkapal, and he highlighted most of the areas of challenge while prescribing in pediatric population. So if there are any questions from the audience, both offline and online. I think back to Dr. Shabnam.
Yes, sir. Sir had some question. Sir had a comment. Bhaskar sir.
Okay. Not a question, but a couple of points. One thing which I think we generally tend to forget is that when we talk about pediatrics, whether it comes to clinical trials or whether it comes to prescribing, we are actually not dealing with a single population. We are dealing with many subpopulations, because within pediatrics also we have preterm infants, we have neonates, we have infants, we have, say, children in the 5 to 7, 7 to 12 age groups. So it itself is a heterogeneous population, which further makes it more complex, because any study which is done in, say, neonates is not applicable, or rather the generalization would be to that specific population. And second thing is just a suggestion from my side. Of course, we are very early in the stage of the society, but can we come up with a statement or, say, recommendations for pediatric clinical trials or guidelines or for prescribing or something like that? Maybe later on, once things get rolled out. That was all. Thank you. Yes, of course. Of course. Okay. Thank you, sir.
No, this is Because you told 3.5 years is AIIMS Kalyan started. Huh?
Yes, sir.
Yeah, because I went there, I think, 2 years ago to take MBBS student. That time it was 50 students. Now it is.
Yes, sir. Now it is 100, sir. 125, sir.
But you have good setup. And that boy who was alone that time.
Yes, sir.
Who's his name?
Kaushik, Dr. Kaushik. Sir.
And now I think full team.
Yes, sir.
So
Yeah,
you take a challenge, you start their separate unit of clinical pharmacology.
Yes, sir.
And do something so that your boss will be proud, we will also be proud. Okay?
Sure, sir.
Now, this is actually giving me an idea about, we have guidelines for adult clinical research. We have guidelines for pediatric clinical research. I was just wondering, there is another lecture we are waiting for, that is fetal pharmacology. So what about fetal clinical research, if you think of? There is no guideline really. That doesn't fall under pediatric. It's yet unborn. Okay. So just going through that maternal fetal medicine and obstetric research. There is a group, fetal surgery clinical trials. This is Mayo Foundation. So we can try to understand this matter. Of course, we are going to hear Dr. Shumal Sen, who has a lecture now. But then Dr. Orkopal, you can also think over that, put some thought into it. And then again, coming back, maybe nothing is there. So this association can think of developing some kind of a guideline or can put forward to ICMR. Whether ICMR can come up, maybe in 3-4 years' time, we can also think of having clinical trials or the interventions, medical interventions during the fetal stage. There are some areas where there is a need and people have also tried, and there are some interventions that are already in practice, although it might not be very common, but then there is an area. And besides clinical pharmacologists who can actually develop insight and put their advisory. I thought it is worthwhile to mention here. Thank you.
Thank you.
Perinatal clinical pharmacology. Yes.
Thank you. It is a
Thank you, ma'am.
wonderful,
Thank you.
wonderful and excellent presentations. May I now request Dr. Shumal Sen. He has done MD from CMC Vellore and DM from School of Tropical Medicine, and he is my co-PDT. He is now attached as an assistant professor in Ghosh Medical College, and his topic is, sir already mentioned, trains in fetal pharmacology. Let's hear from Dr. Shumal. Ghosh Medical College. It is near Durgapur.
It was a very nice session since morning, and the previous two discussions was very important, and it will be as a continuation. And I'm very fortunate that there is no overlapping, because we speakers, we do not have any discussions earlier that we will made it like that way. But I'm fortunate that there is no overlapping part from my side. So to start with the fetal pharmacology, the very important aspects will be the how to assess, and definitely the dosing, dosing in terms of not always the fetal therapy is required.
And then you can continue with your talk and then.
So the thing is that how the dosing, if at all required in some cases, how it has to be done, and specifically the designs for studies, how it has to be. আমারটা স্যার এখানে সাপোর্ট করছে না, আমার পেন ড্রাইভে আছে বাট সাপোর্ট করছে না সিস্টেম, আমি পেন ইয়েতে দিয়েছি।
It will be.
So the important thing is that the kinetic part and the extrapolation that we were discussing, that we were discussing for newborn. But definitely, if any dosing or anything we are planning for fetus, if at all we are planning, in that case, there also should be some study. So here this PBPK is very important. That is the pregnancy physiology based pharmacokinetic model. And that one really helps in case of these fetal issues. We will discuss to some extent regarding those points. Is it uploaded? Can I change it from here? So as we all know the basic about the fetus, that the intrauterine life, the fetus always exposed to series of drugs and toxic substances that the mother is taking. And that effects can be immediate, that can lead to fetal death, that can be just after birth, or that can be delayed effects. So all these three possibilities will be there. And the correlation of this intrauterine exposure to the drug and pathological damage, that assessment is very difficult because we are unable to do the study upon that. But we can just do an association or assume that there may be an association between this drug exposure and the risk. And we know that from the history, a landmark drug that is the thalidomide, how that history is giving us, or that acts as an eye opener. The placenta is actually an organ which offers a safeguard environment to the fetus, and placenta do have lots of. Is it okay? And the placenta actually protects us from protects the fetus from lots of hazards, definitely from the drug exposures and other issues. Now we know that this is from our medical school, we understand and know about this fact that the simple diffusion mechanism and the active transport mechanism. The simple diffusion mechanism, here the majority of the drugs crosses the placenta, and concentration between the this maternal and fetal circulation will be there, and basically it depends upon this physiochemical property, that is the lipid solubility, degree of ionization, and the molecular weight. Mainly these three properties. And active transport, again we know that there should be certain method for this active transport process, and certain endogenous compounds like amino acids, creatinine, sodium, calcium, phosphate, they usually utilize this method. Now transport of some very important molecule like glucose, vitamins, micronutrients, and iron, along with some other things like insulin. Right now I'm not going to discuss individually, but just highlighting point that the glucose usually by the facilitated diffusion, and vitamins, again they do have their own mechanism of transport. Micronutrients and iron, again that too also have the same mechanism. And again, if the transport is not acting properly, in that case, fetus will be devoid of that important vitamins, and there may be a developmental problem or a birth problem or a birth defect. That's why at the very beginning, from the commencement of the pregnancy, lots of important vitamins and important things that is given to the mother. Now insulin, we know that it has been shown not to cross the placenta in significant amount in human being, but that is having a certain receptors, the IGF-1 and IGF-2 receptors, through which it causes the development. We know that there is this important two things, that the lipid solubility and the protein binding, which two actually regulate the placental transport. Regarding the lipid solubility, we know that this is due to the flow dependent that occurs in case of this maternal
and the fetal circulation. And here the high permeability of the placenta to these drugs is actually reflected by their rapid transference. And sometimes in case of labor or during labor, when there is a contraction, in that case, the flow is reduced and that leads to decrease in the maternal-fetal circulation. Next is regarding the protein binding. We know that there is the maternal side plasma protein and the fetal side plasma protein. Both the sides, if the drug crosses the placenta, that will be binded to the maternal side. After that, after crossing, it will bind to the fetal side plasma protein, and there will be a time-taking procedure. Now, if the drug is a highly plasma protein bound to the mother, in that case, the duration of action and the crossing the placenta, that safety issues will be there, and we have to think about that whenever we are prescribing a drug to a mother for terms of safety of the fetus. We know that this is again a very well-known picture from our pharmacology classes, that the absorption, distribution, metabolism, and excretion model. And here in case of mother and fetus, we can see in the left side and in the right side. In the left side, the bound and unbound form, we know that the unbound will cross the placenta and go to the fetus side. And after going into the fetus side, again, that will be either bound form or it will be metabolized. And if it is metabolized, it will be excreted into the amniotic fluid. And we know that in the fetus, the amniotic fluid will be swallowed. And after that, again, there will be two possibilities. One, maybe it will be in the fetal gut, or it will be again unbound form or go to the tissues. So if we move one step ahead, we will see the PBPK model. That is the that is the pregnancy physiology based pharmacokinetic model. Here, normally PBPK model, this last part is absent. That is the fetoplacental unit, what we can see. But in pregnancy, this is one extra unit that we can see in PBPK model. That is the in the lowest part that is shown. That is the fetoplacental unit, and that fetoplacental unit is so the fetoplacental unit, that is a extra part if we do modeling for fetus and the dosing calculation for all those purposes. So here we can see that the from lungs, adipose tissue, bone, brain, all the tissues has been included. And here the fetoplacental unit, in the right side, the arterial, and in the left side, the venous blood. Now we know just a few basic points about the PBPK model is it will actually a predictor for the maternal and the fetal exposure of the drugs. So by integrating some important points like physiological data, preclinical data, and clinical data. So these three are the key points that is fed into this PBPK model in pregnancy, and that can be used to predict the maternal and fetal exposure and guide the optimization of the maternal dosing during pregnancy when pharmacokinetic studies cannot be readily performed. Now, we will come to that, currently USFDA and other regulatory bodies also have given a nod, not only currently, long time ago, given a nod, and lots of drugs getting approval based upon this PBPK model. So validation of this model is a very challenging issue due to limited clinical data. So among these 3 points, the physiological data, preclinical, and the clinical data. The clinical data, getting that clinical data is very crucial, and that is very important, but that data is lacking to some extent. So the validation of these models is challenging. Now, PBPK modeling can also serve as a tool to guide the drug dosing during the breastfeeding based on the drug transfer through the human milk. Based upon the same model, in the breastfeeding women also, they can have the similar simulation technique, and the maternal and the newborn exposure to the drug, or the probability of exposure of the drug, if I say correctly, that can be assumed. So here we can see, though this is a little bit busy slide, in the left side we can see the ideal studies. In the middle part, we can see the next best alternative, and in the right side, we can see the alternate approaches. The ideal studies, it's like that, the drug exposure studies in first, second, and third trimester and postpartum. But practically speaking, it's not always possible because of certain ethical issues in pregnant mothers doing studies. Next is the drug response studies over a dosing interval. We are looking into the left part right now. The drug response studies over a dosing interval, again, that is very difficult conducting in pregnant women. Maternal drug safety also, those are the difficult areas to touch. So next best alternative what we have in our hand, it's like that surrogate drug exposure studies. Some alternate marker we can utilize to have this our result. Next is limited drug response, so that the limited sampling strategy we can use. Placental perfusion, cord blood sampling, milk to plasma ratio, we can utilize. But alternate approach that will be minimally invasive and ethically correct, that is in the right side, that is the prediction based on the probe drug studies on drug metabolism, excretion and transporters. Next is the population pharmacokinetic modeling, and third one is the PBPK modeling and simulations. So these are the alternative methods that we can use, which is actually we are overcoming the ideal studies, because conducting those ideal studies in pregnant mother and sometimes newborn and fetus is sometimes maybe ethically incorrect. This one is not visible. I'm skipping this slide. So to some extent that has been covered by Dr. Orko in the previous presentation. Next, the current gap in the modeling in maternal and fetal pharmacology, it's the lack of data. In the maternal side is the main problem is the lack of data and the enzyme during the pregnancy and the postpartum period, that one is lacking. Next is the lack of data on time course changes on different transporters, that one is lacking. Lack of data from same person during and the post delivery. So majority of the cases it's from different persons. So from the same person, that one is lacking. Now, like that way, lack of PBPA models of the biologics, that is also missing. Fetal pharmacology also, there are certain gaps like actual fetal exposure and blood or tissue concentration prediction is not available. Lack of data on exposure response relationship in fetus and sometimes maternal placental fetal drug partitioning. So earlier what it was done from the adult studies extrapolation, but now as the days and research is progressing, so what we are doing, we are actually making this model that is fitting the mother and the fetus, and after that we are feeding with the correct data of previous studies, and we are simulating this for the present situation for that particular fetus or the mother. This is another way, that is the probe drug based studies. Probe drug is actually a drug that is utilized for having or knowing the pharmacokinetic properties. It's like enzyme or transporter activity determined using this probe drug data, which is specific to the trimester. So say for example, if the probe drug study has been done for third trimester, we cannot utilize it for first trimester. That will be only for third trimester and only for that drug or a similar structured drug. So we can see at the end the example that K et al. Refined a previously published PBPA model to include the CYP3A4 activity changes during the third trimester based on data from probe drug midazolam and used it to predict the exposure of nifedipine and indinavir in pregnancy. So this is another way. So the drug placental metabolism, the placenta is able to metabolize the drugs, and the human placenta is much less active organ in the biotransformation process than the liver. We know about these things, and some just a few points I would like to highlight that what are the pathological effects of drugs on fetus and the newborn that we can come across if we are unaware about the adverse effects and we do randomly utilize drugs in the mother. The fetal emaciation, teratogenesis, carcinogenesis, there's a long list. Apart from this list also other effects we can expect. Fetal therapy, we do have advanced techniques in certain centers, if at all it is required, like fetoscopy, laser, cystoscopy, cardiac valvuloplasty, open repair of spina bifida, if surgical any intervention required. Fetal therapy, if we think it as a hope for the future, we know that the enzyme and other things that is deficient, like 21 hydroxylase deficiency, certain vitamin deficiency, and that vitamin deficiency can lead to fetal birth defects. So in those cases, direct installation of those vitamins, certain essential vitamins, into the amniotic fluid by certain specific method can help to weigh out the come out the baby from the birth defect. I would like to, I'm towards the end of the session, that if we see that this is kind of simulation technique that has been used here, that this one is not working. So in the upper part is the caffeine, this is the middle part is the for metoprolol, and the lower part is the for the midazolam. That's for a bound and unbound drug, or predicted and unpredicted. So here we can see in the left part is the non-pregnant, and in the right part that is the pregnant, and that is for plasma protein bound and CYP enzyme functioning or not. So here we can see in the upper two panels the change of the area under the curve, change in the area under the curve, and the Cmax. If we see the table also along with this graph, we can see that there is a change in the Cmax also. But in the lower part, the midazolam, the predicted value and the normal value that you are getting, this almost similar, or that's touching. So if we are focusing on some regulatory issues on this PBPK, it's a viable alternative to generate the clinical data in special patient population, and regulatory agencies such as US FDA and the European medical agencies have accepted the use of PBPK modeling to facilitate the decision-making process for conducting clinical study in submission for IND and NDA. So with that, I would like to thank you and thank the organizers, especially team ACPICon.
Thank you, Dr. Shoibal. It is a wonderful presentation. And may I now request Dr. Handu sir to unmute yourself, and if you have any comment or anything to say.
Okay, thank you, Dr. Shabnam. I think this was a lucid and erudite presentation by Dr. Sen. And I think this is an emerging field, fetal pharmacology, and a field where I think as clinical pharmacologists we can contribute by doing studies. I think as Dr. Shoibal has mentioned, that regulatory framework is being worked out for fetal interventional studies, that is pharmacological studies. So this is a field wide open for work as clinical pharmacologists we can do. And I would like to ask about the regulatory framework, as what he was mentioning about PBPK modeling. Is it something approved by FDA or any regulatory authorities?
Yes, sir. And there are studies. Actually, in this presentation, it's not included, but there are studies, lots of studies which has been approved by FDA, and there are lots of drugs also that has been approved based upon this PBPK model.
There is the issue of sampling. So, in case of fetal pharmacology, how can we have to resort to cord blood sampling if we want to do pharmacokinetic studies, or is there any other way?
Yeah, that's the challenging issue, sir, that the three pillars for PBPK model, upon that the clinical data and the fetal sampling. Usually sometimes what is done is from the animal studies that is included, and animal study from there, again another modeling is done, and that one previously some other study was done on the fetus, and that one is actually matched. And sometimes if at all no studies is there, in that case it is mandatory to have fetal sampling and have to do the preliminary study. So that's the crux, that there is very limited clinical data, but with the data that is available as of now, we can go ahead and do a lot of work, but that is a bit complicated in structuring the model of this PBPK. It's certain methods are there. I do not know in detail, but there are methods for doing this fetal sampling. Yes.
Okay, thank you. Back to Dr. Shabnam.
I think there are different angles to look at this. Number one is if you think of observational studies, okay, whether or not it is indicated there are many situations where mothers are exposed because of the maternal indications. Okay. In a normal pregnancy, healthy mothers, we try to advocate that don't use any medication unless it is really very much needed. But otherwise, in certain situations, medical conditions, comorbidities, etc., where mothers are exposed to medications, and then at the same time they are conceiving, and then in many situations, if the pregnancy is aborted for any reason, here lies a great scope that once it is aborted, and then you can try to sample that fetus and amniotic fluid and think of doing some research. What was the impact of that exposure, okay, on the fetal growth or development, okay, depending on the antenatal, okay, age, etc. So this is one way one can think of if we try to develop do some kind of research in fetal medicine, and there should not be any kind of regulatory, limitations or anything. Nobody can prevent us. The second thing is about the other kind of research could be that the indication is actually maternal indication. Okay. And when you are using drugs for maternal indication, what is the impact on the fetus, the exposure? One, of course, you are trying to do that observation studies, but otherwise there are very advanced imaging that has come up as compared to say 20 years back or 30 years back. So whether you can also think of trying to generate some data, okay, without any invasive kind of thing, just by imaging. And so this is another way of trying to capture data. And I'm talking of broad fetal research, okay, fetomaternal research, or with a focus to understanding the fetus, okay, how much the fetus might be at risk of exposure, maternal exposure. Because when you are trying to treat the mother, despite we do not want, because there is a problem of selectivity, okay. So you cannot be too selective that only the mother will be treated, keeping aside the fetus. Fetus is also exposed. So one is, otherwise there is abortion, medical abortion or whatever, you get the opportunity of getting the fetal tissue, etc., do some research there. Second is non-invasive imaging, by which you can try to see what is the impact of the exposure. And the third is, of course, fetal indication, specific fetal indication for which you have to try something. And there lies the issue, how, whether we have some regulations, whether we have some guidelines, how are you going to deal with the ethical issues leading to such kind of a trial, where I would say it's an intervention study. Up till now, most of the fetal interventions are surgical interventions. But there are also genuine areas where medical interventions will also be required. In certain areas, they are already established, but there are many other areas where we can think of. So it's good that intentionally, strategically, we have included this particular lecture in order to, okay, delve into a relatively less traveled area where we can start thinking about this. And maybe next time when we meet, maybe after a year or so, we'll see some of our younger friends, they have given more thought into it and trying to develop a project proposal, research proposal, sending it to ICMR or other funding agencies. Try to see what is this thing. Let us start this new area, which is yet untraveled. That was the purpose. And that way, Dr. Suman has done a marvelous job and ignited our thought process, stimulated us. Let's hope we'll be in it. Thank you very much.
Thank you, sir. Actually, I am very motivated, and the one thing ignited me very much, that thing that you have mentioned. There was, if the baby has 21 alpha hydroxylase inhibitor enzymes, so there will be congenital adrenal hyperplasia. So if mother will be treated with dexamethasone, if this is possible, then it will be very good. If previously we can do these things, because congenital adrenal hyperplasia is, though it is rare, but it is there. There are lots of cases with congenital adrenal hyperplasia. So if that kind of things are, we can, like fetal pharmacology that trains, we can think and do that. That sir has told, and you have mentioned lots of things about PPBBK, that things will help.
Another
in
very
future.
important area is the HIV infected mothers.
Yes.
So here lies the very importance that we know that there will be transmission, and we know that these are the drugs which prevent transmission, but we are not sure that this will definitely prevent and treat the fetus. So how to handle? So this is a very important area. And here these models and all these things very much help that if we increase this much of concentration in the mother, the drug concentration, in that case, that model will predict that in the fetus, this much drug will be there. So that way we can actually counter regulate and treat the fetus. So otherwise what we have done earlier is just preventive purpose medicine, but we are not sure that how much it will help.
Yes.
Thank you.
It seems like he's very much interested in this field. It is really a unique field. And why don't we fix him to take it forward? Right. And we'll help. And there is suddenly, as Dr. Tripathi told, that this artificial intelligence, and through this, non-invasive methods will be there. So it is quite known, even undergraduate student knows this chloramphenicol Grey syndrome, then this tetracycline causing these problems. So unintentionally, if mother take that, and their sample can be even from amniotic fluid or without harming the baby, the infant, we can do some works. And it will be marvelous work. Go ahead. We'll support you.
Thank you. So the session, I think the session is ending, and so we will looking for tea break. Oh, sir, please unmute yourself if you want to say something. Please conclude the concluding remarks we want to.
I think this was an exciting session with three interesting presentations. I would like to thank Dr. Puneet, Dr. Arkapal, Dr. Somalia, and my co-chair, Dr. Shabnam, for this interesting and exciting session, which opens up a new vista of work and research for clinical pharmacologists. And so thank you all. And it was my pleasure to join you all for this session. Thank you.
Thank you, sir.
Thank you, sir. Thank you very much. And now may I request Professor Nihar Vishwas, sir, to kindly felicitate Dr. Shobnam Ara Begum. Also, may I request? May I request Dr. Arkopal to felicitate Arkopal. Shumallo Datta. Also requesting Dr. Shumallo Sen to please come. Thank you, Handu sir. Thank you.
I would like to just my regards to Professor Biswas and Professor Tripathi.
Thank you very much. Thank you.
Thank you very much, Chandu. Thank you.
Now we are moving forward to the next session, and that will be an interesting one. And may I request Professor Santanu Tripathi sir to kindly chair the session. And we have with us today one of the eminent endocrinologists, Dr. Soumik Goswami, with us. He is now the assistant professor, associate professor at Department of Endocrinology at NRS Medical College. So over to Chairperson, sir.
So I'm honored to introduce Dr. Soumik Goswami, and who has already been introduced. And Dr. Soumik Goswami will be the lecture topic is continuous glucose monitoring, a pharmacodynamic tool in diabetes research and therapeutics. Dr. Goswami, please.
Thank you, sir. A very good evening to everyone. So we know that there's a saying that if you cannot measure it, you cannot improve it. So measurement of blood glucose has been at the core of good diabetes management. So we know that initially, historically, ants were used to see whether urine had glucose or not. It was manually tested using one's own tongue. The laboratory tested glucose thereafter in the urine initially, later on in the plasma. And finally, over the last 2 or 3 decades, we have been using glycated hemoglobin to see whether blood glucose is at control. And more or less, glycated hemoglobin is the pinnacle of glucose measurement because all the major trials have been designed showing that if you reduce glycated hemoglobin, you improve outcomes. So the question that we need to answer today is that beyond glycated hemoglobin, do we need something more? And if that something more is continuous glucose monitoring, how is it going to improve outcomes? A slight change. So HbA1c, we know that is a sort of an average. It's the mean glucose level over the last 3 to 4 months. Glycation of hemoglobin, glucose and hemoglobin forms glycated hemoglobin. But if you look at certain examples, for example, if you look at 2 patients on the left, the first patient has glucose levels going all over the place, very high, very low in the same patient. If you do an average, the HbA1c comes out to be 8. The second patient has small variations, but again, the average HbA1c is 8. So among these 2 patients, I think it's simple logic that the patient below is doing much better than the patient above. Similarly, if you look at the other 3 examples, the blue zone refers to the good glucose level, say between 80 to 180. Anything above that is dark blue, high glucose. Anything below that is gray, hypoglycemia. So if you see these 3 examples, the one on the right has perfect glucose levels. The one on the left has hypoglycemia, hyperglycemia, a small time spent in perfect glucose level. But you do an average, all these 3 individuals have similar HbA1c levels. So these examples sort of point to the fact that HbA1c is still not the perfect marker of glucose control. It does not give us the variability of blood glucose levels from one point of time to another within the same day or between days or between weeks. So this glycemic variability is something which needs to be looked into as well. The reason being because not only for academic reasons, but it has been seen that beyond HbA1c level, glycemic variability increases the risk of vascular complications and death. 2 individuals might have the same HbA1c level of say 7.5 or 8 or 7.1, but the one with higher glycemic variability, more fluctuations, will have a worse outcome, both in terms of having increased micro and macrovascular outcomes and possibly an increased risk of death as well. So we have now moved from fasting and postprandial glucose and glycated hemoglobin measurement alone to the measurement of glycemic variability to see whether an individual with diabetes maintains glucose within a certain range, the so-called time in range. And there are certain guidelines which have stated that this is the sort of perfect time in range that will reduce glycemic variability and will help maintain A1C within the target level as well. And if you look at the leftmost bar, that applies to most patients with type 1 and type 2 diabetes, where about 70%, at least 70% or more of the time should be spent in the green zone, that is in range. Less than 5% of the time should be in the red zone, that is below range, time below range. And less than 30% of the time should be in the above zone, that is time above range. So 70% should be, say, between 70 to 180 milligrams per deciliter. Less than 5% should be less than 70 milligrams per deciliter. Less than 30% or less than 25% should be in more than 180 milligrams per deciliter, that is time above range. And depending on the risk of hypoglycemia or whether you have gestational diabetes or not, these parameters can again be altered to a certain extent, but the leftmost bar pertains to most individuals with type 2 diabetes. So the next question would be how to do this monitoring. You cannot keep on measuring the blood glucose level using a finger prick glucose meter throughout the day. It would be extremely painful. A lot of charting needs to be done, and it would be impractical. So we now have these devices. These devices actually were launched in the late 80s. From 1999, they have been approved by the US FDA. And we now have these devices called the continuous glucose monitoring systems, which consists of a simple sensor which is placed over your skin. It's usually placed over the posterolateral part of the arm, the one which is popular in India. It has an electrode which projects through the skin into the interstitial space, and it measures the interstitial fluid glucose, which sort of equilibrates with the capillary glucose with a time lag of 8 to 10 minutes. So the capillary glucose, it diffuses into the interstitial space before reaching the adipocytes. This interstitial glucose is picked up by this sensor through near field technology or Bluetooth technology. It transmits this information to a receiver, and it transmits this information every 5 minutes, giving you as many as 288 readings per day. And the very latest ones which have been launched measure it every minute, every single minute of the day, giving you even more readings. Now, the receiver that I've shown here is somewhat of an antique receiver. The receiver that is used to capture these blood glucose levels every 5 minutes looks more like these, which have been shown in the image. Now you can even use smartphone apps tagged to your sensor. You do not need to buy these receivers. You can simply buy the smartphone apps, and the results will show you in your smartphone as well. Of all of these which have been shown in the picture, the two which are available in India are the Medtronic one and the one which is shown there, which is the Abbott one. A disclaimer, I have not received any honorarium for speaking in this lecture anyway. So the main difference between the Medtronic one and the Abbott one is that the Medtronic one is a real-time CGM, which means that on its own, it keeps on taking the readings every minute or every 5 minutes, depending on the generation of the machine that is being used. However, the user needs to check the blood glucose at certain points of the day using a glucometer, a conventional finger prick glucometer, and it needs to be calibrated. The sensor needs to be calibrated with that finger prick reading. And this sensor can pick up at the most 3 to 5 days of glucose data. The more popular one, which is mostly used when we need to use it, is the intermittently scanned one, which gives you 14 days worth of data. You do not need to calibrate it with finger prick, so it's absolutely painless in that sense, except for that single prick when you are inserting the device, and the cost is much lower. However, you need to scan it at certain times. At least every 8 hours, you need to scan the device to generate the last 8 hours worth of data and pick it up using the receiver. So finally, when you have used the device, you get a report which looks something like this. These are the 3 main things which are found in a continuous glucose monitoring report. So it's not very clear, but what is shown there is that 14 days, so 2nd April 2021 to say 16th April 2021, the sensor was there for 14 days. As I said, this is the most popular sensor which is used. If you look at the percent time the sensor is active, 88%. So it was scanned at frequent intervals, as I said, at least every 8 hours. So for a good CGM report, there should be at least 70% of that 14 days worth of data. That is at least 10 days worth of data. So here it was 88% scanning. So this is a good report. If you next look at the time in range, you have a green part, which is 55%. So the person is not maintaining more than 70% time in range. And of course, there are hypos, about 11% is the hypos, experiencing a lot of hypo and experiencing a lot of hyperglycemia as well. If you look below there, there is something called the glucose management indicator, which is nothing but a derived HbA1c level, which means that from the average that it picks up, it gets hundreds and hundreds of readings. It does an average over those 14 days and extrapolates it to give you the HbA1c level for that 14 days. And this actually is possibly even more accurate than the HbA1c which we get from the laboratory, because we know that there are factors influencing the glycation of hemoglobin. There are factors altering the lifespan of RBC, all of which can be overcome if you simply measure the interstitial fluid glucose. So it gives you trends in HbA1c, a very accurate measure of HbA1c. If you look at the graphs that you get with this device, you get each individual day's data, Saturday, Sunday, Monday for 7 days and another 7 days. You get all the peaks and troughs over the 14 days. And all these 14 days glucose is again put into, using the software, it's put into a single day called the standard day or the modal day. The graph which you see above, it's a combination of all those 14 days data. It has a central blue line. That's the median glucose over those 14 days, the central blue line. Above and below the central blue line, there is a slightly dark blue zone, which is the 25th to the 75th percentile, the so-called interquartile region, which is about 50% of the values over that period. And you have a lighter blue zone above and below, the 5th to 95th percentile, the so-called interdecile zone, which again is wider fluctuations over those periods. Beyond that, everything is an outlier. So just to give you a brief idea, again, continuous glucose monitoring system is very complicated. Even I don't have 100% understanding of the same, but I'll just give you some basic idea of what we can derive from it. So as I said, there's a 50% zone, the interquartile range, and a bigger zone, the interdecile range. The interquartile range, if you look at the second example, if the interquartile range is wide, it means that some therapeutic problem is there. The dose of insulin is not correct, or the insulin and the carbohydrate in the meal is not matched well. On the other hand, if the interdecile zone is wide, 5th to 95th percentile, it's a behavioral problem. The patient misses insulin, does not exercise, takes a lot of carbohydrates, misses a meal, etc., or consumes alcohol frequently. So practically, how can, if you look at the overall picture, how can the continuous glucose monitor help us manage diabetes better? If you look at this example here, you can see that this patient is experiencing hypoglycemia at least at 2 points of time, early in the morning and in the post-lunch period, when the median, the 50th percentile line, is dipping below 70 milligrams per deciliter. And of course, the interquartile range, a part of it is also going below that zone along with the interdecile range. So this helps us identify the problem, the time of the day. So he could be taking too much of basal insulin at night, or taking too much of a prandial insulin, or going for a jog early in the morning without taking any carbohydrates, or consuming alcohol at night. This graph will give us an idea of when and how frequent hypoglycemia is happening. It's the same with hyperglycemia. If you look at this graph, this person has, if you look at the bottom, the x-axis, of course, I should have told it earlier, the leftmost point is 12 midnight. The rest is the night part of the day, the morning, the afternoon, the evening. So you move from 12 midnight to 12 midnight as you move along the left axis. So here again, you see that this person has nocturnal hyperglycemia, post-lunch hyperglycemia, post-dinner hyperglycemia. So the post-dinner hyperglycemia is possibly contributing to the nocturnal hypoglycemia, and there's a post-lunch hyperglycemia as well. So he's either taking a lot of carbohydrates at night, or the insulin dose at night, or the insulin dose before lunch is infrequent for this given individual. And there are individuals who have a lot of variability, but if you look at their pattern, they show an interesting pattern. For example, if you look at the individual day pattern below, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, Monday, over 2 weeks, you'll find that most of the problem is happening at the weekend. Friday, Saturday, Sunday, there's a lot of hyperglycemia. So he might be not exercising on those days or consuming alcohol, going to parties on those days. So it also gives you an idea of the specific lifestyle factor on a given day of the week, which might be contributing to the problem. So I've put in 2 basic case studies just to give you an idea of how it might help improve our practice. So this is a 52-year-old man with 21 years of diabetes, has developed severe retinopathy, A1C not controlled 12.2, complaining of fatigue and symptoms suggestive of distal peripheral neuropathy. He is taking 10 units of glargine, twice daily metformin, 1.5 milligrams of dulaglutide, a GLP-1 receptor agonist, and 10 milligrams of glipizide at lunch. However, with the glipizide, he is a bit stingy. He says that I often don't take glipizide because I feel that if I take glipizide, I feel like sweating after lunch. I might be experiencing hypoglycemia. But although he says that he sweats after taking glipizide, he has almost never measured his blood glucose. And he says that he's a busy executive, too busy to measure his blood glucose at different points of the day. So for a person like him, if you put him on a continuous glucose monitoring system, he can continue with his business, but you can get an idea of what's happening throughout 24 hours or throughout 14 days at a stretch. And what this graph shows very clearly is that I won't go into the much details, but if you look at the standard day or the modal day, you can well appreciate that the upper green line is 180 milligrams per deciliter. Most of the time of the day, he's spending above 180 milligrams per deciliter. The 50th percentile, most of the time is above that 180 milligram per deciliter mark. And he's never experiencing hypoglycemia. Even the 5th percentile line is above 70 milligrams per day. So you can use this as a visual tool for educated patient to counsel the patient that, look, this is what is happening. You have already developed complications. You are on the road to a bad outcome. So using this as a visual tool, you can shift the patient now to a basal bolus insulin. So this can be an educational tool as well. Shift the patient to a basal bolus insulin and do a repeat continuous glucose monitoring just to show him that, yes, things can improve if you follow the rules properly. So this is another second case, another man, a 71-year-old man with 30 years of diabetes. He has other comorbidities as well, hypertension, dyslipidemia, cardiovascular disease, kidney disease, A1C 8.9. He has developed moderate renal dysfunction. He is on gliclazide twice daily, metformin twice daily. He occasionally forgets to take his medicines. And although it's not very clearly visible, he was put on a continuous glucose monitor, and it was found that it was only 16% of the time that it was used, which means that he was very reluctant about treating diabetes. He had a lackadaisical attitude, let whatever happens. He spent money on putting a sensor, which is still quite costly by Indian standards, but he did not bother to scan the sensor. So this just shows that in this individual, what is required is not any costly therapy, but simple good counseling. If this individual can be counseled well about his dietary pattern, exercise pattern, to stick to his drugs, DAPA was added given the renal dysfunction. Again, a simple good dietary counseling, using it as an educational tool, can help improve outcomes. So in type 1 diabetes, there's a lot of data to show that it helps improve outcomes. In type 2 diabetes, the data is limited. There is some limited data in gestational diabetes as well, but it has shown that particularly those requiring several shots of insulin per day can improve outcomes with the use of this device. So if you are thinking of using a continuous glucose monitoring device, you can consider almost any patient with type 1 diabetes to be a candidate for the same, provided affordability is there. Type 2 diabetes, receiving multiple pricks of insulin, difficult to control A1C, having hypoglycemic unawareness, severe hypoglycemia, recurrent hypoglycemia, nocturnal hypoglycemia. These are the individuals who can be considered for a continuous glucose monitoring system. So to sum up, this is a technology which is now available. It's still somewhat expensive by Indian standards, but if you can use it, it helps communicate your concern to your patient better. You can give the patient a visual representation of what is happening, where things are going wrong. After giving treatment, you can repeat it to see how your drug is working, and at the end of it, it gives you a better quality of life. Technology has changed the way we treat diabetes, and continuous glucose monitoring system happens to be the one of the latest kid on the block to help us improve outcomes. And just to give you a taste of how technology changes things as well, this slide especially, I've designed it using an artificial intelligence app called Gamma. If you look below, you just feed your query in the app and it gives you a slide. So just to give you an idea that technology is changing the way we are doing things, this is available free of cost, but continuous glucose monitoring is not. When prices come down, hopefully it will be of much greater use in our day-to-day practice. Thank you.
Thank you very much, and wonderful presentation indeed. I think we'll have a couple of minutes for some questions, comments from the audience.
I just wanted a small question of.
Yes, sir.
What is the cost of these?
Right.
The latest?
So if you put it in for 14 days, initially there's a one-time investment for that app or that sensor, or that reader rather, which is around, I think, about 5,000 to 6,000 rupees now. And if you do it every 14 days, the cost would be around 4,000 rupees.
So why would there be a cost? I mean, once you've got that.
Now you have brought the reader or the mobile phone app, but the sensor, you need to change it every 14 days. So that has a cost as well. In fact, there are two types of instruments which are available. One is a professional CGM, which the doctor can insert. It's actually less costly. But the patient has to come after 14 days and you scan and give the last 14 days worth of data. Another is a personal use CGM, which is about 4,000 or 4,500, a bit more costly, where the patient can do it on a sort of real-time basis at his or her home. So that's a bit more costly.
It's wonderful. Any other comments?
So the cost of one time using it is like 4,000.
Roughly around 4,000. So if you use it for the entire month, it's around 8,000.
Single use device.
Single 14 day.
14 days single use.
14 days single.
So, but that the device can be reused.
The reader is there, but the sensor after 14 days,
That has to
it loses all its enzymes and everything that is there. It doesn't work anymore.
Okay. That was great. I think it has been a very lucid presentation. It apparently it was complicated, but then you have made it very simple.
And the slides were just too good.
Too good. I was only trying to add this thing into it, that this kind of device or use of this kind of device can also help us as a tool for research.
So I did not put the research part because I'm not very well aware of that part. It belongs to your domain. I'm more of a clinician.
Right.
But yes, we can extrapolate these findings to the research part.
Absolutely. Dr. Mukherjee was referring to actually the monitoring in academic research. And these are the kind of tools that can actually enrich our academic research in real life situation, and with your patient registry and use of these kind of tools in your patient management. And then the data can be collated and we can see what is the extent of problems in diabetes management and glycemic control. What is the real situation? As we always say that it's not really very otherwise satisfactory, but here we can generate objective data, and by collating them, you can already you can think of having good quality academic research also. Thank you very much. Wonderful job done. No, that's a.
There's an app called Gamma. You just go to the Gamma app. If you put in a query, actually it gave me a 10-slide presentation, but I just kept the last slide just as an example to show how technology is changing things.
You just type your keywords.
You type your keywords
and it will come.
It just gives you a framework to work on. It doesn't give you a great presentation. I just put the last slide. The rest is manual, human intelligence.
Of course.
So we had actually done one small work with this CGM, and that was a 14 days study. So what we did first 5 days, we used Ishbagula husk, Ishobgul pre-meal.
For diet, for lifestyle modification, this is a very good app.
Yeah,
very good.
And we found there is a
tool rather.
Yeah, statistically significant decrease in PP sugar. The postprandial values are
Any
going
sort
down.
of dietary fiber will help smoothen the variation.
So we had done
Glycemic
one small pharmacodynamic study in STM under the SIR's guidance. One thing just I'm thinking about, because now the generic thing is coming up. whether this could be also useful
Absolutely.
in seeing the pharmacodynamics of anti-diabetic agents, switching from one brand to another brand, whether there is some
Any
differences.
change? So there are studies actually like remogliflozin versus dapagliflozin. There is a pharma-sponsored study where they have looked at this, whether there are differences in parameters. So there are some studies which have tried to look at these drug versus drug or changing from drugs with the use of these agents.
Yeah.
In
Small
fact,
studies are there.
any diabetes trial, the efficacy endpoint that can be always, this can
All
be
these
used for.
trials are in the tune of 50, 60 or 100, 150 numbers at the most because of the cost involved. It
Absolutely.
doesn't go into thousands.
So thank you very much. I think we can end the session here. Just a second. I think they're going to do some honors.
So may I request Professor Santanu Tripathi sir to felicitate Dr. Shoumi Goswami. Thank you, sir. Thank you very much. So now we are moving towards the next session, and that is on oncology. And we have two speakers from outside who will be joining virtually with us. But we are really privileged to have with us Dr. Madhu Chandha Kaur, who is a very noted clinical oncologist in this country. So she will chair this session, and we have two talk here, madam, because of some travel related issues. Dr. Devashish Hota had to leave early, but we have Dr. Praful Mohan and Dr. Pooja Gupta. So with your permission, I just want to introduce the speaker and you can start the proceeding. No. So, yeah, that was already done because he had to leave. He had to leave early. So Dr. Praful Mohan, the first talk will be delivered by Dr. Praful Mohan. He is a very noted clinical pharmacologist and currently attached with Army Medical College, Pune, AFMC, as Professor of Pharmacology. Welcome, sir. And also we have Professor Pooja Gupta, who is a professor, who is also an noted clinical pharmacologist in this country. She is now professor at Department of Pharmacology at AIIMS, New Delhi. So welcome, madam. Now over to Dr. Madhu Chandha Kaur.
Thank you, organizers, and special thanks to Professor Tripathi and Shambhu. I think we have very important speakers and session over the next half an hour. The first is welcome Dr. Praful Mohan. It's on drug targets for cancer. I think in no other vertical of medical science, every day drug targets are changing. I mean, after we finish the symposium, maybe a new drug target is coming in cancer. And again, also in diabetes, I think a lot of research is going on. So we are all really excited to hear from Professor Mohan what awaits us in the vertical of cancer as far as drug targets are concerned. Over to Dr. Mohan.
Good evening, ma'am, and good evening, my teachers who are there and also friends. At the outset, kindly let me know if I'm audible to all of you.
Yes, you're audible. Perfect.
Right, ma'am. Thank you. And at the outset, I apologize for not being there, which I wanted to do so much. But anyway, technology, let's take the help of technology. And I would like to just share my screen and so that we can go ahead. Is my screen visible, ma'am?
Yes. Go to show, it's visible.
Just a minute. I think I'll just take a moment to put it. Just a minute, ma'am. I'll just take 2 minutes to. Yeah, I think this is it full screen now, ma'am?
No, slideshow is not there. Full screen, yes, it is. Now it is.
Is it there, ma'am? Yeah, I can see it's there, right?
Yes, it is there.
Ma'am, can I go ahead?
Yes, please.
Proceed, please proceed.
Yeah. So over the next 15 minutes, ma'am, I would want to talk about the cancer cell ab initio, what makes it so special. That's going to make it easy for us to understand how to target it. I would also give you a small glimpse of the conventional anti-cancer drugs and what's wrong with them. Then go on to the targeted therapies, the new targets, and the emerging concepts. So in fact, I was thinking loudly and was telling myself, like the chair also alluded to, that this is a topic which can be talked on anytime. It can be talked on for the next 20 years as well, because this is such expanding field, and rightly so. So about the cancer cell, basically 2-3 things make it special. It's like a naughty child in the class, which cannot be controlled by the teacher. We face them so many times. And it is also characterized by the capacity to proliferate abnormally, invade other tissues, and spread to distant locations. And to do all this, it has some special needs, some of which we have been able to exploit to target it. Really, most of the times, there's a genetic mutation behind this cancer cell. And most of the times, again, there would have been an immune response to nip the evil in the bud, but it does something so that the immune response doesn't mount on it. And as our understanding of cancer biology increases, we now understand that cancer cell is not a solitary entity. It cannot be tackled in isolation. So it's a part of a microenvironment around it, which contains a lot of things, but essentially it contains immune cells, fibroblasts, extracellular matrix, and neural elements also. So it's a dynamic relationship between the cancer cell and the environment around it. So there would be targets inside the cell, and there would be targets outside the cell also. And as we go along, we are trying to tackle or identify targets outside the cell. So this is just a glimpse of certain conventional anti-cancer drugs. I'll not talk about them much because willy-nilly most of us know about them, including the students. But the problem is that all of them have got narrow therapeutic index, and they reduce the quality of life substantially. They're more like a big bomb which falls on a small village and kills hundreds of persons, whereas the target was to kill only one individual. And that's the reason why it has so many problems, and that's the reason why we keep on talking about newer targets and how to make it better. And if you can see that most of the conventional anti-cancer drugs are focused on somehow stopping the multiplication of the cell by attacking the DNAs or the RNAs. Of course, there are certain cells, certain cancers, which we know they are driven by hormones. So we target those hormones and try to stop those cancer cells or kill them. So what is a targeted therapy? Targeted therapy consists of those drugs which are targeting specific molecules which are associated in the growth or spread or progress of a cancer cell. So far, most of the targets which have been identified are oncoproteins. So basically, oncoproteins are those driver proteins which would drive the growth of a cancer cell. Oncoproteins would be produced because of oncogenes or proto-oncogenes. We talked about the mutations which are behind every cancer cell. So a mutation gives rise to oncogene, a proto-oncogene or an oncogene, which gives rise to oncoprotein. And then we try to target these oncoproteins so as to make our therapy more focused. So these oncoproteins can be of two types. They can be those proteins or targets which are essential for the survival of the cell. They can be those proteins which help the cell escape the immune response. We'll try to talk about them as an example. So basically, it's more like a sniper. You identify a particular cell and you only want to kill that cell and not cause any collateral damage. So some of the targets have already been exploited. There are drugs, already targeted drugs in the market, are being used clinically. We'll talk about some of them so as to understand how the targeting goes around. If we understand how we came here, it'll be easy for us to understand how to go ahead. So I'll just talk about 3 representative examples of those targeted therapies which are already there in the market. We all know about them, but just to put the entire talk in context. So imatinib, which is a signal transduction inhibitor, its role in chronic myeloid leukemia. So we have a genetic mutation which gives rise to Philadelphia chromosome. We have a oncoprotein BCR-ABL, which gives rise to CML, and we have a drug which will block BCR-ABL, or would rather block its tyrosine kinase activity. So one genetic mutation, one target, a drug which blocks the activity of this target, and we have a much better treatment of a disease which was not so well treatable before imatinib. So in this we are trying to target something which is intrinsic to the cancer cell. Let's take the example of bevacizumab. As I alluded to in the first slide, cancer cell is dividing rapidly. It will have immense metabolic needs. Most of the times it will be in a state of hypoxia. Hypoxia will stimulate production of vascular endothelial growth factor, which will, dock onto its receptors, VEGFR1 and 2, and bring about angiogenesis. So if you stop this angiogenesis somehow, you will starve the cancer cell. It will not be able to grow, and that's what we do by bevacizumab, which is a monoclonal antibody against VEGF. Of course, you can block the VEGF receptor as well, which we do with other drugs. So point is to stop angiogenesis. So clearly, ladies and gentlemen, in this case, we have tried to target something which is outside of the cancer cell. Example of extrinsic or the tumor microenvironment based target. So this is fairly straight, 2 + 2 = 4. Let's see, it doesn't work like that every time. Let me talk about trastuzumab. Old drug been in clinical use for quite some time, a long history of development. So you identify a particular gene which is overexpressed in a particular type of cancer, that is breast cancer. You make a humanized monoclonal antibody against it. You dock it onto that target, and you see that the cancer cell actually dies and there's a clinical relief. Here the problem is that 2 + 2 = not equal to 4. We still don't know how it works. I have given a reference of a very good paper. Those of you who are interested in how the science progresses, this will make a good reading. So there are theories about how trastuzumab would act. It is seen to be acting by causing dimerization and inactivation, phosphorylation in activation, endocytosis, and so on and so forth. But it works. So at the end of the day, trastuzumab works. How it works, we don't know. So idea is that you have a target which you see is getting overexpressed all the time. You make a monoclonal antibody against it, you block it, and you see that it gives rise to clinical benefit, and you start using it. And then, of course, we are trying to find out how it works. It doesn't matter, of course, as long as it works. Of course, it does matter. I'm sorry, I should not be saying this, but it works. So these are the 3 examples which I wanted to talk about. Now, there are certain newer examples also, like tropomyosin-related kinase inhibitors. So tropomyosin-related kinases are basically transmembrane proteins that are important and required for cell differentiation and growth. They are encoded by a well-identified gene, which if mutant can give rise to fusion proteins or fused proteins. And these fused proteins have uncontrolled activity. They can lead to cell differentiation and growth without any external stimulus. So again, you have a gene, you have a mutation which gives rise to abnormal protein, and you block that abnormal protein by small molecules, larotrectinib and entrectinib, and that affords clinical benefit to patients. A very newer thing. I think it got, if I'm not wrong, it got approved in 2017 or 18. Now, another curious example is now we are going from targets to epigenetics. So we have enhancers of just a homology 2. Enhancers of just a homology 2 are basically histone methyltransferases, which mediate gene repression. So there's a gene, it would manifest, but it would be repressed. The epigenetics of the gene expression will be handled by EZH2. So the hyperactivation of EZH2 increases proliferation of beta cells and favors lymphogenesis. So if you were somehow able to stop this EZH2, so here you're not doing anything to the gene, here you're not doing anything to the target, but you're just trying to stop the gene from getting expressed by epigenetic interventions. So tazemetostat is an inhibitor which is approved for use in certain type of lymphomas. Again, this I'll not go into the detail of it, but because just to it's more of a conceptual thing that you have a very not a small minority, but a subset of lung cancer patients who are ALK positive. Most of the non-smokers who end up getting lung cancer are ALK positive. And ALK is an anaplastic lymphoma kinase, again required for cellular growth and spread. It can be again blocked by lorlatinib and sedative, which are again small molecule blockers of this target. Another similar example, which is a new target which has been blocked now, is FMS-like tyrosine kinase 3. Now, FMS-like tyrosine kinase 3 or FLT3 is the most commonly mutated gene in AML, seen in almost 1/3 of patients of AML. So basically, mutated FLTs, they autodimerize and they drive cell growth in absence of any external stimulus. So again, you have agents against them which target specifically these kind of targets, and then they give they produce symptomatic, cure used in CML. Now there's a very interesting concept of synthetic lethality. So in synthetic lethality, it's basically a conjoint attack by two agents. In isolation, they'll not be able to work. So basically you have something known as PARP inhibitors. PARPs are required for repair of DNA damage. So a single onto your left-hand side is the normal cell response, whereas the single-stranded DNA will be repaired by PARP by something known as the base excision repair. And the cell survives. Now, if you inhibit this PARP, this single-stranded DNA goes on to develop as the double-stranded DNA break. It cannot any longer be, of course, you have blocked the PARP. So this single-stranded break develops into double-stranded break, and then it can be only repaired by homologous reconstitution, for which we require something known as BRCA1 and 2. So if BRCA1 and 2 is also mutated and deficient, and in that subset of patients you give PARP inhibitors, then they would ensure that the cancer cell gets lysed. So that's why PARP inhibitors are useful, are approved for ovarian breast cancer, which are BRCA positive. If you give these drugs in BRCA negative patients, wherein this HR dependent pathway is intact, then they will not have any effect. So there is a case where there is already some kind of a mutation which makes the cell vulnerable to something else, and you give that something else in the form of PARP. So this is a synthetic lethality concept, which a lot of work is going on this as we speak. Now coming on to immunotherapies. So immunotherapies, I've already briefly touched upon the importance of immune response. So why not exploit the immunity to block or to treat the cancer? So very interesting, I would say, class of drugs which have emerged in last 6-7 years is the immune checkpoint inhibitors. So basically, they boost anti-cancer immune response, which had been lulled by the cancer cells. So Basically, there are three targets: PD1, PDL1, and CTLA4. I have already given the list of all immunocheckpoint inhibitor drugs which are already in the market, and again a fantastic summary which got published in 2022. So I'm sort of trying to not go into too much of details about it so as to cover most of the points, but giving you the material all along. Now, another important or very curious therapy which is very personalized is adoptive cell therapy. So basically, you take T cells from the patient and infuse them into the same patient. It's again of three types. There is something known as the T cell therapy, in which there is no genetic modification of the T cell is required. You just take T cells from the individual, infuse it back into the same individual, and hope that they works better and the immune response is better. In other type of T cell therapies, you do some genetic engineering of the targets of the T cell, infuse it inside the patient again, and then hope that this targets on the T cell will elicit immune response against the cancer. So the given, I mean, this is little, I would say, for the students, little difficult to understand, but the reference which I've given, it's one of the simplest summaries which I found on this subject. I've taken the photographs also, picture also from there. So now, refining the old idea, this is a very curious example of two drugs, antibody drug conjugate. We know that a lot of drugs are targeted against folate metabolism to treat cancer cells. In fact, folate receptor alpha is overexpressed in a number of, in a lot of cancers. However, a humanized monoclonal antibody was not able to produce symptomatic relief, or was not able to produce clinical effect in trials, which was targeted against folate receptor alpha. However, when you use it as a antibody conjugate, targeting against the FR alpha and conjoin it along with something, a microtubule agent known as erbilin. So it becomes a typical antibody drug conjugate, wherein the FR alpha, folate receptor alpha antibody, is not doing anything to the cancer cell. It is just using, it's being used as a decoy to put erbilin inside the cell, which leads to cytotoxicity. So this is how the farletuzumab, which could not produce clinical benefit in phase 3 trials on its own, can it still be used in some other way as an anti-cancer drug? Now, another refinement of the old idea, we all know that antibody drug conjugates were a very famous, were a very frequently, or I would say widely studied arena about 10-15 years back. But because of the large size of the antibodies, a lot of them did not find success. Same thing has happened now. Now bicyclic peptides, which are much smaller than antibodies, are being used to sort of deliver a cytotoxic substance. In this case, MMAE, a tubulin inhibitor. So Nectin-4 is a target which is overexpressed in bladder, breast, lung, and pancreatic cancers. So you have a peptide which identifies this Nectin-4, docks onto it. It has MMAE along with it, and that goes inside and produces cytotoxicity. Now coming to emerging concepts. So one thing which has not been studied so far is the importance of protein-protein interactions. I'm sorry for this spell. The spelling of one of the proteins is wrong. Sorry for that. So basically, we have been talking about gene, the epigenetics, and the target, but we don't know how proteins interact with each other, and where can there be any target between these proteins. So OncoPPI is protein-protein interaction network. It's a kind of a network which studies about protein-protein interactions so as to find some other targets if possible. Then metabolic vulnerabilities. Cancer cells have special needs. I've talked about that. We also know how we exploit these needs by way of FDG PET so as to identify where the cancer cell is lying. Something similar happens. Cancer cells, some of the cancer cells also have more production of or more requirement of 2-hydroxyglutarate. A lot of work is going on blocking 2-hydroxyglutarate production so as to starve cancer cell. Similarly, also to stop serine synthesis, which is essential in development of certain cancers. A lot of cancer cells also have enhanced requirement of lipids. However, it is very difficult to target those because we have the understanding of cancer lipidome is limited as of now. But this is another area where a lot of work is going on so as to identify how do we starve the cancer cells with lipids. Another emerging concept is the concept of proteolysis targeting chimeric technologies. So you attach small molecules with some agents which destroy a particular target protein via the ubiquitin proteasome system. So instead of targeting the gene, instead of targeting the epigenetics, you just identify protein and try to kill it. And of course, then at the end, there's an emerging concept of cell states, which says that a body of cancer cells, I would say, will have mix of type of cancer cells. Some of them would be trying to metastasize faster. Some of them would be in a stable state, and the tumor microenvironment around the cancer cell will determine which stage the body of cancer cell lies. The most important of them is cancer-associated fibroblasts. So a lot of work again is going on. This is an emerging target, that how to change the cancer-associated fibroblast so as to stabilize a particular cancer cell in a particular state, stable state or unstable state. So these are certain things which on which again emerging concept on which work is going on. So ladies and gentlemen, this is the target tree. Again, a fantastic review. Kindly read this. So it's the last slide. So you have targets which are intrinsic. We have talked about oncogenes. We have talked about tumor suppression. Epigenetics we have talked about. Synthetic lethalities we have talked about. DNA damage we had also talked about. Onco-PPI network, it has yet to throw up something of translation value, but this is very promising. And again, metabolism, some of it has been exploited, some of it remains to be exploited. Onto the right hand side, tumor micro environment targets, immune checkpoints we have talked about, adaptive immunity and innate immunity. So basically T cell adaptive immunity is something which is already in the works, already approved, highly personalized. And of course, cancer-associated fibroblasts I've talked about. Angiogenesis, a lot of work has already happened. It's bevacizumab is an old drug, but a lot of work is still going on. Thanks. I think that was all I could, sort of clubbed into a 15-20 minute time slot. I hope I have not overshot my presentation. Thanks a lot, ladies and gentlemen.
Thank you, Dr. Praful. I think it was a very detailed and methodical presentation. We can have one or two comments or questions. Yes.
Ma'am, I'll just take a moment. I think there is something wrong with the audio. Just a minute.
Can you hear now?
Yes, ma'am. Yes, ma'am. I'll just, I think I can. Yeah.
Professor Ubujit Hajra will.
Actually,
yeah.
Ma'am, just a minute. Ma'am, I'll just take a moment. I'm not really able to understand what's wrong with it because. Yeah, ma'am, I should be fine now. Yeah, please.
Okay, Dr. Mohan, first of all, thank you for giving us a rapid overview of this emerging field of targeted cancer chemotherapy. So as you rightly said that the future of cancer chemotherapy lies in targeted therapy. There is no point in bombing ourselves with traditional cytotoxic drugs. But when it comes to reading and studying, it's all very difficult. We leave aside undergraduate students, even for postgraduates, the field is very difficult to grasp. So with the review we have done recently, may I ask you that if you were to narrow down, keeping the next 3 to 5 years plan in view, what are the most promising targeted therapy areas of the many you have mentioned and the many more which are emerging every day? If you were to narrow down to, let's say, 4 or 5, which are the most promising areas?
Yes. So thanks for your question, sir. I think I should have covered it myself, but anyways. So, sir, to my limited wisdom, I can say that immune checkpoint inhibitors would have been a great, area of promise. However, so far they've not been able to show that kind of clinical efficacy and at that cost. So I think that something like we have to probably, attack it from the two sides, choose a target which is in the microenvironment and choose a target which is inside the cell, intrinsic to the cell. So I would say something like an immune checkpoint inhibitor coupled with something which starves the cancer cell. Maybe, as we understand cancer lipidome better, maybe something which stops production of a critical lipid. And something which makes the cancer cell more vulnerable. So if I may answer your question very honestly, again, limited wisdom, sir, any single agent won't be able to do that, because willy-nilly the cancer cell, by virtue of its development, will find a way out. So it's going to be kind of a two-pronged attack over it. So I think that's the best way I can answer that, sir. And in between these two things, if you want really me to sort of identify, then probably immune checkpoint inhibitor on one side and a trihydroxyglutarate inhibitor on the other side, or something like that. But our problem is that the physiology of the cancer cell, the energy needs of the cancer cell beyond its requirement of glucose are not very well known as of now. So I think this is what I have to say, sir. And I would like to hear some voice from the learned audience and stand, more wiser on this.
Okay, thank you, sir.
Thank you. If I may put some comments, we began with cancer chemotherapy killing the cells. Then we thought we have found some targets like imatinib, which will be more specific. And then we found that this tyrosine kinase inhibitors started growing resistance. So to block the resistant pattern, we went downstream signaling. So we picked up PI3 kinase in the resistant pattern to block PI3 kinase. And then we learned that no, there is something else we can do. We can have anti-angiogenesis.
Yes.
But we found that anti-angiogenesis alone will never work. It has to be combined with the chemotherapy. Then we learned, okay, why not combine chemotherapy with the tyrosine kinase inhibitors? Initial trials were negative, but then some positive trials in lung cancer have started coming. Then we have something unique, that is immunotherapy. Body's own immune mechanism will take care of the cancer cells. By what we promote the immune system, and that is what is immunotherapy. And recently, there are umpteen of trials which are combining immunotherapy with chemotherapy to get the maximum benefit. So actually, no one target will ultimately fulfill. To get more and more better results, you are combining chemotherapy with immunotherapy, even with anti-angiogenic therapy, triple therapy we call it. Yes, for these, what has happened is the goalposts of adverse events have changed. What was vomiting, nausea, diminished cell count has shifted to metabolic derangements with hypothyroidism. Target therapy have also caused diabetes, and immunotherapy has given rise to a host of autoimmune diseases. So the goalposts of adverse events have changed. And recently, if you look at the immunotherapy trials, what is unique is we also get to learn that there is some pseudo progression. Suppose there is a lung cancer, you've seen the cancer size, and next when you give the immunotherapy, the patient is okay, he feels better, but your lesion in the lung shows some slight progression. So do not react to that. Yes. The patient is clinically stable, you continue with your treatment, because this is nothing but pseudo progression. So days are going by and cancer treatment is becoming really interesting, at the same time more complicated, more costly, and more combinations are coming to stay. Thank you.
So ultimately, it's a naughty child, ma'am. We need to find ways and means to control, and it will try to evade our control.
Once we control this, something else is
Something
clever.
else will come. So it will keep on having naughty ideas.
Clever, it's clever.
Prof, I had a couple of questions too. If you haven't looked into those areas, then feel free to say that you're not aware of it. I wanted to ask you about PRMT5 inhibitors. I have a specific question. So PRMT5 inhibitors are a new class of anti-cancer drugs that are being developed. I think there are 5 or 6 candidates in development right now. Now PRMT5 works within the spliceosome, and they are protein arginine methyltransferase is the name of the enzyme, and what it does is it methylates arginine in the histones. Now, this enzyme is there in all cells, of course, and so when you inhibit this enzyme, you would expect all cells to be affected. But I hear that PRMT5 inhibition, cancer cells are more susceptible to it than other cells. And I've not really understood that. So if you can clarify, if you have that knowledge and if you have read up about that.
So frankly speaking, I've not delved into this much, but this pretty much happens with the, whenever we are trying to tackle a particular metabolic need of the cancer cell. So it's not that this need of the cell is unique to it. It's just that the need is more than the other cells. So when we say that the cancer cell uses glucose and more, it just uses more glucose, you know. So I really don't know how, how to answer the question. So probably your question is that why certain cancers are.
You are no longer audible.
Hello. Hello. So,
You're audible.
You're muted, Prabha. Yeah. No, you're muted again.
Sir, you have to unmute. Yeah.
Yeah, am I unmuted now?
Yeah, now audible.
Yeah. So, sir, as I understand your question correctly, it was about that why certain cells are, certain cancers, why they are still not responding to it. Is that so, sir?
No. My question was
why the lysosomes, which are present everywhere, why specifically they attack the cancer cells?
the spliceosome. So
Yes.
splicing of the DNA.
Why
uptake.
that occurs only in cancer cells, not in other cells? If you know the answer, I don't know.
Sir, frankly speaking, ma'am, I have also not delved into this, but I may attempt, maybe because of the rapid rate of multiplication of the genetic material, probably.
Yeah, no problem. The other question I had was more to do with actually the clinical trials for development of anti-cancer drugs. So phase 1 for the development of anti-cancer drugs is, as we all know, generally carried out in patients, unlike phase 1 for other chemical molecules. Now, when you do that, and cancer is something that is often treated with multiple medications, multiple drugs. And phase 1, the objective is to be able to say what the toxicity profile and the tolerance profile of this new medicine that you're developing is likely to be. So if you are going to add that on to existing therapy, then the amount of information that you're going to get is going to be pretty muddled, because you have several drugs being given to the patients. On the other hand, whether it is okay then to use, and how what do people do in phase 1? Do they use single agents, particularly for the newer type of agents that are coming up now, the targeted therapies? Are they using single agents in phase 1, or are they using it on top of the standard therapy? That's my specific question.
So basically, sir, when you join two drugs, one of them would have some kind of established action. So you have some drug which has in most of the combinations which are being used, a drug will have some kind of at least one drug will have some established action with known profile, and then you add something more to it, because either by then the cancer cell has developed resistance to it, or it was, safety wise, it was untenable. So at least one agent will have sufficient understanding about it. So it's not, I would say, a blank blackboard on which we are trying to create a painting with two pens simultaneously.
Actually, if you look into the cancer trials phase 1,
so I think this Dr. Pooja is covering the endpoints.
Most of the drugs in phase 1 have been in advanced cancer, where the patients have already exhausted most of the lines of treatment. So that is how a new drug develops in cancer.
Right. So would you think
we don't try it in adjuvant, we try it in metastatic or advanced setting.
Yes, yes.
Just one point to those questions. If you look at the recent phase 1 trials in cancer which are being published, they're doing it with single agents because it is not a therapeutic intent. It is to define the basic pharmacokinetics of the drug, but they have to do it in patients for obvious reasons. But they're doing it with single agent because there's no therapeutic intent behind that.
Right. So would it generally be considered by ethics committees in India, for example, to be quite okay?
Yeah.
Ethically, that would be your own ethics committees.
Yeah.
You would consider that
We don't consider too many phase 1 trials. Only a few we have considered, but that's done mostly as a single agent. Yeah.
Something.
So ethics committees would consider that quite.
Very few patients, and those who have exhausted everything in the advanced setting, they usually get a new drug phase 1.
Okay.
In
Actually,
cancer, that is a dictum. You don't do in a operated patient. You do it in an advanced or metastatic setting where you have done all the standard treatment already. And then a single agent, as he said.
Right. Okay. Great. Thanks.
Okay, let
Thanks
us
a lot
thank
for
you.
that.
We had a very fruitful discussion. I think give a big hand to Dr. Praful for inciting talk. The next one is equally important, I think. The endpoints in cancer trial, and Dr. Pooja. Dr. Pooja is here. Dr. Pooja.
Yes, ma'am, I'm here.
Okay, ma'am, please take up.
Can we stop sharing the screen so that I can share mine?
Yes, ma'am. Just a minute. Just a minute, ma'am. Just trying to do this. Just give me a moment. I'm just trying to do that. Just a minute. I'm so sorry. Okay, what I'll do is I'll exit for a moment and then join back. I guess that'll be probably better.
Yeah, I think.
Yeah, I'll do that. That's easy.
Clarnet, can you help us? Hello, Clarnet.
Yeah, stop share. Ho gaya, ma'am. Done. Thanks.
Thanks.
A very good afternoon, very good evening all. I'm going to talk about endpoints in cancer clinical trials. Endpoints in itself, when we talk about diabetes or stroke or epilepsy, they are very well defined, and you don't need to kind of apply too much of your mind into what endpoint to be selected. But the game changes when it comes to cancer. Here, there are several types of endpoints that can be selected, and it depends on what is the drug that is being considered and what is the cancer that is being studied. So, well, that's just how an endpoint should be. What are the characteristics that should be there in an endpoint? That's a very generic this thing, that it's an overall outcome that a clinical trial is aiming to measure to determine the safety and efficacy of an intervention. It should be clinically relevant. It should reflect the change in the disease process which is being treated. It should be reliable. It should be responsive, and it should be practical. In terms of cancer clinical trials, the endpoints are usually divided into a patient-centric endpoint, which reflects ultimate clinical benefit to the patient, or it could be tumor-centric endpoint, which is not, which is a kind of a surrogate marker for the clinical benefit. Then there are biomarkers and safety-related endpoints as well. In terms of patient-centric endpoints, overall survival is considered the gold standard for oncology clinical trials. It is overall survival is measured from the time of randomization till the death from any cause. That gives us the actual clinical benefit that the drug is going to give in a particular cancer. It's precise to measure, patient is alive or dead, so that's very easy. Death is a very, very specific event that there cannot be any biases in its measurement. However, on the flip side, it is very, very time consuming, especially for cancers which have prolonged longevity based on the treatments available. Second endpoint in terms of clinical benefit is quality of life, which is now emerging as one of the primary endpoints, especially when the existing armamentarium of anti-cancer drugs has improved the lifespan significantly. Now the drugs are focusing, now we are focusing on changing the drugs to improve the quality of life. So overall survival has already been improved. Disease-free, progression-free survival has already been improved. Now we are focusing on quality of life. So there, in such situations, it is emerging as a primary endpoint. It shortens the duration of these studies as well. However, it comes with a lot of methodological and statistical challenges, how to interpret the data, what are the cutoffs to be taken. There is a lot of subjectivity involved. And there is a particular concern about missing data when it comes to studying quality of life using several scales that are available these days. And then identifying a particular scale. So there are n number of scales which are generic in nature, irrespective of the cancer. Then we have cancer specific scales as well. Within the cancer specific scale, there would be a range of scales which would have the number of questions could range from 10 to maybe 100, and there would be several subdomains. So it would depend on what exactly is the intent, how the drug is, what kind of effects we are expecting from the drug. So based on that, the quality of life scale should be selected. Then coming to the endpoints based on tumor assessment, these are time dependent endpoints. They are based on the indirect measurements on about, let's say, tumor size. So a CT scan or a MRI may be done to see how the tumor size is changing over time. These are used more or less as surrogate markers for the or surrogate endpoints for the clinical trials. Now, when I was talking about overall survival would need to be studied against a comparator. Now, natural progression of disease cannot be a comparator, so a standard of care would be taken as a comparator. But when we talk about tumor-based assessments, they can be done from the baseline also. So what was the tumor size at the baseline and after the treatment? So that can be compared with the available data on natural course of the cancer. In this, we have objective response rate, wherein the proportion of patients with tumor size reduction is noted. The amount of reduction and the minimum time period on which the reduction is sustained is predefined in the protocol, and then the objective response rate is calculated. Now, in this, target and non-target lesions are taken based on the study protocol, how it is being defined. A set number of lesions in an organ may be taken as target, and other metastatic activities may be taken as non-target lesions. So measurements are usually by imaging techniques. So as sophisticated the imaging techniques or the progress or the advances in the imaging techniques are, more objective the response assessment becomes. Now, initially there used to be a lot of variation in how the measurement was done, or how, depending upon the availability of the imaging techniques. Then European Union came with a standardized criteria, which is response evaluation criteria in solid tumors specifically, by which the response could be standardized between different studies and between different individuals and different investigators. Then we also have progression-free survival. Progression-free survival is time from randomization until the objective response is achieved or the patient dies. So it could be progression, it could be death, or it could be an objective response which was defined as has been achieved. So that's progression-free survival. It tends to correlate with the overall survival, especially where the longevity of after the disease progression is not too long, like pancreatic cancer. But where even after disease progression, there are several treatment modalities available which can extend the lifespan even after disease progression. There, the progression-free survival may or may not correlate with the overall survival. Time to progression is it is something like a progression-free survival, but it does not include death. Then we have disease-free survival, wherein time from randomization until recurrence or tumor or death from any cause is taken as disease-free survival. It is usually used in wherein adjuvant, it is most frequently studied in adjuvant settings, wherein definitive surgery or radiotherapy has been done, and now cancer chemotherapy is being studied. So here, in such situations, survival also becomes one of the endpoints. This is just a small example, like wherein trastuzumab was shown to have wide benefit in terms of disease-free survival, but in terms of overall survival, the benefit reduced a little compared to the standard of care. Then there are several other endpoints like time to distant metastasis, time to first subsequent therapy, time to next therapy, and so on, which are being explored, but all of these are more likely to be secondary endpoints rather than the primary endpoint. Then we also have endpoints involving symptom assessment. These are not very frequently used, or these are not very frequently preferred, but based on the time to progression of a cancer symptom, it could be used as a clinical measure of a clinical benefit. However, the assessment is biased, and that's why it is not very frequently used, or it is not preferred overall. This is just how, so from progression-free survival, which measures, at every visit, the assessment is done and to see whether the disease is progressing or not. Criteria for progression is well established in the protocol itself. From there to overall survival, several intermediate clinical endpoints have been defined, which are being explored for different types of cancers, depending upon the disease pathophysiology. This is just a summary of what I've been talking about so far. Overall survival is looking at death. Progression-free survival is looking at the evidence of disease progression or death. Time to progression looks only at the disease progression, not death. Then event-free survival could be, it's how the event is defined. It could be discontinuation of the treatment or disease progression or death. Disease-free survival is, as I've said, till recurrence of disease or death. Then time to treatment failure and time to next treatment, or time to first subsequent treatment, second subsequent treatment, and so on. So this list goes on increasing and complicates how in the selection process of the endpoint for a particular clinical trial. But then ultimately overall survival and progression-free survival are the most frequently used endpoints for the clinical trials. Then biomarkers are also used not as the primary endpoints, but more as an exploratory endpoint. Specifically in the phase 1 and 2 clinical trials, biomarkers are utilized to as a proof of concept, to provide the proof of concept that the drug is actually interacting with the target, is producing some effect. What is the dose response relationship with respect to the biomarker or the drug target interaction, if there are any associated adverse effects. So in these situations, biomarkers are used. So they are particularly useful for initial evaluation in phase 1 and phase 2 clinical trials, but when it comes to phase 3 clinical trials, they are mostly used as exploratory biomarkers to assess or to identify the disease population wherein the drug could be particularly useful, or to whether the biomarker could be used as a prognostic marker for efficacy of the drug or not. It can also, based on these parameters, it can help in the accelerated drug development as well. Then lastly, we have safety endpoints. Safety endpoints are mandatory for all clinical trials. They are usually, so when we talk about cancer chemotherapy, the NCI has given CTC criteria, common terminology criteria, wherein the adverse effects have been defined and their severity grading has been done. So it is, when it comes to cancer, severity grading becomes really important for, traditionally, most chemotherapy have been associated with one or the other adverse effects. So that's kind of, some of it would be acceptable, some would not be acceptable. So that's why the severity grading becomes important for safety assessment in clinical trials for cancer. That's about the talk. And FDA has, US FDA has given a guidance document for selecting the clinical trial endpoints for cancer drugs and biologics. And that's about it. Thank you.
Thank you, Dr. Pooja. Are there any important discussion points or questions? Hello.
Thank you, Pooja Madam, for giving us an overview of the various endpoints in cancer clinical trials. So just one question I had. We have seen a few published studies where they have used well-established biomarkers like alpha-fetoprotein or PSA or CA19-9. And the rise in the levels of the biomarkers have triggered intervention in the form of second-line treatment or salvage therapy without objective evidence of tumor progression. So do you think this is ethical, even if done in the context of clinical research?
Sir, as far as, so there are two aspects to it. When we are talking about new drug regulatory approvals, there it is not acceptable. But when we are talking about subsequent, once the drug is approved, we are trying to optimize the use, or academic clinical trials are being conducted therein. The biomarkers that you've mentioned, they have been studied extensively, and their change in levels have been correlated with disease progression. So in that sense, as surrogate markers, to my mind, they would be acceptable. In fact, I'm doing one of these studies wherein I'm using PSA as a biomarker for prostate cancer.
If I may summarize what she said, this is very important aspect of clinical trials in oncology, endpoints. See, we began with all registration trials, they demand overall survival benefit. But as more and more lines of cancer treatment have started appearing, PFS became, progression-free survival became a surrogate, because once you stop one line, the patient progresses, you have another line, and that improves the overall survival. Third line, fourth line. So that's why overall survival, without even impact on overall survival, PFS is becoming an endpoint in many registration trials, number one. And what Madam showed also, PFS2, PFS1 means the first progression-free survival. Then PFS2, the second progression-free survival. This is also in the endpoint nowadays. Number three, as Sir pointed out, that there are many biomarkers which are also certain endpoints in various trials, but definitely only biomarker is not in a registration trial. It is an additional, subset analysis or an academic exercise, particularly PSA, as you said, sir. There are many trials which have shown that a particular drug has caused decrease in PSA, but not any impact on the radiology or RECIST criteria, which Madam showed. But I would like to point out one thing which she didn't say. is with the advent of immunotherapy, resist is becoming very dubious, and also targeted therapy, because as I mentioned, there is pseudo progression, not actual progression. So there is a new concept known as I resist, immune resist. So endpoints are always changing, and quality of life, I would request this August gathering that we are always borrowing quality of life data and the schedule from Western literature. Why doesn't this association develop a quality of life parameter list pertaining to our Indian patient, which is doable? We find it very difficult to do those quality of life. So I think, yes, endpoint will always remain a point of discussion, very much important, because remember, imatinib, we had the fusion gene BCR-ABL, 100% in CML patient, and that had objective response of 0%, known as major molecular remission in those patients who had impact of the drug on CML. And another thing which was very important, which is why disease-free survival or progression-free survival has become important, is carryover effect. Suppose I do use a targeted therapy for even 1 year and the patient goes off, doesn't come. The patient continues to have the clinical benefit. So that's why only overall survival is no longer the endpoint. Progression-free survival, disease-free survival have been into the armamentarium of endpoints because of carryover effect of different types of treatment. I think it's very late. We can have a lot of discussion. It's very interesting topic, but I have to end the symposium and the session. Thank you, the organizers, for giving me this opportunity, and thanks to Madam for raising many questions.
Thank you, ma'am. Thank you, the organizers.
Thank you, Madam. Thank you, Praful Mohan sir. Thank you, Pooja Gupta, Madam. So now may I request Professor Nihar Vishwas sir to kindly felicitate. Also, may I request our Dr. Shoibal Mukherjee sir also please join us to felicitate Madhuchanda Kaur.
I went back to Ujjain. I have joined there.
Thank you, Madam. Thank you. So now we are moving forward towards our next session, and we are really privileged to have with us now Professor Abhijit Hajra sir, again, who needs no introduction in the field of Indian medical education system. Sir is a doyen figure in the field of pharmacology. Welcome you, sir. So please start the session.
Okay. Curtains are coming down on the second day of the conference and Sunday evening. So we have only a handful of audience, but knowledgeable audience. So may I request first the speaker, Dr. Melvin George, to step forward, Melvin. So I'll just take a couple of minutes to introduce him as he handles his slides. So Dr. Melvin George, he did his MBBS, MD, as well as DM in clinical pharmacology from JIPMER, Pondicherry. After completing his DM in 2012, he joined the SRM Medical College and Hospital and Research Center in Chennai, and he has risen through the ranks and is now a professor there in the Department of Clinical Pharmacology. Simultaneously, he has been active in setting up a clinical trials unit in the Hindu Mission Hospital in Chennai, and from 2016, he is running this unit And as part of his clinical research activity, his areas of interest are acute coronary syndrome, biomarkers in acute coronary syndrome, heart failure, and COPD. So he has done and is doing sponsored trials in these areas and also ICMR funded research projects. And is also involved in registry projects related to heart failure and COPD. During the pandemic period, he has been involved in different phases, phase 1, phase 2, phase 3 of the clinical development phase of Covaxin, which is our indigenous COVID vaccine, which has played a very significant role. So for his academic output, he has over nearly 100 papers in peer-reviewed journals, 8 book chapters, and over 1,100 citations. He's a well-known figure across India. He has gone across the country, participating in various national and regional symposia. And at his own centers, he is involved in biostatistics, research methodology, and clinical ethics. He has regularly organized workshops and conferences. I was fortunate to attend one of them in the pre-pandemic period. So with this introduction, I'll request Melvin to start his presentation on medical device and the regulations in India. Over to you, Melvin.
Thank you, Dr. Avjit, sir, for your kind words of introduction. Usually when we watch a cricket match, especially if it is a 50-over match, by the time we come to the 47th or 45th over, we'll be seeing mostly the tail-enders batting. And then we know that nothing much is going to happen. But still we hope that at least some miss-hits will go to the boundary for a 6 or a 4. So hopefully I'll try to do something like that for the next half an hour. Is it moving? Okay, fine. So on the screen, you see something. What is that? Can anyone tell? What is this? It's written out there. Yeah, it's written. It's an MRI scan. But what is special about this MRI scan is this is a unique MRI scan that was developed indigenously from India, and this came out in the news just a few weeks back. It was having a technology that was different from the conventional technology that relies a lot on liquid helium, which is a scarce resource currently, especially because of the Russia-Ukraine war. And that is something, a big step for the medical device industry to have such a sophisticated device being developed in India indigenously. So if you look at the Indian medical device market, it is said to be around $11 billion, $11 billion US dollars. That is around 90,000 crore. It contributes almost 75% of its total market size is mainly from imports. So that is, it is highly import dependent market. There are approximately 1,000 manufacturing sites in our country for medical devices, 200 sites for in vitro diagnostic kits. And this is one industry that allows 100% foreign direct investment. Not every industry in India is this way. And to a large extent, price control is not as much as you see in other industries, except in the case of cardiac stents and knee implants. Of course, this is changing. So there was a report that was published by Deloitte in 2016, which was trying to evaluate the whole medical device market. And they made some very strong conclusions about how the Indian medical device industry is, at that point in 2016. It had a very unfavorable duty structure, heavy tax, low domestic demand for many of the products, absence of a clear-cut law, because most of drugs were, most of devices were not regulated, and there was no proper quality certification policy, and even the entire ecosystem for developing medical device was highly inadequate, and there is no structured model to develop medical devices in India. And most importantly, the ease of doing business was extremely poor. At that point of time, it was almost around 140, the rank ease of doing business in India. And the labor laws, of course, were restrictive, and the higher cost of financing to develop medical device indigenous manufacturing facility. So, but at the same time, this graph shows that for a lot of devices, India was slowly becoming independent and able to manage by itself. At least devices like suturing materials, bandages, dressings, consumables, syringes, needles, catheters, those kind of simpler devices, we were less reliant on outside imports. But when it comes to the more sophisticated devices which relied on higher technology, we most likely needed imports for the same. And if you look at the manufacturing landscape also, it is not uniformly distributed. You will find a lot of manufacturing capabilities in the state of Tamil Nadu, Maharashtra, Andhra Pradesh, and a few places in and around the rest of the country. So what this report ultimately came to say was there is a lot of scope for improving the healthcare system in India if India is able to contribute directly to medical device manufacturing, where we develop our own medical devices, so that substantially brings down the healthcare costs that a patient is having to afford. Because we all know that currently in India, almost 20, it's only around 25% of the population who have an insurance. Rest 75% of the population is depending on out-of-pocket expenditure for their hospital bills. And medical devices contribute almost 30%, 30 to 40% of the whole financial burden that a hospital has to take to develop a hospital in the first place. So we can bring down the cost of healthcare substantially if we have a strong medical device capabilities within our country. And we often see news items like this, where fake medical equipment racket being busted, okay, in different places. So the point I'm trying to say is that there is a strong need for a appropriate regulatory mechanism in the country, which was lacking for a long time. Drugs and Cosmetic Act 1940 and Drugs and Cosmetic Rules 1945 were the guiding light for medical devices also. So they were medical devices were considered under drugs itself and regulated likewise. And then we had the medical device rules coming up in 2017 and the medical device amendment rules coming in 2020, and most recently the National Medical Device Policy in 2023. So until 2018 January, medical devices were hardly regulated, you could say. As I told you, under Drugs and Cosmetic Act 1940, the definition of devices, that is those devices intended for internal or external use in diagnosis, treatment, mitigation of prevention of disease, which are specified by the DCGI office from time to time, will be considered for regulation. And the story started in 1989 with 3 devices being considered as notified devices, which are considered as drugs, which will be regulated by the office of the DCGI. Subsequently, this list expanded in 2005 to 10, and in 2017, it expanded to 37. It was only in 2018, when we had this medical device rules, 2018, that things started, the regulatory standing for medical devices fell in place. And in 2020, there was a landmark event which happened, and that is the medical device amendment rules. So this stated that henceforth all medical devices will be regulated in the country, and it also gave a deadline for this devices to be regulated. I will come to that. So Medical Device Rules 2017 what does it contain? It talks about the regulation of medical devices in terms of its classification and principles of manufacturing, product standards. It talks about what are the various authorities that are constituting this, who govern this whole structure of the medical device regulatory system. It talks about manufacturing for sale and distribution, import and of medical devices, what should be there in the labeling of the medical devices, how do trials with medical devices happen, how it should happen, import and manufacturing of medical devices which do not have a predicate use, that is, they do not have a particular model in India, in the country. It's a unique model, it's a unique device. Then how does the system work for it? And then it talks about the responsibilities of a medical device officer, registration of a laboratory for test or evaluation, sale of medical device, and export of device and exemption. So there are 12 chapters and there are 8 schedules, which again talk about important aspects of the classification of medical device and in vitro diagnostic kits, the fee structure, and it talks about also notified bodies. I'll come to that in a minute. It talks about the different documents required for grant of manufacturing and import of license, the quality management systems to be in place, and the post-approval requirements and requirements to conduct trials and the exemptions. So the first thing we need to know is risk classification of medical devices. So medical devices are now classified into 4 categories: low risk, low moderate risk, moderate high risk, and high risk, class A, B, C, and D. So the class A is the least risk kind of device, something like catheters, disposable perfusion sets, surgical dressing material, whereas a high risk device, class D, would be cardiac stents, septostomy catheters, high density array catheters. So the more invasive the device is being used, there is more chance that the risk is high, and so it is categorized as high risk. So the regulations are different based on the category that the device belongs to. So if you look at this table, the data requirement and timeline to obtain license, I'm not going into the details, but one important thing I would tell you is that the clinical trial requirement is there only for class C and class D devices. So for class A and class B devices, clinical trials are not required. That's the most important thing I want to tell you here. And we have the central licensing authority, which is largely involved in regulation of class C, class D devices, which are definitely having a higher risk. Whereas for class A and class B devices, it's largely the state licensing authority that is involved in regulating these devices. In addition to that, we have a national accreditation body, which is approved by the CDSC office, and this body in turn will regulate the notified bodies and inspect the notified bodies. Notified bodies are in turn agencies, private agencies, which would do the inspection of facilities which are performing manufacturing of medical devices, both class A, class B initially, and then subsequently, based on their experience that they get, they would also be allowed to inspect class C and class D facilities. So the notified bodies are the ones which are directly involved in the audit and the inspection of medical device manufacturing facilities, and they would be accredited by the national accrediting body, which is again under CDSCO. So the standards for medical devices in India are laid down by the Bureau of Indian Standards or any other as notified by the central government from time to time. If there are no standards for a particular medical device, if ISO standards are available, that would be used. If nothing is available, if there are no standards, it's absolutely novel device, then the device would have to follow the validated manufacturer's own standards. And even for, just as how we have drugs, even for devices, if a manufacturer of a medical device has found that there is one of his devices unsafe, he has a duty to have a recall procedure in place so that immediately the safety risk is reduced. We have something called as ISO 13485 quality management system. which is a universally accepted standard published by ISO. So this is available exclusively for medical devices, and it is increasingly encouraged that medical device companies use this ISO standards for developing their device. So I was talking about Medical Device Amendment Rules 2020 earlier. This is a very landmark event which happened just before the pandemic began, where it stated that henceforth all devices, no matter what kind of device we are dealing with, if it is a device that is used for diagnosis, prevention, monitoring, treatment, alleviation of any disease or disorder, or for any injury or disability, or investigation, replacement, or modification or support of anatomy or physiological process, or for supporting or sustaining life, or disinfection of medical devices, or control of consumption. If a device falls under any of these categories, it would henceforth be regulated by the CDSCO and would require registration. So the medical device market, which was highly unregulated environment all these years, now had to fall in place. So this was something that was welcomed by most of the major medical device players, and they had given a deadline as to by when this should happen. So it is expected that the Class A, Class B devices should have got their licensing by August 2022, whereas for Class C and D, it was supposed to be August 2023, and now that is pushed to October 2023. And even the supply chain also requires the same kind of licensing registration. So when you talk about medical devices, when in terms of its development, how does medical device development take place? It would start with preclinical activities to determine whether the device is safe and effective. So we have something called as bench testing, technical testing. Sometimes computer simulations may be used if it works. I mean, if it is available for that particular device, and animal studies also. So this would be done prior to the clinical trial. So what is bench testing? So bench testing is basically where the device in a laboratory or a workshop testing, we assess the device for its performance and safety. That is not with the patient, but just the device per se. Okay, whether it is able to do what it is expected to do. The technical testing also needs to be done. That is the engineering quality, the material that is used, the mechanical elements, the accuracy, reliability of the instrument. All these needs to be checked during the technical testing. For some devices, there would be possibility of using computer simulations. Then those could also be done so that we could predict how successful the device is even before we start testing it in humans. And then we have the animal studies. Again, efficacy testing in animals may not be always possible, but if it is possible, that should be attempted before we start doing it in human beings. And then we have the clinical trial, which is done in drugs, we have phase 1, phase 2, phase 3 trials. So for devices, we don't call it as phase 1, phase 2, phase 3. We call it as pilot studies and pivotal studies and post-marketing studies. So the form to do a clinical trial is called Form MD 2022, MD 22. So you submit this application to the office of the DCJ. So I'm not going into those details. So how is the first study done? The first human study, which is called a pilot or a feasibility study. This is a study that is done in humans to understand essential information about the device before moving to the large scale pivotal trials. So the pivotal trials can be considered like phase 3 trials, whereas the pilot study is the early phase 1, phase 2 trials. So usually 10 to 30 participants. It's highly exploratory in nature, mainly to understand the safety of the device, how the device performs in humans in terms of its effectiveness in measurement, prevention, treatment, whatever we are looking at. And through this study, we are expecting that we can modify the device and change the design of the device for future purposes before it goes to the pivotal phase of the trial. And this particular trial is also expected to teach us what is the ideal eligibility criteria to be used when designing the phase 3 trial. So this is the purpose of doing this pilot feasibility trial. all the other rules that come for drug trials hold true even for device trial, meaning if there is there should be a ethics committee approval, there should be a CTRI registration. So all those principles apply even for these clinical trials. When it comes to if there is a serious adverse event, the serious adverse event management happens the same way as how it happens for regulatory drug trials. So compensation, all those details, SAE reporting, everything, the same rules apply. So pivotal study is a confirmatory study, something akin to the phase 3 trial, done in a large number of patients to gather evidence for safety as well as efficacy. For medical devices which doesn't have a predicate medical device but approved outside India, pivotal studies need to be carried out. And prior to conducting a pivotal clinical investigation in Indian subjects, CDSO may sometimes expect a pilot study generated within the Indian population to assess whether the pilot study data are similar to what is there from the Western literature. And then we have post-marketing clinical investigation that is expected to be done after the device is approved to monitor the long-term effectiveness and safety and usage of the device in the general population. And it's also required by CDSO. So same PSUR system is also expected for medical devices. The government of India has also launched several schemes to improve India's ability to manufacture medical devices. There is something called as a production-linked incentive, PLI scheme, which is basically an incentive given to companies if they manufacture their medical device within Indian soil, they would be provided incentives if for the same. So based on this, there are several companies which have even global companies which have come forward and successfully got this PLI scheme and manufactured medical device, and they have marketed it. And there is another scheme which is called as the medical device parks. So this was a concept again that was basically the states, the different state governments, they were expected to come forward and provide land space to establish medical device parks, which are large facilities that can be used as a common facility for medical device, smaller medical device companies to come and test their products. So that is a medical device park. So this was an application that was brought up by the government of India, and several states have applied, and finally certain states have been shortlisted in the first round, and the medical device parks are right now on its way. It's not fully established in Madhya Pradesh, Tamil Nadu, Himachal Pradesh, Uttar Pradesh. We are finding that these parks are coming up. Now coming to the National Medical Device Policy 2023. So this was again another landmark event. In fact, this is considered a bigger landmark event than anything else that happened before in medical device industry. Into 2023, in the month of May, the Prime Minister of India has approved this, the cabinet has approved this Medical Device Policy 2023. This is a highly forward-looking document. It basically is a visionary document that is built in providing an innovative and globally competitive industry, medical device industry in India, to achieve, so that India achieves 10 to 12% share in the global market within the next 25 years. Currently, it's less than 5%. So under this policy, some of the important missions under this policy include access and universality, affordability of devices, quality of medical devices, patient-centered and quality care, preventive and promotion of health, skilled manpower, security, and research and innovation. So essentially, the policy has attempted to ensure that every Indian has access to good quality medical devices, which is not the case in India. Currently, if you see, we all know that those who are living in the tier 3 cities might not even have access to an MRI or a CT scan device. As a result of that, the quality of their medical device, the quality of the medical care will obviously come down. So universal access to devices is not there in India. It's a well-known fact, and that is what this policy is stating that we should try to achieve by having low-cost medical devices indigenously manufactured within our country, making healthcare affordable by essentially having medical devices available at, again, lower cost. At the same time, not compromising on the quality of these medical devices just because we are having a low-cost device. And ultimately, through all these advancements, we are supposed to see that patient outcomes really improve. So it's not